So this is going to be live streamed on YouTube, y'all, and LinkedIn if I can get it on there too. All right. Dr. Pugh, Dr. Williams, is Dr. Pugh in the
Let's see. No, I don't see. I'm gonna send her a quick text. We talked last night.
I'm waiting for the LinkedIn up to load up now. So it's on LinkedIn and it's on YouTube. I'm gonna see if I can get it on Facebook. It might not do it, but see.
We're up to 7 so far, and the attendees 8 to the attendees list.
Okay.
See names.
So Mario, I'm gonna make you a co-host too, so that if anything happens with Zach Speed, it won't knock anybody off. Okay.
Yeah.
That's fine.
I'm gonna make all the I'm gonna
Lachelle,
make
she's
all the
already joined. Yeah.
Okay. Did you see her in the feed?
Panelists. Oh yeah, I see it now. Promote panelists. Got it. All right. We're on unit panel. Shoot.
You see her?
Yeah, she declined from both. Promoted to
I'm
panelist.
gonna
Yeah,
promote you to a panel. Hold on, I got her.
yeah. Because first she said she had declined because I sent her, I tried to promote her to panelist. So
Okay, let's see if we can get her up here now. Okay, so you're coming in as a panelist. Okay, so let me go to y'all side, and then I'm gonna get ready to get started. The co-host, yes, Samario, the co-host. So that way you got a bunch of co-hosts helping you, and
appreciate that.
you are now the host.
Great.
Oh, I think let's make you the host. There you are. Now I don't have any controls. I don't have any controls. Okay.
All right.
All right.
So I got an appointment to go have my car detailed. So
So glad you can.
while I'm gone to do that, my camera will be off, but I'll still be logged in. Can you hear me?
Yes.
Okay.
Thank you so much for helping and for your assistance for everything. Send you a message.
Were you able to get it to work?
I was able to open it yesterday. Let me see if I can try it now over here. But it was able to work yesterday. Uh, I have to send that to my.
Dr. Williams,
Mhm.
Jacqueline Delata is on there too, so you might want to,
Well, her.
yeah.
All right. I just spoke from other things. Yeah. She's be rejoining as a panelist. So
Dr. Williams, did you see your other speaker? Your first speaker, is he on here yet?
yeah.
I don't think so. Tuesday.
Yeah, Dr. Alberti, yeah.
Okay. And could you,
Make whole.
I think we're good. Okay, so I'm gonna get started. Oh, you gotta press record, Dr. Williams.
All right.
Good morning and welcome. Welcome to our 7th annual State of Disparities Conference. This year, our focus is on reparations in the African American community. Um, I am Ivanka Hall. I am the Executive Director of the nationally recognized Northeast Ohio Black Health Coalition, Housing and Health. We do all of that by working to educate, advocate for, and empower the community. I want to make sure that I introduce to you our staff so you'll know who our team members are. Dr. Lachelle Pugh is our Assistant Executive Director and our Research and Evaluation Director, Coalition. Michelle Hall is our Community Engagement Coordinator. Samario Ford is our Activities Coordinator and our Environmental Justice Coordinator for the Northeast Ohio Black Health Coalition. Kayla Boston is our Administrative Coordinator. And Dr. Zachary Williams, your host for today, is our Health Equity Director. We want to thank you all for taking the time out of your busy day to be with us. We appreciate the opportunity to bring such a powerful group of speakers to you. I am away. I am in Cincinnati, so you'll probably see me popping on and off, but I am here working on some purple air issues with the Northeast Ohio Black Health Coalition, and I'm going to pass this on to Dr. Williams, and I know that he's going to give you the instructions for the day, and I hope that my team treats you well and you have a great day.
Good morning. Thank you so much, Ivanka, and thank you, Dr. Pugh, for your assistance, and for our entire team, Samario and Michelle, Dr. Ford, and others. We're so grateful for your participation today, for your attendance. We're excited about our conference, and with no further ado, we'll go ahead and get started. This is the 7th annual Northeast Ohio Black Health Coalition State of African American Health Disparities Conference. And this year's theme is the state of reparations in the African American community. And our conference goals and objectives are as follows. Reparations for slavery, Jane and Jim Crow, and continuing discrimination against African Americans is long overdue. To understand the long her story and history, the push for African American reparations from slavery to freedom and beyond, beginning with Field Order 15, continuing to HR 40, and the recent establishment of local legislative reparations commissions. Further, we seek to understand the challenges and struggles of efforts toward restitution of historical wrongs against African Americans, and the struggles that African Americans have had to endure and to face over time, as well as we want to highlight the resilience in practical ways. Holistic Black resilience has preserved and been passed on. We will explore numerous approaches to achieve health, medical, and holistic well-being, and well-being as reparations. We will engage in open conversation about the nature of Black reparations efforts, successes, struggles, and lessons learned. We hope to enrich the state of Black health reparations conversations and efforts with meaningful intergenerational dialogue about the influence of social forces and factors, including slavery, Jim and Jane Crow, mass incarceration, and continuing discrimination, on the success of efforts to achieve restitution. Our goal to examine how local, state, and national policies, laws, and initiatives can impact the African American community to achieve health equity through the acquisition of health and medical reparations. The conference will examine the state of Black health reparations by exploring the impact of such efforts on the community through scholarly presentations, historical documentation, and personal testimonies. With regard to the past, we're examining policies that have and can have impact on the present state of Black reparations efforts in the African American community on the local, state, and national level. With regard to the present, we will engage in discussion on the impact of Black reparations efforts in the pursuit of continuing health equity efforts, and for projecting for our future, we will look at what must be done to help shape equitable policies of restitution that promote health and well-being in the African American community, equipping attendees with the knowledge to create and advocate for relevant policies at the national, state, and local levels, keeping in mind what is currently being done, the tremendous work being done all across our country, as well as what has already been done, from Evanston to Tulsa and Asheville and many other places as well. Objectives of conference workshops: 1, exploring concrete ways to strengthen the health and well-being of African American communities through the achievement of policies of a reparatory nature. 2, engaging in honest personal, group, and institutional conversations about creating pathways to create holistic health and well-being of African American communities nationwide. And 3, partnering around holistic ways to promote health equity across generations, taking note of local, state, and federal actions to achieve restitution of past harms, informed through intergenerational conversation, interaction, and exchange. I'd like to introduce our first presenter and speaker, Dr. Philip Alberti, Senior Director, Health Equity Research and Policy, the founding director at the Association of American Medical Colleges Center for Health Justice, which is located in Washington, D.C. And Dr. Alberti's presentation title will be Racial Justice and Health Equity, Public Perspectives on Reparations in America. I'll be placing in the chat more information about bio for Dr. Alberti and other speakers, but I want to turn it over to Dr. Alberti and want to welcome you and thank you for agreeing to present and be one of our speakers for this very important conference. Thank you, Dr. Alberti. Good morning.
Good morning. Thank you, Dr. Williams. It is an incredible honor and privilege to be a part of this conversation today. I'm so excited for the dialogue and for all that I know I will learn from the speakers that follow. So I've tried to share my screen. I hope that you can see the slides. So as Dr. Williams mentioned, I serve as the Senior Director for Health Equity Research and Policy at the Association of American Medical Colleges, which is a national not-for-profit organization whose membership includes 158 U.S. medical schools and 15 Canadian medical schools, around 400 teaching hospitals, including veteran services, health centers, and 80 academic societies. And our mission as an organization is to lead and serve that very diverse community to improve the health of all people everywhere. Our Center for Health Justice was greenlit and kind of given the go-ahead in 2019 as part of our strategic planning process. We spent about 2020 and 2021 building and creating the center, which we launched almost 3 years ago in 2021 with the goal of being a space where community wisdom, multi-sector partnership can come together in order to develop research and evidence for policies that can ensure all communities have a genuine opportunity to thrive. And the resonance with reparations and reparative justice is so clear in that all communities thrive. Today in my talk, our goal here is to spark some dialogue and maybe even co-development of research and messaging that can increase support for reparations-related action and policy. And we're going to do that in 3 different ways. First, we're going to define, differentiate, and connect some of these concepts and terms that we all use: health equity, health justice, trust, community engagement, and reparations. And I think it's important to get on the same page at least so we all understand how the center approaches these concepts and in this work. We're going to identify how messaging and framing and your local context can impact support for policies that would have a reparative justice impact. And then hopefully we'll have some time at the end to explore strategies to really broaden support for reparations beyond those of us that are already in it to win it, so to speak. How do we broaden that tent, make it bigger while staying true to our core values and principles of the movement for health equity? So we'll back into it this way. At the Center for Health Justice, our mantra is this. We say health equity is our goal and health justice is the path that gets us there. So 2 super simple sentences, but I do think it's worth unpacking these concepts of health equity and health justice. What do we really mean? What are we really hoping to achieve? And of course, the definition of health equity that I'm sure that everyone on this call is familiar with is this from the CDC. Right? Health equity is a state where everyone, and I would offer a friendly amendment to the CDC, I would make that every community, right? Because health equity, health inequities only exist for populations, not for individuals. So every community has a fair and just opportunity to attain their highest level of health. And I put in bold, fair and just opportunity. And this is how I'll kind of begin to talk about messaging and framing. I think our focus for health equity absolutely needs to be on that genuine opportunity for health. We need to hit that note that opportunity is actually the outcome that we desire, right? But think about it. When we talk about health equity, we always talk about closing disparities or closing inequities, right? Measuring the outcome. When we think about how we measure and track our progress to health equity, we're not measuring opportunity. We're measuring those downstream impacts of opportunity, which are health outcomes. And I think this is so important when we think about how we talk about our goals, whether our goals are reparative justice for health equity, to create that opportunity for Black Americans, because those that are opposed to this work, those whose kind of actions and beliefs run perpendicular to racial justice and reparative justice, love to use this strength, this focus on opportunity for health equity against us in a way. And so let me make that pretty clear. So here's an opinion piece that Dr. Ben Carson published in 2021 in the Washington Post that literally in the title said, moving from equality to equity is another kind of racism. right? That our work to achieve that fair and just opportunity for all is in fact racist. And he went on to say that rather than equality of opportunity, rather than the stated goal of the CDC and all of us here on this call to make sure that all communities have that fair and just opportunity, they are characterizing, those opposed, that our goal is actually to mandate equality of outcomes, right? That we don't care whether those are good outcomes or bad outcomes. We just want everyone to have the same outcome. That is not true. That is literally the opposite of what health equity means. And he goes on to say that therefore, because we are not about opportunity, such a Central American concept, then we that are focused on health equity, that are focused on racial justice, are not only racist, but we are un-American. And so this is the framing and the messaging that we have to counter if our goal is to really build support for a movement, not only for health equity generally, but specifically for reparative justice. And so then the question is, well, what does a community look like that actually offers that fair and just opportunity for health? How do we take that kind of rather vague, guiding star, guiding light, and make it more pragmatic and operational on the ground? So we in the center don't talk so much anymore about social determinants of health. We instead prefer to frame our work around this framework of the vital conditions for health and well-being. And here's why we don't talk about social determinants no more. So one, they're not really determinant, right? It is not a foregone conclusion that if you are born into a community that lacks affordable housing or reliable transportation, that you will automatically have poor health outcomes. It is not deterministic. The vital conditions for health framework is super goal oriented. Rather than saying we want so-and-so to address transportation, not address does a lot of heavy lifting, what do we mean? This framework says we think every community in order to thrive needs reliable transportation, right? We don't want to address housing as a social determinant. Our goal is to make sure that every community has humane housing. So it's goal-oriented, and I love that. Also, pragmatically and strategically, about 50 federal agencies have adopted this framework for their work around social factors that drive health. So there's this wonderful initiative out of the Assistant Secretary for Health's office called Equitable Long-Term Recovery and Resilience, ELTRR, I think is the acronym there. And it is an interagency kind of group of folks representing 50 or so federal agencies, institutes, and centers from across the executive branch who have really begun to coordinate their work at the federal level around this very framework. So the more that we can talk the language of the feds, I think it's better for us in our work to make inroads. So that's another reason why we have switched. I have also found this framework to be super inclusive, right? I give talks in blue states, purple states, red states, and there is a common ground that every community, even if they're thinking super selfishly for themselves, every community wants these things for their community at the very least. They want humane housing. They want a thriving natural world, right? They want basic needs for health and safety, including, drinkable water and breathable air and high quality healthcare that is easily accessible and affordable, right? So there's a common ground when we say all communities should have and deserve these vital conditions. And then the last reason that we love to talk about vital conditions is because I think it's really instructive for healthcare. At this very moment in time, healthcare is being asked to do or to coordinate or to refer to a lot of these other partners across sectors represented here on the wheel. And we all know that health equity is in fact a multi-sector endeavor, that it is not created in a doctor's office. It is not created in a visit to a clinic. It is created through large structural changes that create health opportunity for communities with the stroke of a policy pen. And so it's useful in this framework to remind healthcare that when push comes to shove, here's what you own healthcare. Right? You own these urgent services around acute care for illness and injury. You own a significant chunk of addiction treatment. But when it comes to those basic fundamental building blocks of health, those vital conditions, you own a sliver of a sliver. You own that affordable healthcare piece and that basic needs for health and safety, which again includes drinkable water, breathable air, nutritious food, etc. So vital conditions for health and well-being, when communities are characterized by having and providing these fundamental services, that is how we in the center ultimately kind of operationalize health equity. For us, health equity means that every community, whether we're talking about geographic communities or whether we're talking about socio-demographic communities, every community has and provides the vital conditions and services that we all need to thrive. So that's where we start. That is our goal. How do we achieve then this goal of all communities thriving, all communities having these basic vital conditions and services? And where we've landed, based on our kind of experience and expertise, is on the framework of health justice. And I'll explain health justice this way. This is a paper that we published last year to talk about different levels of action that healthcare organizations can take in support of health equity and population health. We're not going to go through this whole framework today, but health justice really lives at the bottom 3 tiers of this pyramid. And these bottom 3 tiers are not unique to healthcare. These bottom 3 tiers apply to housing, public health, education, whatever sector you find yourself in. The work of health justice lives here. So I'm going to go up. I'm going to start at that basic level and work our way back up to those vital conditions. So my training in grad school about 25 years ago focused on social factors, social conditions as fundamental causes of disease. And what do we mean by social conditions? We mean all the isms, all the diverse systems of oppression with which we grapple in this country and the world. So we're talking about racism, classism, sexism, heterosexism, cisgenderism, you name it, you pick your ism, that's what we're talking about. These fundamental causes are fundamental causes of illness for a couple of reasons. One, because those systems determine who has access to health promoting resources, right? Resources like information, prestige, power, money, beneficial social connections, a voice at the table, right? The isms, racism determines whose voices are heard and whose are not, who has the important information and who does not. When those isms work their way into what Daniel Dawes calls the political determinants of health, right? Our policy decisions, right? Those policy decisions then in turn maldistribute across our communities those vital conditions we just spent the last couple of minutes talking about, right? So for example, when we talk about new policies around voter disenfranchisement, we're talking about racism in our policies. When we are talking about bans at the state level for gender-affirming medical care, we are talking about cisgenderism. When we have laws in states that don't say gay, we're talking about heterosexism. Right? When we are talking about laws that restrict healthcare for women, we're talking about sexism. These are very concrete ways in 2024 that these fundamental causes, these isms, work their way into our policies and then unfairly and unjustly distribute health opportunity via those vital conditions for all the communities. And of course, today we're talking about Black and African American communities specifically, right? And so undoing these fundamental causes, particularly the fundamental cause of racism, that requires reparations. It requires reparative justice. That's a huge connection between the work that we're talking about today and this ultimate goal of achieving health equity through health justice. And in the Center for Health Justice, we operationalize our process in this way. We say we keep one foot grounded in community wisdom and multi-sector partnership, understanding that the answers do not derive from scientists or public health experts. They derive from local community wisdom who have been dealing with and navigating those isms, those fundamental causes for decades and centuries, right? And again, given the comprehensiveness of the vital conditions, all the things that communities need to thrive, this isn't just the business of public health or healthcare. It is the business of all of us working together in a cohesive collective to do what? To then move to the other foot, which is to co-develop evidence, co-develop research that can be embedded into policies at all levels, organizational, local, state, and federal, so that we change underlying systems and structures so they are oriented towards opening up that health opportunity for communities that currently and historically have been made marginalized. And we in the center do that in a very explicitly anti-racist and anti-discriminatory way, which for us means who has the power to decide which research questions we ask? Right? Who has the power to decide which policies we interrogate, what programs we develop? It can't just be me, and it can't just be our team. It has to be us in concert with the communities that we represent and their communities and that community wisdom on the ground in that hyper local contextual way. So I'm just going to say one more word about each foot and then turn to our research on reparations specifically. So what do I mean by community engagement as a way to work with and understand community wisdom? And I think the important part here is I'll define it by what I don't mean. What I don't mean by centering community wisdom is saying, hey, I have a community advisory board. and we engage that community advisory board 2 or 3 times a year. And the way that this typically goes is I'm going to bring all of my great ideas. I'm going to say, hey, community advisory board, here's my and my team's great ideas. What do you think about my great ideas? Do you love them? Can I get a thumbs up? Check the box, community engaged. That is not what we are talking about for authentic community co-development. So this framework from the National Academies of Medicine is how we've adopted this framework, and we work with this all the time. So check those words in that green circle, right? The iterative, ongoing, long-term process of community engagement and co-development is characterized by co-equal partnership, which means shared governance, which means equitably financed, right? The money is not all flowing to academia or public health. It is equitably financed. It is bi-directional learning. It is inclusive, and it really is in that spirit of co-creation and co-development. And when we do our community partnerships in this way, you can see those 4 petals, if you will. Our partnerships are stronger, our alliances are smarter and better. Everyone's knowledge expands. It is not just a unidirectional flow of information. It is a multi-directional expansion of knowledge, which then leads to better health and healthcare programs and policy, which in turn over time means all communities thrive and that we've achieved health equity, that fair and just opportunity for health by transforming our systems for health beyond medical care, right? All of our systems contribute to that system for health. So that's that first foot of health justice, that deep, meaningful, multi-sector partnership and community engagement. The other side is that research to policy action imperative. And this is a 20-year-old framework that I love and have been talking about for a long time. So we health equity scientists talk about these generations of health equity science, right? That first generation is really descriptive. Where are these gaps? Which populations are dealing with them? How big are they, et cetera? Right? That is important, right? That kind of disparities or inequities surveillance. How big and where are these unjust differences in health between groups? Second generation is really more analytic. Why do these gaps exist? What gives rise to them? What maintains them? Right? The center in our work, and I think all of our work here on this call around reparative justice, is really that third generation science of solution, right? This is evaluation science, it's implementation science, it's health policy research. It's given the gaps and the reasons those gaps exist. How do we actually develop and evaluate strategies, again, that create opportunity for health by changing those underlying structures and systems? And so this work of reparative justice is really both how do we co-create with community the kinds of policy solutions that sit squarely in that third generation of health equity science. And this process of co-creation, of diverse perspectives, of really focusing on policy change for us in the center is as important as the products, whether it's the output or that ultimate product of health equity. If we don't adhere to this kind of process, we are not going to achieve the goals that we have together. This is not a top-down, anyone knows best. This is a collective movement to achieve health equity through health justice. And so our goal in the center is to model that process as best we can as a national organization, to influence the understanding and adoption of this process by our member institutions, by other national organizations, by federal agencies, and then to develop tools and resources that make this easier for everyone to do. And I won't spend any time on our actual work beyond reparations today, except to say here are our 4 domains that we have focused on these first 3 years: trustworthiness, data for health equity, maternal health equity, and environmental justice. And so in that community engagement foot, and now to segue into our conversation about reparations, here's how we try to operationalize our community engagement. We convene a group, a collaborative that you all can join. There's the link. It's free. There's no barrier to entry, called AAMC Charge, or the Collaborative for Health Equity Act, Research, Generate Evidence. They are literally the first stop for anything that we decide to do. If we are writing a comment letter in response to a notice in the Federal Register, we are co-writing that with Charge. If we are developing a program, we are co-creating that with Charge. Right now, there are about 1,700 members of this collaborative. About half, maybe 55%, are from one of our member institutions, an academic health center. But that means the other 45% are their multi-sector partners, their community and faith-based organization partners, local business partners. So the kinds of perspectives that we are able to bake in because of our work with Charge, really diverse and really importantly, multi-sector and community driven. And so one of the very first ways that we worked with Charge was early in the pandemic, in February, March of 2020, when there was a lot of conversation about how we as a society could focus on diversifying clinical trials for vaccines that were coming down the pike or being developed. And we heard a lot of expert voices in that dialogue. We heard experts from public health, from medicine, from politics. We didn't hear any community experts, but we heard a lot of other experts about what the community needed to get over their mistrust and distrust in vaccines and science. And that narrative kind of went like this. It said, if only the community were educated, right? If only we experts could educate the community, they would see that we're not like that anymore. If only we had this perfect magical pamphlet that had all the right pictures and all the right local jargon, we could distribute this pamphlet to the community, like there was only one, and they would see that we're not like Tuskegee or Henrietta Lacks or Havasupai or the Guatemala syphilis studies, that we're not like that anymore. They would trust us. And we thought, given our expertise in this space, that that was incorrect, that it was patronizing, and that it was not helpful. And the time had come to flip the script on this conversation about trust and really make it one about trustworthiness. Right? What does it mean for organizations with power and privilege, federal agencies, healthcare organizations, public health departments, whatever it is? What does it mean for organizations with power and privilege to demonstrate they are worthy of communities' trust, right? That they are trustworthy. And so we worked with Charge in 7 different communities across the country and 35 different community members to develop our very first product as a center, which is our Principles of Trustworthiness Toolkit. And I'm going to share the first principle with you now because it is so salient and so relevant to this conversation about reparative justice. And the first principle that the community members came up with is this: the community is already educated, and that's why it doesn't trust you. Right? This is not only about respect, right? Why are you coming at me with trying to educate me instead of trying to partner with me? But it's also about taking responsibility. Right? It's about taking responsibility for the current and historical actions that have made communities marginalized over the course of decades and centuries. And the conversation about taking responsibility for current and past actions absolutely led to the next step of what Charge did for us. Is we said, Charge, what do you want to focus on? What do you think your research, as this kind of research and policy collaborative, what do you want to take a stab at? And they said 3 things. We want to focus on reparations and its impact on health equity, economic policy and its impact on health equity, and civic engagement and voting and its impact on health policy. And so because of Charge's direction and our desire to always kind of follow that health justice model of leading with community, that led us to the current work on reparations that I'm excited to present today. So hopefully that first learning objective of tying reparations to health equity and health justice and community engagement, hopefully we can check that box off. So in April of this year, we published this report, Racial Justice and Health Equity, Public Perspectives on Reparations in America. We partnered with Morning Consult, which is a national polling outfit. This poll included a sample of over 10,000 US adults, so folks in the US over the age of 18, and specifically probed perceptions about how they felt about reparations, what they knew about reparations, and then tried to begin to understand how we could frame policies that focus on reparative justice for maximum buy-in and maximum support. As I always say, we in this community, the health equity community writ large, we are great at shouting our truth at each other. We are less great on making our tent bigger. So how can we do that, particularly when it comes to the important issue of policies for racial justice? And so at the time, this is already out of date. You can see this map was put together on March 6th of 2024. Chicago is not on here. They, of course, launched their Black Reparations Task Force just about a month ago. But at the time of this work, there were 22 localities and 11 states that had begun the work of exploring reparations. They had task forces underway. They had commissions that were being established. And one state, of course, California, in June of 2023, released their report their California Reparations report that listed 115, maybe even more than 115 policies that could have a racial justice and reparative justice impact. And importantly, those policies are representative of all of those sectors in the vital conditions for health and well-being. So we in the center were interested in those policies in the California Reparations report. And is there general support across the US and across all 50 states? That large sample of 10,000 plus actually let us get state level estimates and understandings of support and ideas around reparations. And so what we did in the center is that we selected 7 policies directly from California Reparations Report's recommendations. And so you can see those 7 policies here. We should increase funding for civic engagement, education, and voter registration drives in high schools. We should restore voting rights for folks that were formerly incarcerated. We should require landlords to accept housing subsidies and vouchers. We should have more public school funding for educational programs. We should fund environmental hazard exposure screenings. We should have financial support to assist voluntary participation in clinical trials. And we should prohibit rent increases on units that need repairs. So these are directly from the California Reparations report. And the first thing we did in our national poll of US adults was just without any context, without any mention of reparations or racial justice, without any framing about where these policies came from, we just tested these policies as written in the California Reparations report. And here's what we found. So a majority of everybody supported all 7 of these policies. There was not a state in the union, red, blue, or purple, where support for these policies from California's reparations report fell below 60%. You can see that it didn't, it mattered whether you were conservative or liberal in terms of your level of support. But across all these 7 policies, self-identified conservatives, a majority of self-identified conservatives supported these policies. So that was a really important kind of high-level first takeaway for us, is that the policies themselves that promote racial justice, when you haven't mentioned racial justice, and that's important, right, are universally supported. That in theory, every state could get behind these policies. So for 3 of these policies, for high school voter registration, environmental hazard screening, and support for clinical trials, policies that could be phased in some way, we did something what I think is pretty clever. We did a split half sample. So we had 5,000 folks get one version, 5,000 randomized to get another version. And we said, for example, for voter registration for high school students, we said, because of limited resources, we might have to phase this policy in. So one way that we could implement this policy is to prioritize high schools in so-called voter turnout deserts, which is a real thing, which just means that the voting turnout is less than the median voting turnout for voting districts across the US. So we should prioritize high schools and voter turnout deserts. That's what one half of the sample got. The other half of the sample said, same thing, limited resources, have to phase it in. But because of a history of disenfranchisement in Black communities, we should focus in on high schools in Black communities. So one got a very racial justice, reparative justice kind of forward message. The other got a, I guess we could call it more objectively neutral, voter turnout desert message. Importantly, focusing on voter turnouts, just because of the correlation of who lives in voter turnout deserts, would have a racial justice impact. There are an increased number of Black and brown folks that live in voter turnout deserts, but again, it wasn't framed explicitly as reparative justice or focused on racial equity. And so we did that kind of split half frame for all 3 of those policies, and the results probably won't surprise you, right? The agreement with an already proven to be popular reparation policy is lower when it is presented with a racial justice focused implementation. So you can see in the middle that voter registration for high schools, when it is a racial justice focused framing, 27% disagree with it. When it's that more neutral voter turnout desert, 19. And you can see support higher for the neutral and disagreement higher for the racially justice focused. But that's not the end of the story, right? So I think that's probably not surprising to us, given these hyper-polarized time, the way that these words and concepts, as we saw from Dr. Carson, have been weaponized and twisted a little bit, it's no surprise that the way that we talk about these policies mattered. But the next nuance, I think, is really, really fascinating and instructive for all of us trying to do this work and garner support at the local level, is that depending on what state you were in, because remember, we were able to see with that huge sample state estimates of all of these, depending on what state you were in and depending on what policy you were testing, whether or not there were differences between these implementation strategies, right? The racially focused implementation strategy or these more neutral focused, it really did vary. So here you can see that the only reason that I boxed Pennsylvania is because it was easier for me to draw a rectangle than to try to draw a line around Ohio. But you can see in both Ohio and Pennsylvania, these huge swings, these are the differences in support, right? The relative difference in support between the reparative justice focused implementation and these more neutral implementations that we're talking about. You can see that in Ohio, 9% difference for clinical trial diversity and even higher difference for environmental screening. But when it came to high school voter registration, it didn't matter quite so much. Right? And in Pennsylvania, it didn't matter at all that the same number of people supported that the racial justice focus implementation as supported the voter turnout desert implementation, right? So again, these local contexts and the policies being discussed really, really matter. And to me, as a community engaged scientist, that really speaks to that first foot of the health justice framework, is that spending time in community, understanding how these dynamics play out with the diverse communities you all serve and live in, is really key to thinking about the right way to frame and message the policies that we think would have this reparative justice impact. So broadly, then we kind of opened up the conversation and actually used the word reparations in the poll for the first time. We found 66%, so 2/3 of US adults were familiar. The more years of education that you had completed, the higher income that you reported, the more likely you were to be familiar with the term reparations. There was pretty much an even split in those who supported and those who opposed, with a full fifth of US adults not knowing or not having any opinion. So there's some movement that is possible among that fifth of US adults that are kind of unfamiliar with the concept. Just some racial ethnic breakdown in the support numbers. So 3/4 of Black respondents supported, kind of going all the way down to about 1/3 of white respondents. If you were from a younger generation, you were more likely to support the concept of reparations. And there were only 2 states, or 1 state plus DC, where the majority of US adults supported reparations. My state of Maryland, and of course the District of Columbia, where almost 70% of district respondents said they supported reparations. So why were folks who were opposed to reparations, what were the reasons for their opposition? We have the ability to get a little bit of qualitative data here. You can see that many folks believe that that slavery and that racial injustice of yore does not impact the African-American population today. 1/3 of those that stood in opposition to reparations did not make the connection between kind of historic and injustice and modern day inequity. So I think that is one big message from this poll, is how do we in this movement do a better job of connecting those dots from the history to the modern day inequity and inequities that exist for our communities. About 20% said money isn't the solution. Now, importantly, we included money in our definition of reparations, but much like the California document, there are so many other ways, so many other policies beyond direct cash payments that would have a racial justice impact. And importantly, in the California report, they didn't even propose direct cash payments. They were focused on those kinds of policies that you saw we tested: housing policies, education policies, healthcare policies, etc. And again, the final sentiment is, the damage is not done to these folks personally. This is some ancient history that no longer reverberates today in 2024. So those are some of the counter messages that we that are committed to this work need to begin to overcome and think about strategically how we respond to these reasons for opposition to reparations. Dr. Williams earlier mentioned some of the current efforts in Evanston and Asheville, I believe he called out specifically, and that was the last part of our poll, is we presented these 5 actual instances of the United States, in some way states or federally, providing reparations to a group. So we tested one-time payments for eligible Japanese Americans who were interned during World War II. We tested the recent Evanston and Asheville and Durham, North Carolina policies that had a racial justice and reparations focus. And then we tested the award of $10 million in other forms of redress, including healthcare and burial costs for the living relatives of the African-American males who were denied medical treatment for syphilis during the U.S. Public Health Service untreated syphilis study at Tuskegee. So we wanted to understand, regardless of how you feel about the word reparations and some of these policies, do you support what we've already done? How do you feel about that? And so here's what we learned. So a third of conservatives support past reparations. So that's, I think, pretty impressive. And all told, regardless of your political persuasion, there was, if you look at those purple bars, all 5 of those kind of actual instances of reparations garnered over 50% support. And then you can see that, of course, self-identified liberals had the most support, followed by moderates, followed by conservatives. And then there was this final kind of interesting trend that you'll see that in the Japanese Americans in World War II internment camps and the non-treatment study at Tuskegee, those were the only 2 examples of actual reparations where the majority of conservatives were in support, right? And so they were the most historical. So there's some maybe some kind of look back effect there, but also maybe the briefest amount of time had passed between the injustice and when the reparations was made. So there's something, again, about connecting dots between history and modern day. There's something about not waiting too long to make these reparative policies, to put them in place. There's something here that is absolutely worth exploring. And so a main conclusion for us then, obviously, is that there's majority support for these selected policies from the California Reparations Report, but U.S. adults are less likely to agree with actually implementing them when racial justice is an explicit goal. And so I think the largest question that we left with in the brief, and you can see the link to the brief on the screen, is this one. How do we advocates for racial, social, economic justice? How do we grow our tent, right, and use words and framing that bring people in to this movement, but without hiding or watering down what we're actually after? We can't have a conversation about reparations without talking about racial justice. Wouldn't make any sense. So how do we do this? How do we square this circle given these data that we've just gone through now? So some of our tactics, and I would love to expand this list for some of your strategies. Again, we always start with community engagement. Let's really dive deeply into the words, the framing, the messages that resonate and work. And it's okay to shift messages from one community to another, from one county to another. That's just successful marketing, frankly, right? We want to make it personal. We want to have more storytelling. So this isn't just about data, and we've heard this from whether it's policymakers or folks kind of overseeing regulations, that yeah, data are important, but what really moves the needle are pairing those data with individual stories of how this work, how past injustices actually does impact communities in 2024. Let's tell those stories in ways that really resonate. We also have taken it upon ourselves to really address all the isms, right? All those fundamental causes. We in the center are never not going to talk about racism. That's just core to a health equity movement. But we absolutely are going to be talking about classism and elitism and sexism. And we're going to lead with the system of oppression that is most germane to the communities in which we're talking. Again, that community engagement imperative. And then finally, using frameworks like the vital conditions, where everyone can come together and say, okay, you know what, maybe I'm not there yet with trying to understand why other communities don't have those basic vital conditions. But at least as a starting point, I can say that, yes, I think my community should have those. And sure, other communities should have those. And then maybe there's a way to open up a conversation that is more inclusive, again, that enlarges our tent while sticking true to our values. So some of our next steps in this work specifically, before I close, is we're going to take another look at those polling data, and we're going to correlate with the context of state level policies around voting restrictions, around other kind of what I would classify as kind of racist policies at the state level, to see if attitudes toward reparation and state level policy action kind of hang out and are correlated in any other way. Our director of policy, Daria Greer, who wishes she could be here today, she's tremendous. So I'm just a poor stand-in for her on this talk. She has conducted an amazing landscape of those 22 localities in 11 states that have developed task forces or commissions to really take a deep dive into what policies they are proposing. And so we, with our Charge Collaborative, our reparations focused Charge work group, we're going to take a very deep dive into those policies, maybe map them to the vital conditions to begin to really create this multi-sector movement for some of this work at the local and state level. So if you're interested in learning more about the center's work in reparations or those other domains, here is a QR code that will take you to our website. You can sign up for our newsletter as well. So here's that QR code. If you have things you want to share in our newsletter, please just email me and I'll put that up in a moment. This reaches about 5,000 folks across the country. You can join Charge. That's another action. Please do take that. Again, it's open. There's no barrier to entry. And then here are all the ways that you can connect with us. So there's our inbox, AMC Health Justice, healthjustice@amc.org. If you have things you want to share with us, you can follow us on X and LinkedIn. You can sign up for our newsletter. Thank you again for this opportunity to present some of the work that we've been doing. And I look forward to answering any questions that you might have. Dr. Williams, you might be muted if you are.
Oh, yes. We certainly want to appreciate your participation, your presentation of information, your research and insights from your center and your center's work. We're certainly grateful for your participation today. And if there are any questions for Dr. Alberti, for Dr. Alberti's presentation, you can add those questions to the Q&A, and that's true for all of our speakers, and then we'll be sure to ask those questions and be able to get everyone's questions hopefully answered. So if you have questions, please feel free to put those forward. I'll just ask Dr. Alberti, where do you see the next local reparations efforts going in terms of the research which you presented, based on what you've come across and what you've researched thus far? What's next? Where do we go from here?
So I don't have all the answers to that. I want to pretend that I do, but we've begun to have conversations with different task forces across the U.S. We made a particular effort to share the research brief with folks who are part of those task forces. And I think what we've heard again is the imperative for the local research, particularly in kind of the vein of a health impact assessment. So these policies that are being proposed, can we begin to estimate the impact in localities or states of implementing these policies, what they would mean, not just for Black and African American communities, but for the populations of the entire state, right? Again, I truly believe that these policies that promote racial justice actually promote health and population health for all of us, for all communities, whether we're Black, brown, white, or anything else. And so I think the research that can build that evidence that shows these policies are good for state health, all populations' health, and are leveling that field in terms of creating that fair and just opportunity. So we heard that from the Philadelphia task force. I know we've heard similar sentiments, and we're chatting with folks from the New York State task force, I believe, next week. And so we've just begun to kind of understand what individual places are really trying to prioritize in terms of their own research.
Thank you, Adrian Worthy, and thank you for your question, Adrian. Adrian asked, how does whiteness and specific anti-Black racism affect your initiatives if they aren't addressed directly and called out for what they are? Adrian expresses fear that this will continue to perpetuate the system that still negatively impact Blacks and African Americans.
Yeah, that's exactly right. So as I said, we always talk about racism, we talk about classism. I think if you don't call it and name it out, you can't address it, you can't measure it, you can't take action against it. I think it's also about acknowledging the privileges, that conferred by whiteness, and doing our best, as I mentioned, in the way that we try to be an anti-racist center and walk that talk, is to make sure that the power to make decisions, the power to craft our work, the power to develop polling instruments, the power to access our data, is not just for us and by us, but is truly co-developed with diverse folks from, yes, our academic medical community, but more importantly, like that principles of trustworthiness toolkit, that's actually driven by local community member wisdom. And so I think the way that we have tried to undo and run counter to the kind of the knee-jerk racism and focus on white privilege is to make sure that we are not centering that in our work, and that we are centering the voices and perspectives of folks that have been made marginalized historically. So.
Thank you. And along with that, Lonnie asks, and thank you for your question, tailoring messages based on the audience can be both confusing and maybe contradictory. Should those communities come together, how do we reconcile that to create, common ground and some operational unity around these issues?
Lonnie, that is a tremendous question. So I think one, and maybe this is like a Pollyanna kind of answer, if we are true to like our truth and our core, then I truly believe that our messages shouldn't be contradictory, right? They might be using a different synonym. They might be prioritizing one piece of the work over another. But at the end of the day, I think that consistency, that authenticity of message, if we don't have that, we are not trustworthy, right? So I think that's number one. And so I think making sure that we are consistent and authentic in our motivations and in our goals, and then being able at the same time, when we're sharing our goals and our motivations, hearing the goals and motivations of disparate communities, right? In Ohio, and pick a city in Ohio, you are working with 12, 14, 16, 18, 20 different communities, right? The Cleveland community is not monolithic. And so if everyone has that shared desire to thrive, right, to make sure that everyone has a shared opportunity for health, right? The pathways for the different subgroups might be different. The local policies might be different. The messages might be slightly different, but that core goal and aim, I think, is the same. And so I think another principle of trustworthiness is show your work, is transparency. And so when we have, I spent a lot of time in New York City Department of Health and Mental Hygiene doing community partnered research and program work in 3 very distinct communities, the South Bronx, East Central Harlem, and then if you know New York, kind of deep into Brooklyn, Bushwick, Bed-Stuy, Brownsville, East New York, right? Grappling with the same inequities around housing and healthcare and services, but with very different ideas about what the reasons for those inequities are, what the solutions were. So being transparent when you bring people together in that act of convening so that you can explore those differences and find strength in those differences and understand how you have to be clever in the messaging and the tactics, depending on where you are. I think bringing folks into that conversation and helping co-develop those kind of nuanced different messages is also, you can never go wrong with co-developing in a transparent way around that core truth. So.
Wonderful. That's great. Certainly appreciate the questions and your responses as well, Dr. Alberti. I believe, there's another question Adrian has. How does this intersect with people of the neurodiverse, disabled, and queer Black individuals when many large organizations fail to hire and seek out these individuals for positions of power and decision makers? This then creates continued unsafe performative institutions that for many Black and brown people, we will still struggle with trusting fully.
Oh my gosh. Adrian, you have literally hit in that one paragraph, you've hit on 3 of the other community identified principles of trustworthiness. So first is around intersectionality, right? Diversity is more than skin deep. So how are we being very intentional about seeking perspectives at the intersection? Number 2, another principle that you hit on is, a pledge without action is performance, right? So, and the kind of post-COVID, as if we're actually post-COVID and kind of in the wake of the series of murders by police at the outset of the pandemic, there was a lot of pledges and a lot of new positions that were created that have around health equity, around racial justice, around EDI that have since been rolled back, right? So these pledges of racism as a public health crisis without actions and accountability to back it up are absolutely performative, 100%. And the question disappeared, but I think the third one that you hit on is really that intentionality. I think the principle that the community members came up with is if you're going to do it, take your time, do it right, right? This is thoughtful work. So in the center, I mentioned that we convene our Charge Collaborative. The other group that we convene is our multi-sector partner group, right? To really walk the talk on health equity being this kind of all hands on deck perspective. We were very intentional, right, in seeking folks out from the disability community, for example, folks that represented not different sectors, but different identities. And then that group is another way in which we kind of bring perspective into our work to try to undo some of the privilege at the AMC, that the center, that I as a cisgendered white man might have in our work to make sure that we are bringing that intentionality, that transparency, that sense of intersectionality to our work. It takes a lot longer. So I think, the arc of this work, and I think policymakers in particular want quick results. There are no quick results in this. And I think that is something, another lesson, something for us to grapple with is doing this work in the way that overcomes the barriers that you completely accurately laid out in your question takes a lot of time in the arc of elections and election cycles, moves at a much faster rate. So I think that's another challenge that we face, but we are trying to walk that talk in the center every day. And I appreciate that question. Thank you.
All right. I think those are questions. If you have other questions, then, I'm sure we'll be able to provide contact information, for all of our speakers, including Dr. Alberti. You can certainly get in touch with Dr. Alberti and Dr. Gray and others and be able to interface and ask your questions. Dr. Alberti, we want to thank you so much. It was a great presentation. Thank you for your partnership and participation in this conference. It's been extraordinary.
Thank you, Dr. Williams. I appreciate it. Looking forward to the rest of the day.
Thank you. Just want to also just recognize some of our partners. I want to, thank and recognize Attorney Jaleese Thomas, who is Director of Research, Health Equity, Clinical and Translational Science Collaborative with Case Western Reserve University. We're partnering around continuing education credits for lawyers and attorneys, and Lawyer Thomas will be assisting us with a survey that they have put together for their members and just assisting us throughout the conference. So we want to recognize them and all of our partners and thank and welcome all of you who are joining us today. And we hope that, the beginning of the conference has been exciting and interesting to you and piqued your interest. And we hope the rest of the day will be as fulfilling and interesting and informative along with that. Let me go ahead and introduce our next speaker so that we can continue on in sort of a timely manner. Want to introduce Dr. Athindar Venkataramani, who is the Director of Opportunity for Health Lab and Associate Professor, Department of Medical Ethics and Health Policy at the University of Pennsylvania. Senior Fellow in the Leonard Davis Institute of Health Economics at the University of Pennsylvania. And Dr. Venkataramani is an associate professor in the Department of Medical Ethics and Health Policy and is a staff physician at the Penn Presbyterian Medical Center. It's a health economist who studies how social and economic factors and policies affect health and well-being throughout the life course. His research combines insights from economics, public health, and clinical medicine, spans both domestic and international settings. Dr. Venkataramani directs the Penn Opportunity for Health Lab, a research group that seeks to identify policies and interventions that can jointly bolster both economic opportunity and health in the United States. Dr. Venkataramani completed his MD at Washington University, his PhD in health policy economics at Yale University, and his BS in biology and economics at Duke University, completed residency in internal medicine, global primary care at Massachusetts General Hospital. And the title of Dr. Venkatamari's presentation will be Wealth, Public Policy, and Racial Disparities in Longevity. And with that, we want to welcome Dr. Venkatamari to our conference. I want to thank you so much. Grateful for your willingness to present, for your research, the work of you in your lab, and your willingness to be with us today. And without further ado, we want to turn it over to you and just look forward to your presentation. Thank you so much for joining us.
Hey, thank you so much, Dr. Williams, for having me. It's a really incredible conference, and I enjoyed your remarks in the previous talk as well, and look forward to the rest of the day. So I'm going to load up my slides here. I just want to confirm that you can see them.
Yes, we can see.
Perfect. Okay. You never know with Zoom. All right. So what I thought I could do is just set the stage with some stylized facts and results about just wealth in general and how that relates to racial disparities in longevity. And I'm an economist and an internal medicine physician, so I'll stick to what I know. And I'm aware that many of you will know a lot of these facts, but this is more of a way to bring everybody together around a common set of facts that we can build on going forward. I just have to disclose research support from various places. And what I'll do today is I'll start by talking about the racial wealth gap, just quantify that, and go through the types of forces that have led to its origin and persistence. We'll kind of go into what that means for health consequences, focusing specifically on longevity. And there I'll highlight two studies that I was part of, led by Katie Himmelstein, who's in Boston. And then we'll simulate the effects of reparations and other policies, and then we'll end with talking about the healthcare sector. I think it's something that there's been a lot of energy around reparations and health equity in healthcare, but we often are not quite sure what, say, an academic medical center or a hospital system can do. And there's also things that we do in healthcare that are potentially not great for health equity, but we aren't really aware about the negative impacts we might have on our communities just through standard business operations and so forth. So I'm going to try to highlight a lot of those things just to bring in some additional facts to the discussion that we are going to have today. All right, so first I'll talk about the racial wealth gap and its origins. So as this is a great paper from Elora Duranencourt and colleagues, and what they did that was really interesting was they were able to find measures of wealth going all the way back to 1860. I think many of us have had a sense that there is a large racial wealth gap and that it has persisted over centuries, but quantifying it and understanding its dynamics is very useful. And there's a couple interesting facts that emerge out of this figure. What we've got on the y-axis is the white to black wealth gap. So you can think of this as the number of dollars of white wealth for every dollar of black wealth. So right around 1860, at the time of the Civil War, there was this almost 60-to-1 ratio in the black-white wealth gap. Post-Reconstruction, you saw this drop, post-Civil War, you saw this drop to about $20, $25 per dollar of black wealth. And from then on till about 1950, 1960, you saw a pretty slow but real decline in that ratio. But since around the 60s, we've plateaued. And certainly since 1980, if anything, the white-black wealth ratio has increased. Today, Black households have about 17 cents for every dollar of white wealth. So this is the set of facts that we're working with. And there's, again, two interesting things. Large progress made very early, but persistence and recalcitrance since then. So trying to understand why that happens. Going back to the origins of the gap, I think we all know this, but it's useful to put some figures around it. The original sin of slavery contributed to hollowing out wealth and the ability to save and invest and create more wealth in Black communities. And this isn't even, what I'm about to show isn't even the true gap that we're dealing with. This is just looking at Black individuals who happen to be free or who had ancestors who were free prior to the Civil War, and Black individuals who had ancestors that happened to be enslaved prior to the Civil War. And this is a difference in things like literacy rates, the types of occupations people are in. And what you can see is from 1870, 3 generations, 4 generations onward, you have persistent gaps between those who had ancestors who were free versus those who had ancestors that were enslaved. This gap isn't even the size of the gap that we're talking about when we think about reparations, because we know that individuals who had free ancestors still faced a great degree of systemic discrimination. But nevertheless, even among that group, you see this big difference in how it persists over time. Reparations seeks to correct some of those gaps here. And it's worthwhile to think about why these gaps have persisted, because it will bring us to present day. Back then, what happened after, say, 1880 in particular onwards was that states adopted Jim Crow laws of various different kinds. And through those policy actions, were able to maintain differences between the free and enslaved population over a generation, 2, 3, or 4. So there was a policy response to freedom that led to effectively a constraint on that freedom. And this is a theme that has played out over and over. We can look at what happens by accident when there is investment in the Black population, and it tells us a little bit about what underinvestment might do. And we can think about something like schooling, right? That's important for occupational attainment. It's important for social mobility. It's important for wealth and savings. So in Mississippi in 1920, this is a paper by David Card and others, there was this financing equalization program trying to make sure that all public schools in Mississippi were receiving the funds to be able to teach the children what they needed to learn. The key, when I say all public schools, the key qualifier is all white public schools. So what ended up happening was the state had this policy to equalize public school finances, but at the county level, it worked out that most of that money went to counties where there were majority white students. This affected Black students in some interesting ways. On the one hand, counties that were predominantly Black did not see a lot of this money. But if you were a Black individual living in a predominantly white county, you actually did benefit from school investment. So it gives us a sense of understanding how might things have looked like, not just in 1920, but in 1940 and all the way to 2000, so close to present day, had there been some more investment in the schools that you were in. And what they were able to do, and this is thanks to innovations in data, is to connect people who are living in these counties around the time of the school financing equalization program to people who were surveyed in the census in 2000. And what you see is that individuals who happened to benefit from this program that wasn't actually trying to benefit Black individuals, but by virtue of moving money to white individuals affected some Black individuals in a positive way. The Black individuals who benefited through sort of that perverse mechanism were more likely to have higher years of schooling. They had 3% at a single point in time higher log household incomes and income per capita. And if you take that 3% income and you work it back over the course of one's life, that implies a good deal of savings and wealth that can be generated. It's not the whole gap that we see today, but it gives us a sense of how not just the original sin of slavery or the response to freedom that happened right after that, but the continued underinvestment in this population, even through policies that were supposed to be universal, have contributed to the gaps that we see today. When Black individuals were able to attain wealth, there were responses, some of which were dramatic, some of which were less subtle, or more subtle rather, that led to the destruction of wealth. So this is going back to the Tulsa massacre, where on the pretense, it was a racial powder keg. There were some false accusations that were made, and it led to the mass looting and destruction of Black houses and Black businesses. So over 1,200 people lost their homes and businesses were destroyed. It's noteworthy, not just because of the concentrated scale and nature of what was done, but the fact that Tulsa was actually considered the Black Wall Street. It was a generation of wealth in Black communities. And economists have been able to follow this forward from 1920 onwards through to about 2000, looking at what happened to home ownership, which is one of the largest ways that Black households hold their wealth today. And what you can see is that in Tulsa after this massacre, and you can go 80 years into the future, you see effectively this monotonic, steady decline in home ownership, thanks to something that happened in 1920. And the reason this happens again is because we respond or I think society has responded to social mobility among Black individuals and wealth among Black individuals in ways that try to preserve the racial hierarchy. There are various theories of this in sociology. It could be fundamental cause theory. Dr. Sandy Darity has a really interesting set of theories looking at intergroup conflict. It's the type of thing that plays out in what Dr. Alberti was talking about earlier, which is when you frame policies that are potentially redistributive around racial justice, it actually changes the valence of support for those policies, right? So there's a threat that the majority group feels, and much of it is framed around zero-sum thinking. Something similar happened during the Great Migration in the second wave in 1940 to 1970. So here, Black households tried to go north to avoid some of the Jim Crow laws in the South and achieve upward mobility. But what ended up happening was that in moving north, they actually were less socially mobile. So here we're measuring social mobility as the extent to which your children do better than you do. And that got worse as people moved north. Not only that, migration out of the Deep South has shown to have led to a reduction in Black life expectancy by about 1.5 years, right? So that's about half of what COVID did in a short time. This is what happened with the Great Migration, something that was supposed to have the opposite effect. And the reason for that has to do with a lot of different policy changes that were responding to the influx of Black migrants. More investments in police, greater racial residential segregation, and by virtue of that, white flight from public schools and creation of neighborhoods that were hollowed out in wealth, where the tax base was not high enough to invest in school. And then, of course, more incarceration. So this will bring us back to the present day. But what I want to highlight with this, and again, I'm not telling you things that I think we all know these facts, but the scale of the size of the effects, the repetitive nature of starting with an initial inequality and having legal means, extra legal means to reinforce that over the course of generations, that is the reason that the Black-white wealth gap has not progressed since 1950 or 1960. And remains wide into present day. So that brings us into thinking about the health consequences. So here we go. Let's first talk about wealth and health gaps and what we know about them from the literature. So in general, we know that wealth is correlated with health. I think that's probably intuitive to all of us. Whether that correlation is something that is a causal relationship between wealth and health, it does seem to be the case. So there are people who've looked at things like what happens to abrupt changes in wealth, say as in the Great Recession, and they have found that you see these either adverse or positive impacts on health depending on whether health goes down, wealth goes down or up. It's important to know this correlation and to know that it's causal, because as we start talking about what might the effect of reparations on health be, we have to have a strong base to be able to link these two concepts to understand what their policy impacts will be. It is a hard thing to do, though, to try to understand causally how wealth impacts health. And before I get into this, one thing I just want to caution is the argument for reparations does not necessarily need to have some kind of operational foundation, right? So it doesn't have to be the case that one has to show that reparations will solve racial health gaps to support reparations, because we're talking about a completely different concept around justice. What I'm trying to do with what I'm showing here is potentially these types of facts around what reparations may do for health can bring in other communities that might be interested in policies to help increase health in general, and through that bolster the arguments for reparations, build the consensus around that, and so forth. But the instrumental effects of reparations is not necessary to go ahead and support a policy like that. So with that caveat, we'll move into what reparations could do for health. So it's hard to study. There are very few data sets, I think, that have good information on race, wealth, and health. Also, within different racial groups, it's hard to track wealth. Wealth can look like different things in different groups. So I'm of Indian descent, and one of the things I know in studying Indian data is a lot of wealth is held in gold, and that is not reported, and the exact amounts are not even known. And so that at some level, it's liquid enough that families can draw on that during times of need. So if we were to study this question in India, for example, it would be really, really hard. And some of those problems are there in the United States too. So what do we do to try to get at this question? So the first thing we do is there is some good survey data that we could use. And what we end up using is something called a health and retirement study, which is a longitudinal survey of people above the age of 50 starting in 1992. It has a couple of good features. One is it oversamples Black adults. So we'll be able to get more precise estimates of what we're trying to understand. The second thing is it has information on different forms of wealth. It could be home ownership, it could be stocks, it could be other things. And we also know the debt side of the equation. So we're able to actually measure wealth as assets minus debts and do so in a very reasonable way. The final thing that's useful is that we know when people die, if they do. Some people continue to live through subsequent surveys, but this is a 50 plus population. It's been now 30 years since the survey started. So naturally, there will be some deaths, and we'll be able to use that information to look at the relationship between wealth and people's probability of surviving. So we will think of that as life expectancy. We are going to do what is a back of the envelope exercise. And we hope that others can build on it. And it's back of the envelope because, as we learned from Dr. Alberti's talk, a lot of the work that's been done on reparations, like actually implementing reparations, is either very, very current or historical and affects small groups of people. So trying to understand from those historical incidents, if we were even to have the data to study them, trying to understand how that might look at a population level is tough. So we're going to have to simulate all of this. And in simulating all of this, you make a lot of assumptions. So I'm going to be honest about what those assumptions are, and I'm hopeful that other people will build on it. So the first assumption is that, we have a measure of wealth, we have a measure of health, we're going to correlate them. We're not going to take a position on whether that's causal or not, because you need a lot of different natural experiments to do that, and we just don't have that. What we're going to say, though, is the fact that this wealth gap has persisted between these two groups for centuries and relates to many historical factors, that modern day differences in health are because of those historical factors, and that those historical factors have nothing to really to do with the types of attributes people might have that may determine their wealth or health. So, for example of an attribute,
Hopefully Dr. Alberti will be able to, Dr. Ventika Damari will be able to join us again soon. Just want to note there are some notes in the chat for those of you who are, qualifying for CLE credit. Before the chat is over, for those who are applying for or qualifying for social work Cs, we'll put that information at the end of our conference so you can be able to get those credits. And again, if you have questions or thoughts you'd like to share or raise with our speakers, and please place those in the Q&A, or you can also raise your hand, so we'll be sure to identify everyone. so that you can, ask those questions of our speakers. We'll also take some time to be able to take a break, maybe after around maybe if you need to. We'll try to keep our conference going because we have a good number of speakers. So if you need to take a break in between, then that's fine. But we'll try to keep things moving in a timely way. And I believe Dr. Venka tomorrow is back with us, so we'll continue on.
Hi, I'm so sorry. Dr. Williams, where did I stop? I think we have a tornado watch around here. I think it just knocked out a bunch of things.
Yeah, I think that's a good place right there to start.
Okay, great.
To continue.
Thank you. All right. So hopefully my real internet will come back. Otherwise, I'll hotspot, and this should be okay for us. Yeah. So I think I mentioned that we had looked at the health and retirement survey, and it's a good place to look at this question. And we're going to do a back of the envelope kind of calculation. We're not able to pin down cause and effect between wealth and health, but we'll assume that that is the case because of the historical nature of wealth differences between Black and white communities. The other thing we're not able to do is that, when people come into wealth, for example, if we were to implement a reparations policy, there might be behavioral changes that affect both the trajectory of wealth that's accumulated after that and health as well. So one could imagine that if you have low levels of wealth, you may not take on risky but high reward investments. But that if you were to come onto more wealth, you could diversify in ways that generate additional wealth going forward. So we can't really model a lot of that stuff. We're just going to take the reparations payment as given. But this is the type of stuff that in the future would be useful for people to do in order to get more precise answers to the question, which will motivate the policy discussion and debates. All right, so we're going to do two things. We're going to first say, hey, there's a racial disparity in longevity. To what extent does differences in wealth explain that? And then the second thing we're going to do is say, using the relationship between wealth and health among the Black sample in this survey, let's look and see what happens if we shift the distribution of wealth in a manner that is consistent with reparations. And for that, we're going to use Sandy Darity and Mullins' estimate of about $840,000 transfer, and that would be the amount that would be required to close pre-tax mean wealth gaps in the United States. So that's the number we're going to work with. And in a little later, I'll show you what other policies like baby bonds might do, and that has those transfers are not as large. So in our sample, we have about 7,400 Black individuals above the age of 50. We have 26,000 white individuals above the age of 50. There's, I think some of the differences that we see that speak to systemic discrimination over years is that in the Black sample, you have a far smaller share of folks with some college or above education. And, there's also this gender difference speaking to the fact that there was early mortality, especially among Black men, prior to making it to the age of 50. So that's a limitation of what we do. If you didn't survive long enough to make the study, then, we aren't able to model what the effect of reparations might have done for that person. And so whatever we'll show could be an underestimate of the true impact of reparations. But just wanted to put that out there as a difference. The other thing that's stark is if you look at the distribution of wealth. So here, if you take the entire country, you get everybody's wealth in the HRS, and you put them into 10 equal sized groups or deciles, what you see is that 50% of Black households in the HRS, over 50% are in the bottom 3 deciles of wealth. So this kind of speaks to the 17 cents on the dollar phenomenon I mentioned earlier, but it's a little bit more than that. It's not just even average wealth. What you're seeing is that the majority of individuals are in the very bottom of the wealth distribution, and the lowest decile of wealth, where 23% of Black adults are, is less than about $1,200, and there are some high negative values here too, right? So there's more debt than assets. So that's what we're working with. And so do these differences, what we're seeing here, can they explain the differences in longevity that we see in the HRS? And just to focus you on this table, in this first column, what this number means, 1.26, is that Black adults over the course of the survey period from 92 onwards are 26% more likely to die in any given year than white adults. When you adjust for income by itself, there's still a difference, about 9%. If you adjust just for education, there's a difference about 12%. But then if you adjust for wealth alone, and not even including income or education, the difference is gone, right? So we often think of income-based gaps in health and education-based gaps in health, and to some extent those are there. But I think what they're really speaking to is a wealth-based gap in health. And when you can measure wealth well, what you find out is that simply adjusting for it will remove this correlation between racial group and longevity, right? So we think that this is almost predominantly a wealth story. So that brings us to the reparations pieces of this analysis. So reparations and longevity gap. So let me walk you through this figure. This on the y-axis is the proportion of people who will survive at any given age on the x-axis, right? So you want this curve to be as flat as possible, as long as possible, right? Some people would like it to be indefinitely flat. But there are limits, and so this is what we've got. This line that's out here is for this darker line is for white participants in the HRS, just as is, if we were to plot the survival. So what you can see is at any given age, they are more likely to be alive than the Black participants who have this orange line. And at the place where about 50% of people are still alive, that number is about 83 years for white participant, and it's about 77 years for Black participants. So we're looking at a wealth gap of about, or a longevity gap of about 5%, 5 years. Once reparations are put into place, we get this light blue line, right? If we were to basically take the reparations amount, give it to the Black participants, and reassign the decile of their income that they're in, just doing that, what you can see is that the entire Black-white survival gap is gone. These two lines look exactly the same. So that's the first result. So that seems great. Basically, we're erasing with this size wealth transfer a 5-year difference in longevity. One issue with that is, and I think this is something for the conversation on reparations in general, is that the racial wealth gap, part of it has to do with how much wealth you started out with, right? And that goes back to the days of slavery and early Reconstruction. But it also has to do with how easy is it to accumulate wealth going forward. So there are some challenges. What can happen is that low levels of wealth can explain a lot of what you see, low starting levels. But it's also the fact that there's discrimination in other markets. There's discrimination in education. There's discrimination in labor markets. There's discrimination in financial markets, for example, in home buying. So these are all means to try and access wealth. But if you're investing, what can happen is that because of discrimination, the return to every dollar you invest can be lower for Black individuals than white individuals by virtue of the systemic processes that are happening. And so a reparations policy that potentially does not address the fact that there's still discrimination and this history of responding to Black wealth through curtailing wealth generation might be a kind of a short-lived policy, right? And so Duran and Court and others have tried to simulate this. So in the real world, if we take what we know about discrimination in these markets, and let's say we do a reparations transfer, let's say we did that back in 2020. So the Black-white wealth gap is $1 to $1. So it's gone. If we don't change the discrimination that persists, you see that this wealth gap can just reaccumulate. And it takes like 100 years to go, to 2 to 1 and so forth, but it does continue to open. If we make some small changes, it doesn't open up as fast, but it continues to open up. But if we're able to make it so that investment potential for Black individuals is the same as it is for white individuals, or very close, you actually see that the Black-white wealth gap after reparations can persistently be at a low level, so no gap at all. And this one thing I should mention is that even some will say, why don't you just get rid of the discrimination part of it, and you don't have to do reparations. But a lot of what is happening to generate wealth differences is the fact that the initial differences were so big. So even if you were to make the world less discriminatory now, it would take hundreds of years for the wealth gaps to disappear. So you do need to complement any type of anti-discrimination legislation or policy or so forth with some kind of transfer or some other policy that basically increases the initial wealth of the group. So you need both these things. So for our purposes, we did give the participants in the HRS our simulated reparations. What happens though if we don't address discrimination in other markets? And we do that by basically saying, hey, rather than, we're going to assume that the income level that you attain today and the education level that you attain today, that is what you would attain under reparations because the discrimination in those markets remains. And what happens here is that you can see going from the orange to this light blue line that reparations has a small effect um, on survival. It reduces this gap by about 60%, but it doesn't get us all the way. And so what we take from that is in this, again, back of the envelope calculation is that you will probably have to do some kind of, you probably have to have some complementary policy changes to address discrimination in other markets to get the full bang for the buck if you're interested in survival gaps, racial health disparities, and you're interested in getting the biggest bang from the buck from reparations. So that's what I would take from this set of results. Reparations are not the only policy that's being talked about with regards to Black health. One that has been very popular among Senator Cory Booker, the economist Derek Hamilton, is this baby bonds idea, which would provide infants basically with a maturing asset that is large, and they'll be able to get that investment over the course into adulthood and then take the money and invest it and use it as they see fit. Under some assumptions about what the size of that transfer looks like and how it would be invested, what we can show is that baby bonds, it's not going to close the Black-white life expectancy gap fully, but it would get us maybe 40% of the way there, this policy alone. So what this graph is, we basically took the entire country and in the HRS, and we've shown what life expectancy would look like under different regimes. This dark bar is the current wealth distribution, right? So here, if you're in the lowest decile of wealth, if you make it to age 50, the expected survival time is to age 72. But if you're in the highest decile of wealth, you get to live to age 86. That says nothing about the quality of life or anything like that, but that's a 14-year difference, right? With baby bonds, and this is for all comers, you get to a difference which is much smaller. So here, the bottom group gains a lot, of almost 6 years of life expectancy, and the top group doesn't lose a lot or anything. And the reason for that is that the relationship between wealth and longevity is nonlinear. So it matters a lot if you have low levels of wealth. If you have high levels of wealth, losing some of that wealth is not going to hurt your health, at least as measured by survival. All right, so that gets us to what could reparations do for racial health gaps, and how, the types of things that would be necessary from a policy perspective to really get the most from an intervention like that in terms of our country's health. That brings me to this natural question, which is what can healthcare do? So I'm a physician primarily. I sit in healthcare. My hospital is in West Philadelphia, and I take care of a lot of patients who are Black and white. I can sit and advocate for policies that improve the health of my patients, and so that's one thing healthcare professionals can do. But what about our sector as a whole? I mean, we're very large. We're about 20% of GDP. We command a lot of authority. We have access to a lot of assets and technology. So how can we use that to potentially, address these survival gaps? So with Gina South, who's a colleague of mine, she's an emergency medicine doctor, and George Dallenberg, who's a pediatrician, we wrote a piece a couple years ago thinking about what health systems can do to help build Black wealth. And there's actually a few things we can start doing now that can complement efforts to build Black wealth, like reparations. One is we can improve the financial position of workers. We can try to encourage savings and reduce debt among our workers and patients. We can try to improve wealth through procuring from Black-owned businesses, especially if we serve majority Black communities. And we can look at our own market activities and make sure that we're not inadvertently harming communities and hollowing out wealth by virtue of what we do. And then to the extent that we have expertise, and one of the big things that I worry about as someone in healthcare is that we're entering this space of social determinants of health, but I don't know if we actually know a lot about it in the way that people in other sectors like housing and education and so forth would. And so as dollars come into us to try to do work on social determinants of health, we better know what we're doing. And if we don't, that money is better spent by someone else and somewhere else. So, but what can we do within the expertise we have? Let's talk about workers. We'll go that first bullet point. So this is some calculations I was doing in 2023, and this is healthcare workers. So we have the solid bars are non-Hispanic white workers, and the unshaded bars are workers from Black, Indigenous, and underrepresented communities. And what you can see is that the hourly wage distribution is to the left, or lower wages on average, and at every point in the distribution for workers who are from minoritized groups. And the reason for that is longstanding occupational stratification. If you look at women healthcare workers in particular, um, and you look at the type of work that they do, among lower wage occupations like home health workers, these are critical occupations. We called them essential a few years ago. Among those occupations, 50% of individuals are from these minoritized groups. So this occupational stratification, the wage structure of healthcare, has really important implications for Black workers. And we know that in healthcare, this is the red triangle, your income that you get from work matters for your health, just as it does in any other industry. So if you're in one of the higher earning groups, you do better in terms of your probability of survival. And this is probability of death, so I've inverted it. Whereas if you're in one of these low earning groups, your probability of death is quite high. And the gradient that we have in healthcare is actually wider than the gradient that we have in other industries, right? So what we are trying to intervene on, these social determinants of health, are happening in our walls. And as time has gone on, we have seen this inequality in wages increase. So this was a study that we did looking at what happened when states got Medicaid expansion. A lot of money came into healthcare organizations as a result. And if you were in a high wage occupation, your wages went up after this influx of cash from the healthcare sector. But if you were in the lower wage occupations, your incomes did not go up, and potentially they went down a little bit. Not only that, it's not like you're getting additional benefits. Employer-sponsored health insurance actually dropped for both the bottom two groups of low-earning healthcare workers. It didn't change for high-earning healthcare workers. So as the healthcare sector gets richer, the groups that are capturing what we call the rents, or the pie, it's disproportionately high-earning workers, like physicians. So we have Black workers and tend to be, because of occupational stratification and other discriminatory processes, in lower wage jobs. We know that lower wage jobs are harmful for health, including among healthcare workers, even though they work alongside us all. And then we know that as the pie has increased in healthcare, perhaps too much, the low wage workers are not getting that money. Here's a fourth fact. Medical debt, which is a big cause of debt in general and one that erodes wealth from low income individuals. Healthcare workers have medical debt, right? So it's about, on average, it ends up being about 14% or something of healthcare workers' own debt, or 13% on average. And if you look at Black and Hispanic workers, you actually see that the rates of having any medical debt is about a fifth, versus for Asian and white workers, which it's about half of that, right? So there's a high incidence of medical debt among people who work in the healthcare system. And you can see the amounts of debt on average, those also tend to be larger and largest for Black individuals. So these are all places, I think, that we could potentially intervene, right? So there are increasingly, health systems are trying to build in living wages for low-wage healthcare workers. As part of Penn's strategic plan, that was something that my colleague and I put into our working group, and is now hopefully going to be implemented, that there has to be a living wage for healthcare workers. George D'Alembert, my colleague, is working on medical financial partnerships, where he's trying to work with low-wage healthcare workers and create things like 403B plans, the nonprofit equivalent of a 401k, have access to financial counseling for people, and effectively build wealth within workers through providing access to high investment vehicles, higher wages, and then the type of advice that like I end up getting for free, but everybody should have in terms of how to manage their finances. There's also the communities around us, and I see the effects of medical debt all the time in medical practice. But what we know is that if you look at nationally, and this is different zip codes by their wealth, right? So the highest income zip codes tend to have the lowest medical debt, right? And low income zip codes, like the kind that I take care of, medical debt incidence is very, very high. That's problematic. And that has a lot to do with our market operations, right? We charge a lot of high prices for healthcare. There are a number of hospitals that send bill collectors after patients. And so this can end up, there's uninsurance as the insurance side of the market. Those rates are high, and then public insurance doesn't pay as well as private insurance. And so you have all these wedges where lower income individuals actually face a lot of costs from their healthcare, and after an unexpected hospitalization can hold debt that they did not expect to hold. In addition to those things, when we merge as healthcare institutions and become bigger, we acquire more power in markets, and that market power means we get to negotiate higher prices from insurers. Those prices are passed down to workers almost one-to-one, to the point where, if you can look at here on this graph on the right, after a merger and acquisition, you actually see wages for not just healthcare workers, but everybody in that market fall. So incomes fall, especially for low-wage workers, debts increase, and this is a recipe for hollowing out wealth through activities that we think are part of typical business in healthcare. So those are things that we've long said we've had to really think about hard. And there's federal policy, state policy, and local policy around monopolies and all of this other stuff. There's a movement among hospitals now to stop sending bill collectors after patients. These are all good things, but there are a lot of blind spots like this in healthcare where typical market operations can lead to catastrophic outcomes. The last thing I'll conclude with is, what can we do that's within our expertise? And so one thing I'd like to talk about is with Gina South. We're attempting a study where we're trying to strengthen the neighborhoods around the hospital to the extent that we have expertise, and in what I hope is the most humble way we can, and in a way that has been, I think, in partnership with the communities that we're working with. And this gets to some of the points that Dr. Alberti was making earlier about what is a meaningful partnership and what ends up being extractive. I'll let you decide what you think about what we're doing, but let me tell you about the Ignite study first, and I would love to hear your thoughts. Based on about 10 to 15 years of experiences that I've had and Dr. South has had, and I will just say that Dr. South is a revolutionary in the work that she's doing. And in talking to communities, community groups, we came up with a multi-pronged intervention to try to deal with multiple injustices at once. The two different bins that we focused on were environmental justice and economic justice. Our intervention seeks to green vacant lots in a lot of the neighborhoods that we take care of, engage in weekly trash cleanup, remediate abandoned homes, and plant trees. These have various environmental effects. They're good for property values, and they have been shown to work in these communities and on individual levels without leading to gentrification, making those communities unaffordable for the people that are living there. We're interested in making the community, making the wealth that's there stay there. So that's one piece of it. The second piece of it, which helps ensure that, is to build in an economic justice framework. So we're giving people access to free financial counseling. We're reducing the cost of connecting to benefits that people may want to apply for, but because of stigma or the Byzantine paperwork that people have to go through to get it, they're unable to do it. We provide just a one-time cash grant for expenses or debts that need to just be taken off the plate, and then free tax preparation services so that people can get the tax credits that they deserve. And this comes out of the fact that every year in Philadelphia, about $40 million of benefits are left on the table. And so we want to bring some of that back to the communities where they should go. And what we're doing right now is a cluster randomized trial, where in North and West Philadelphia, we have microclusters that are randomized to this intervention. We have about 600 participants, and we will be starting our end-line data collection very soon. What we did was we got information on everyone. We randomized them to two groups. We've been checking in We've worked with 4 community partners who are well known to people in the community, to the point where one of the community partners didn't get a lot of business from our study because they had such good inroads in these communities. We're working with the West Philly Promise Zone to make sure that we're doing everything in a respectful fashion. And our entire staff is hired from the communities we're trying to serve. And every day they tell us where our ideas are wrong or right or could be better. And the intervention has been molded around the input we've gotten from all of these parties. So we're about to do our follow-up survey. And in a year from now, I can tell you if it worked. We're going to be looking at measures of self-reported health, at crime rates, at people's level of stress, experience of discrimination, property values. But our hope is that a multi-pronged intervention, short of a large transfer of cash, so this is done in a $10 million NIH budget, but short of a large transfer of cash, what can we do in communities to make sure that we can build the wealth that's there and provide the types of services that we all have access to without even thinking about it, but provide them to communities where they may not have had it, to basically keep the wealth in those areas and provide, just a framework for moving forward and onward. And our hope is that whatever we learn, we can take to the city of Philadelphia and cities around the country to say, here's what worked, here's what didn't work. But investing in communities and, in some sense, it's odd that a bunch of doctors and a medical center is doing this, because these are things that you might think the government might do on their own. But nevertheless, this is the reality we're faced, and we're trying to figure out what are the types of things we can do in these communities, in partnership with communities to try to unleash the potential that we know is there. So I'm going to summarize here, and I'd love to take your questions. So basic facts, just the objectives for this talk. The racial wealth gap is large, and without intervention, it has been recalcitrant. And there are just long-standing structural forces and reactive responses to progress that have made it so. And if you look at this gap and you look at the gap in longevity, because we talk about life expectancy a lot, the first thing explains the other. So what we see in terms of health gaps across different population groups, it predominantly or almost fully arises from wealth gaps. And there are policies that can address it. We simulated the effects of reparations. It suggests that it could go very far in reducing these gaps, especially if we pair it with interventions to reduce the possibility of reactive responses to acquiring Black wealth. But it's a lot of work, and it needs to build a lot of consensus. And I think what Dr. Alberti had identified as these different bins of policies, what was in the California reparation report about different types of policies that can help keep the wealth once it's given, that is absolutely, absolutely key for the health piece of it too. And while we're doing this, we can do some things in the healthcare sector right now. We can pay our workers what they are worth, focus within our own walls. And to the extent that we have expertise, we can exercise it in the communities we serve. And where we don't have expertise, we should partner with others, or we should make sure that the funds are going there instead of coming to large hospitals for work that we just don't have kind of the know-how to do. So I'll stop there. I would love to answer any questions you have. I think there's some already. And please do feel free to email me and our group's website, opportunityforhealth.org. We have a whole section on structural racism that you can look at some of the work that we're doing there.
Dr. Venkatramari, I want to thank you so much. It's a great presentation. We do have a number of questions. Carol asked, where will you be publishing these results, or where are they published? And is there somewhere where she can find more information about what you presented to them?
Yeah, sure thing. So the results on reparations and the wealth gaps, those are published. And I can put those in the chat in just a second. The results on the IGNITE studies, those are still, well, I mean, we're going to find out what the results are very soon. So we have about 9 to 12 months worth of re-interviewing participants. There's a whole qualitative study. And then we're starting to dig into the crime data, hopefully in the next couple months. And so those will probably be available only next year. But of course, Dr. Williams, I can send all of that over to you as they happen if you want to disseminate and if you're interested.
That'll be very helpful. Thank you. Thank you so much. I also wanted to ask, how do we assess for health reparations given the impact of social factors, race, gender, and class, labor, that happens as a result? Well, it helps to create shortened life expectancy and longevity gaps for African Americans. I ask this, especially in the case of Tulsa race massacre survivors, which was referenced and mentioned, 100 years or more older, still waiting around. And how does that also compare and contrast with this issue of inheritance, as it's been passed down as a way of generating wealth versus what many African Americans in our families use as sort of a substitute for inheritance, life insurance, the sort of wealth transfer, contrasted with institutions such as Georgetown and others that have leveraged enslaved African Americans as collateral to prop up their institutions, and probably other institutions as well. I know the age of former Pellman attorney, talked about those issues with her lawsuits against Fleet Boston and others. But can you address some of that?
Yeah, so I think that's absolutely, I will try to address all of it. And please tell me if I haven't addressed it. So I think, yeah, so it's, to your point, I think it is very, very, where I start with this whole question is Sandy Darity's work on intergroup inequality and the dynamics of how groups with power keep that power. And so this is a long-standing kind of multi-move type of chess match where for every action there is a reaction. And so some of the comments you made about how there's this persistence with Tulsa, these like discrimination in multiple different sectors, all of that, at various times kind of bubble up to surface as responses to real progress by different groups of people. And it's a testament to kind of, generations of civil rights leaders and community members that there has been the steady march of progress at all in the face of what I think has been at times very well organized that have, that have helped kind of quelch growth in different parts of the country, and that has added up over time. So it's in a simulation, it's really hard to address. The way we tried to do it the best we could is to say, let's say you were to give wealth, that can open up a lot of doors, right? So for people who face barriers in the credit market and they can't borrow against the future, wealth is a way to go get that college education that can elevate their upward mobility, right? Wealth is a way to get that high income job that will allow them to kind of keep a stream of funding and build the wealth that they have for their children and the next generation. So the first way to do it is say reparations alone will solve all those problems. And in a statistical model, you just don't control for education and income. You say that education and income can be anything, and it'll flow from this wealth transfer. And then what does that do? So in that model, we showed that you can erase the entire wealth longevity gap with reparations, right? At least that's the stylized fact of the model with all of the caveats. The types of things you're saying, criminal justice, housing discrimination, credit market discrimination, well, the way we try to address that is to say, hey, those will manifest as lower levels of education and lower levels of income. So let's fix people's income to what they are today in the HRS. So that's saying that reparations is not solving any of the problems that generated those lower levels of education and income. And now what does the wealth transfer do for health outcomes? And that number is less. It narrows the gap less. So that's the way we did it. One could imagine that it's even less than what we estimated because it's such a I keep thinking of this fundamental cause theory that Phelan and Link have, and the idea is that if racism is a fundamental cause of health, there are multiple different channels that lead to worse health for Black individuals because of racism. And any one thing that you try to address, like here's an educational policy that'll fix that part of it, it'll just lead to another arrow coming in to reinforce the disparity that was already in place. And so you can try to adjust out as many of those arrows as you can. What my belief is that a one-time reparations payment will improve health. It is potentially not without, without power that comes with it, without being able to address discrimination in other markets, it's going to be a real problem. In terms of inheritance, one of the interesting things that I've learned in reading Dr. Darity's work is that most of what's happening for wealth transfers is not at the end of life. So it's like what you know, what I like. So if I have two kids, I might try if I can to pay for their college education, right? So what I've done is I've basically invested wealth in their human capital so that they can generate more wealth. So that is the transfer. It's happening when they're 18. So it's a lot of transfers like that. Helping your kid get a house or something like that. Um, those types of things, I think, are the kind of the predominant way that we tend to pass wealth on. They have tax benefits of doing so, and they also hit people at various points in the life cycle. So it's important that we have access to good schools, good colleges, good jobs, whatever. And a lot of that happens in the first 20, 25 years of life. And so those types of transfers, I think, we don't typically record in data, but they're very, very consequential for the dynamics that we're seeing. It's and I think that we all would invest maximally in our children if we could, but if we're coming in with low levels of wealth because of historical reasons, those types of investments are harder to do, and we'll have to say no where we might have wanted to say yes. But if you have high wealth, you never have to say no. So yeah, I mean, the life insurance piece, the inheritance piece, the estate stuff, that matters. But all these little things we do along the way, I think end up mattering a lot more.
Thank you. Chris has a question. Chris, you can unmute yourself and ask a question. Let me actually allow you to do that. All right, go ahead, Chris.
I'm sorry, I didn't mean to raise my hand. Sorry about that.
Oh, that's all right. Another question. Let's see. Yeah, given the data supports reparations. What do you personally find are best responses to people who argue that reparations are socialism, a handout, or racist?
Yeah, I mean, I think the best response, so Dr. Alberti knows this, but one of the things that we're doing in the Opportunity for Health Lab is we're trying to take back this term opportunity at some level. And the idea is this, there are lots of different groups in the United States that have suffered hardship, and the hardships are different. But they all come down to a very similar pathway, which is some people have access to opportunities and they're able to flourish, and other people get stuck because of the systems around them and various other features. And so the ways people get stuck and the ways opportunity disappears or never had been prevalent vary from group to group. And the solutions will look different. And so when we talk about, when we talk about reparations, we talk about them as part of a suite of policies that address opportunity in general. So here's a group of people that for generations did not have access to the types of things that we don't even think about. The institutions that protect my savings that I don't, it's on autopilot. Like it should be like that for everybody, right? So a lot of us have privileges that basic types of things people have lacked for a long time. And reparations corrects to some extent acknowledges and corrects the fact that we did this to a group of people. So we talk about it that way. In parallel, we'll also have a conversation about auto workers and steel workers in the 70s and 80s who, by virtue of policy choices and technological change, lost their jobs that were their path to wealth in the middle class. And at some level, it wasn't done to them as directly as you might say something like slavery. But it's something that they can understand as, wow, that was a force that was beyond my control. And as hard as I'm working, I'm not able to accumulate and save enough to do what I'd like to for myself and for my children. And so we talk about policies that address that type of failure of opportunity. And so our answer has been to put them in an analogy and tailor it and center it around this common mechanism that we think affects all humans, which is that opportunity is important for health. I can't say we've been 100% successful, but people do listen at least to the second sentence. These days, it's easy to lose them at the first sentence after you say reparation. The other thing that I wanted to look up for today, and I didn't get a chance, is that Darity and others, Darity and Mullen, have pitched reparations as something that does not require redistribution. And I'm trying to understand, I think it will involve taking on additional debt of some kind, but I'm trying to understand exactly where that came from. And that would suggest that something like a federal effort will be much easier to sell to people than a state level effort where you have to balance the budget. So that's just another thought. But for us, to the extent that people learn by analogy that they can put themselves in other people's shoes, then we think this opportunity story is central, and we try to talk about all solutions of opportunity problems together, so that we're not that we're showing people that they're related in the problems that they have, and related in the creativity needed to solve those problems.
That's great. Yeah, and I see a comment from Dr. McKay, who will be presenting soon, and she said she believes that, yeah, that's based on MMT.
Yeah.
And so I know that's I think another scholar, Stephanie, I think Kelvin's talked a good bit about the economy in MMT in terms of progressive economic policy. So I think those are great questions, and I think there are other questions. Someone says the 824 million dollars required to eliminate the wealth gap. Is that for every every woman, man, and child? That's the question that someone posed. So
It would be at the level of the household. And I think there's kind of problems with defining households, and that will be a challenge for implementation. For our purposes, one person in each household was surveyed, so we gave it to that person.
Wonderful, wonderful. Well, thank you so much. I think those are the questions that we have. If there are other questions, please feel free to get in touch with Dr. Vinka Tamari. And Dr. Vinka Tamari, I want to thank you so much for your research and your presentation, for a great contribution to this conference. And we look forward to working with you and hearing more about your future research and that from your Opportunity Lab.
Thank you so much. This is such an amazing group. I'm really honored to be here. Thank you.
Thank you so much. And now let me go ahead and introduce our next speaker, who will be presenting. Dr. Leslie Ford is an associate director in the Office of Race and Equity Research at the Urban Institute. She's a sociologist by training, brilliant scholar. She regularly leads and contributes to research and policy-focused projects that explore sources of and solutions to racial inequities. Her research is focused on a range of topics, including philanthropic and federal grant-making programs and practice, economic mobility, and health policy. Dr. Ford holds a BA from the University of Michigan, go Wolverines, an MED in education policy and management from the Harvard Graduate School of Education, and PhD in sociology from Duke University. Dr. Ford will be presenting on the topic, how reparations can support Black health and well-being. And without further ado, I want to turn over the controls to Dr. Ford. Welcome, Dr. Ford. Thank you for joining us, and thank you for your research and your work.
Good morning. Thank you so much for having me. I really appreciate this invitation. And I'm just getting over like a really bad cold, so please forgive me if I am not at 100% energy, but I'm definitely going to try. Let me go ahead and share my slides. Okay. All right. So, good morning. I am delighted to be with you today. As was mentioned, my name is Leslie. I am an associate director in the Office of Race and Equity Research, and I actually lead our office's wealth equity body of work. It's focused primarily on economic mobility and wealth building for Black Americans. And as a part of this wealth equity body of work, I lead our research on Black families and the Black middle class as a part of our Black Family Thriving Initiative. And I also lead our reparations research in our office. So in my view, reparations is a core component of any wealth equity framework or agenda, and it's perhaps the most promising solution that we have for converging or closing the racial wealth gap, and in turn, actually advancing progress on health equity. So before I get started, I wanted to just thank Reverend Dr. Zachary Williams and the rest of the team at the Northeast Ohio Black Health Coalition for inviting me to participate in this event. So before we jump in, I just want to sort of provide you with an overview or a roadmap for today's presentation. It will be a bit more conceptual with some applications that specifically focus on the creation of the middle class and the underdevelopment of the Black middle class. As I go on, it'll make more sense about how this then ties back to reparations and health equity. So across several key outcomes, including health, wealth, education, and life expectancy, ostensibly race-neutral social policies have failed to close persistent racial gaps for Black Americans. And thus, this presentation will provide an overview of both the policy history and some of the present-day applications for reparations for Black Americans in the United States. We'll also provide an overview of the development of the middle class and the underdevelopment of the Black middle class. We'll also examine some of the historical harms that Black Americans have experienced and the structural factors that contribute to harms today, and describe to some extent how these harms contribute to health inequities in the US and the potential for reparations to improve health outcomes and well-being for Black Americans. So before I jump into this presentation, which connects to the foundation of a national reparations research agenda that our team published last year, I just want to sort of provide like a bit of context for what led me to an interest in reparations policy, and then how this connects both to my primary scope of work, which is, again, wealth equity, economic mobility for Black Americans, but then is also related to some other work that I've been able to do in health policy. So my road to sort of seriously engaging with reparations, both as a research and a policy area, is somewhat of a winding one. So I started my career in Detroit, which is the city I grew up in. I was a classroom teacher. My mother, my grandmother, my aunts were all educators. And so I, for a very long time, believed very, very deeply in education as a tool for upward mobility. And I still do, to an extent. But the longer that I stayed in education, in classrooms, in neighborhoods, and in community, the more I realized, of course, that access and opportunity was not universally distributed in every city and in every community, and certainly not across racial and ethnic lines. So after pursuing graduate studies in sociology and working as a researcher in DC for a few years, I just became more convinced that the inequitable distribution of wealth was more consequential for the educational and the social and all the health-related outcomes that I've been studying. So after a couple of years of work or research on reparations, I published 2 briefs at Urban, which I'm happy to share after this presentation. So the first brief traces the policy history of reparations in the US, and it documents the policies that helped to enable wealth building for some Americans, in particular white middle-class Americans. And it also documents the exclusion or the missed opportunities to actually pay reparations to certain groups in the United States, particularly Black Americans and formerly enslaved people. And then the second brief outlines a framework for a new reparations research agenda that, if it was fully supported by social scientists, could help to advance progress on the study of reparations across several domains, including health, wealth, education, and overall well-being, which is, of course, our focus for today. So I just want to sort of emphasize that I do come to this work from the perspective of economic mobility, financial security, wealth building, and we'll later make some connections to health equity and how this relates to health equity outcomes. So the ways that Black Americans from enslavement through Jim Crow and through American apartheid today have both contributed to and also been exploited by the US economy and have been locked out of wealth building opportunities and also had their wealth stripped through very targeted policies and practices. The only policy solution that has the potential to close or remedy or rectify those gaps are reparations. So what we know is that traditional public policy, even race-conscious public policies, have not reduced inequities or helped to converge the racial wealth gap for Black Americans. And in fact, research has shown that even one-time cash transfers will not converge and ultimately help close that racial wealth gap. So there have to be some other policy solutions and ways that we think about this. So I'll say this and then move on. So reparations presents a possibility that can dramatically improve the economic and social conditions of Black Americans in the US. And the act of economic reparations could improve or would improve progress on improving health outcomes and improving longstanding health inequities for Black Americans in the US. So I think many folks in this room will be familiar with, the United Nations framework, and I share this to just describe it as it's the foundation for our research approach at Urban. So our work is guided by the United Nations 2005 resolution on reparations and its 5 standards, which includes restitution, compensation, rehabilitation, satisfaction, and guarantees of non-repetition. And one consideration that we are making at Urban in our work is when we think about these 5 standards, do we believe that these standards adequately cover and satisfy the need for reparations and reparative efforts here in the United States and for Black Americans? And is it possible that there are additional standards that could be added or should be added to conceptualize the unique or distinct case of the descendants of enslaved people and Black Americans in the US? So in addition to our work drawing on this United Nations framework and our work centering on these 5 standards for reparations, we also take a sort of comprehensive approach to both compensatory and transformative approaches. So in addition to the international standards that I just mentioned, we also integrate 2 longstanding approaches to repair. So following the very long history of compensatory reparations, which typically refers to monetary compensation, meaning that scholars should examine the role of both the federal government and private institutions, including universities and corporations, and others who have benefited or profited from enslavement or other systems of either segregation or exploitation in the US. We also consider the role of transformative approaches, and transformative approaches account for the psychological, social, and emotional harms that Black communities have experienced. And when taken together, it's my belief that health equity sort of lies at the intersection of both the compensatory and transformative reparations approaches. So there are, of course, the need for monetary forms of reparations to advance progress on health equity and to address longstanding health disparities. But there's also a need for, additional approaches or interventions that account for the psychological, the emotional trauma, and the harm that have been caused to Black Americans over several centuries. So I just briefly wanted to share a slide that shows some of the past federal reparations proposals. My apologies if this is small. Again, really happy to share it at another time for everyone's review. We selected just 9 proposals dating back to 1865 that either called for reparations for an individual, a community, or a group. So dating back to 1865 up until 2021 with a specific request that was put forth on behalf of Black servicemen and servicewomen who were excluded from the full benefits of the GI Bill. So I just want to note that, of course, this call for reparations, both compensatory or monetary and transformational, again, addressing deeper sort of psychological and emotional harms are not new ones, but they, started with very much the end of enslavement in the US. Okay. So now I'm going to, as I mentioned earlier, like a lot of my research focuses on economic mobility, financial security, and wealth building for Black Americans. And recently we launched a new initiative that focuses on the Black middle class. And part of the reason why we thought that this was such an important, topic to undertake, and how I will, also tie this to reparations, is because, in popular discourse, a strong middle class is sort of like one of the hallmarks of American society, and it is something that individuals aspire to be a part of the middle class and to reap the benefits of middle classness in the U.S. And so I'll just use the development of the middle class in the United States as an entry point to understand the case for reparations for Black Americans, and then tie this to the potential of wealth equity to advance progress on health equity. Okay. So what does it mean, or what has it meant to establish a middle class in the United States, or what was required to do so? So I won't trace the history of the Industrial Revolution. I'll just briefly mention that, as many of you know, the federal government established several proactive policies that helped white Americans build wealth in the United States. So that includes everything from the rise of union formation and participation, of which many early unions, African Americans or Black Americans, were excluded from full participation and thus had to form their own unions in many of our industrial cities. Another targeted intervention that was designed to support the growth or the development of the middle class is the 1944 Servicemen's Readjustment Act, which is widely known as the GI Bill. This legislation gave returning World War II veterans access to a variety of benefits to help them transition into civilian life and compensate veterans for their service. The bill also enabled Americans to build wealth and helped contribute to the development of the middle class through the 20th century. And it's just important maybe just to mention that the GI Bill, of course, is what helped, or which granted veterans education as well as housing benefits. So by the 1970s, nearly 60% of all Americans in the US were considered to be middle class. And at that time, being middle class meant owning a home, having a good job, having a steady income, and the ability to plan for a future, including retirement. So at the same time, the federal government in the US was helping to enable the development of a middle class. There was a simultaneous underdevelopment of the Black middle class. So for decades, federal policies were designed to support, again, middle-class white Americans. So Established in 1934, the Federal Housing Administration accelerated patterns of residential segregation by refusing to insure mortgages in and near African American neighborhoods. So while Black Americans were locked out of home buying in segregated, mostly white neighborhoods, the federal government helped to subsidize builders developing new housing for white Americans in America's suburbs. Thus, Black Americans were not only locked out of opportunities for home ownership and wealth building derived from ownership, but the federal government developed a targeted intervention to help white middle-class Americans both attain home ownership and build wealth. So similarly, unions, which helped many white Americans attain middle-class standing, excluded Black workers from their ranks and forced Black laborers into much more dangerous, unsafe jobs. And also, while the GI Bill helped to afford white Americans clear pathways to the middle class through homeownership and education, the GI Bill excluded Black veterans who served their country and came home to a segregated United States. So just briefly want to touch on what the middle class is like today and how we define middle classness today. So I just want to sort of reemphasize, like why class analysis, like why does middle classness matter for a discussion of reparations and health equity? So class analysis is important, again, because the middle class is seen as or referred to as like the economic engine of this country, the backbone of America. We also know that some of the benefits of being middle class include higher levels of education, the ability to participate in a more skilled workforce, economic productivity, and expanded investment in public goods, including education, healthcare, and infrastructure. Most importantly for this conversation and this discussion of reparations is that the obstacles faced by the middle class or by middle class families helps to inform how community leaders and lawmakers respond to the needs of this country, which is important, of course, for a discussion of health equity. So I just want to share just a couple of data points about middle classness today. So although the term middle class is generally understood in certain contexts, there is no consistent definition for what that means. And there's no consensus among researchers of who is considered to be middle class. So a 2018 study reviewing 12 income-based measures of the middle class found that a household with an annual income of between $13,000 and $230,000 could constitute the middle class, depending on the definition, which we all know is like much too wide of a range to conceptualize the middle class in the United States. So today, middle class generally refers to people who have higher levels of formal education, post-secondary degrees, white-collar jobs, middle-income earners, and those who own certain assets like a home. So though homeownership is sometimes considered, wealth-based definitions are less common among defining the middle class. So all of this is to say that many of the traditional markers that are associated with middle class status don't often apply to Black families in the same way, or aren't always enough to secure financial well-being or middle class standing. So there are still some, many and pressing challenges that we hear about often facing middle class Americans. So the middle class has contracted over the last 40 years. The costs associated with being middle class in America have increased significantly while wages have remained stagnant. And this experience is particularly acute for individuals and families with low levels of wealth, as is the case for many Black Americans, relative to white Americans in this country. Okay. So I just want to, before I move on into the section that focuses on the role of wealth in advancing health equity, I just want to note, I mean, as you'll probably hear throughout today's presentations, that there are several existing policy interventions apart from reparations that exist or that have been implemented or tested to promote wealth building and help to close the racial wealth gap. So it is widely known, excuse me, that Black families have made significant progress over the last 2 generations in education and employment and other measures associated with middle classness. One of the biggest challenges is that Black Americans, even those who grow up middle class, are less likely to experience upward mobility and are more likely to experience downward mobility as compared to white Americans. So there is some difficulty in attaining a certain class position and maintaining that and being able to pass that down to your children. So that's like one challenge that Black families are facing. And also, there's, in addition to reparations, there are other policies or programs like the worker tax credit, a tax credit for first-time home buyers, paid family leave, child savings accounts for college, and baby bonds that have the potential to help Black families build wealth that can help them sort of weather like an economic shock or an unexpected expense, and most importantly, be positioned to pass this wealth down intergenerationally. Okay. So now I'm going to finally transition into the role of wealth in advancing health equity. So as many of us know, and is going to be again mentioned on this during this event several times, the American healthcare system is beset with inequalities that have a disproportionate impact on people of color and other marginalized groups. And these inequalities or inequities contribute to gaps in everything from health insurance coverage, access to services, and health outcomes. And it's well documented that Black Americans bear the brunt of these challenges. So in a recent research project that I conducted on the diversification of the healthcare workforce, we wanted to better understand, what was needed to help ensure that more Black Americans and Latinos pursued careers in the healthcare profession. So we know that concordance matters for the experiences of Black men and women in pursuing high quality healthcare. We also know that there are many barriers that prevent Black Americans from pursuing post-secondary education and thus pursuing careers in the healthcare field, especially careers that require more education and more training. We also know that Black youth are more likely to attend more racially segregated and less well-resourced schools. Thus, students who otherwise may have had an interest in or the aptitude to pursue careers in the healthcare field, including medicine, nursing, public health, health policy, et cetera, are less likely to do so because of the poor quality of their K-12 schooling. So in our research, and through speaking with nursing and medical students across the country, we identified several steps that could be taken to help just on one dimension of health inequity, which is the diversification of the healthcare workforce. There are several steps that could be taken to improve or increase the numbers of Black American and Latino nurses, doctors, and other healthcare professionals. And those steps include the need to strengthen the quality of K-12 education across the board, but in particular for highly racially segregated schools. We also identified that Black students need earlier exposure to the healthcare professions through shadowing, mentorship, and internship opportunities. There's also a real need to increase the number of scholarships and fellowships and other funding that is available for everything from exams and boards to helping ease the burden of pursuing professional training and credentialing for students once they enter nursing school or medical school. So in terms of how this study, the diversification of the healthcare workforce, and these steps actually connect to reparations, both several scholars and corporate leaders have proposed that there is a role not only for the federal government to play in paying reparations, but there is also a role for some of the nation's largest corporations and universities to play in supporting what is called reparative capital. So the idea is that the private sector, again, universities, corporations, et cetera, could help to strengthen the healthcare infrastructure in communities comprised of people of color. They could also equalize things like broadband access. They could help to improve the quality of public school education and funding STEM education at historically Black colleges and universities, which could help to increase the number of Black students, again, pursuing careers in the health profession. And just as an aside, one thing that I haven't touched on in the context of health equity and the distinction between compensatory and transformative reparations and the role that a diverse set of stakeholders, again, ranging from the federal government to corporations and universities could play, is that whether we are talking about an individual payment or an individual scholarship, or whether we're talking about investing in improving the quality of mental health services or community health clinics, or helping to support getting better and more qualified physicians into spaces where there are higher populations of Black people, there are reparations has the potential to fund and test and develop models for what this could look like in different communities across the country. And ultimately, whether we're talking about compensatory or transformative models of reparations, we're talking about financial resources, we're talking about coordination, we're talking about buy-in, and we're talking about directing resources into the communities that need them the most. And in some ways, this may require some sort of like public-private partnership. It may require us engaging philanthropy to think about the sources of their own endowments and the extent to which they're willing to leverage their research or their resources rather, to make investments in reparations, and what this may look like for funders, whether it's corporate, private, family, or other. What could these reparations look like at the local level, a place-based level, or perhaps in the context of some sort of like national trust or endowment? So I will go through these next couple of slides pretty quickly because I just want to leave enough time for comments or questions or reactions. The question that we sought to answer with the first brief that we published on reparations at Urban last year was how can social science research inform a national reparations agenda? And the first publication that we published, and again, I'm happy to share these for the attendees and if other panelists might be interested, the first product that we published was The Next Reconstruction, Examining the Call for a National Reparations Program. And essentially, we went through all of the post-enslavement federal policies, analyzed where those policies fell short, and how researchers and advocates can use the United Nations standards, which I outlined earlier, to guide the development of new reparations policies and approaches. And the brief also makes recommendations for how we could strengthen the research and policy infrastructure around reparations to ensure that it has the appropriate funding, support, rigor, et cetera. So a couple of the key points that came out of that publication were, like if we are to proceed with a reparations commission model to ensure that it has the capacity to do multidisciplinary human rights focused research, to establish a rigorous approach to reparations research that builds on existing models. So making sure that our approaches are not duplicative of existing research, but that we're actually building on the wealth of research on reparations that exists. We also discussed what it would mean to strengthen the research and policy sector's capacity and infrastructure to study reparations. So not making this just a responsibility of like university academics or professors, but seeing how social and economic policy research centers could and should also be doing this work. And then the last point was that we wanted to study local reparative initiatives to learn lessons that could help inform a national reparations program. And then lastly, the second publication that we released last year is entitled How Social Science Research Can Inform a National Reparations Agenda. So again, it describes the two forms that reparations most commonly takes, compensatory and transformative. It outlines a set of research questions that, if answered, could help to make progress on reparations to both close the racial wealth gap, but also to address health inequities, well-being for Black Americans, et cetera. And so some of the key points from this brief were just that there are roles for social scientists to play in conducting additional research to advance progress on a national reparations program. And while a lot of public attention is focused on the role of the federal government, there is a huge role that corporations and private entities could also play in reparations. And again, we've outlined a set of specific research questions and identified which disciplines could contribute to answering those questions. So as I mentioned earlier, there's a role for corporations to play in investing reparative capital. There's a role for corporations to play in funding Black-owned banks and businesses to strengthen the community and sort of economic development infrastructure and organizations that exist in communities already. And that there's this huge role for social scientists to play in examining the role of US corporations and nonprofits that have played in accumulating wealth in the United States. And then lastly, and I think this is incredibly important, kind of going back to the earlier point about the development of the middle class and then the corresponding or concurrent underdevelopment of the Black middle class. A recent publication from the American Academy of Arts and Sciences outlined an agenda for advancing a people's first economy. And in section 7 of the report, they recommended that Black World War II veterans and their descendants receive the housing and education benefits that they were denied under the 1944 GI Bill. And this bill was first introduced in 2021. And I think that there is like a tremendous opportunity for researchers and for the federal government to use Black veterans as, a case study for what reparations could and should look like in this country. So I am going to stop sharing there and I welcome any questions.
Thank you so much, Dr. Ford. Appreciate your presentation and your research and expertise, and know you're feeling under the weather, so hopefully you're going to feel better soon. Well, thank you for coming forward and presenting. And just want to say too, it's good to see that Buckeyes and Wolverines can come together for a common cause. So we're going to build some unity here today. So appreciate that. We do have a couple comments, and after your presentation, the question and answer, we'll take a brief 10-minute break and then come back and allow you to stretch and grab some water, maybe a bite to eat, and we'll continue. But Genevieve asks, well, she makes the point, discussion seems top heavy and a lot of the conversations around, a lot of these topics. How do we, attend to that and make sure that particularly Black masses, Black working class, their voices are centered, and they don't get lost in the shuffle, that more, it continues to be a practical issue that localizes and focuses attention where it needs to be most. Can you address that? And she asks, has any academician done research regarding effective remedies for those who have sought to operationalize or use the Black masses for their gain? So.
Dr. Williams, do you mind repeating your first question?
Yeah. Okay. One of our participants, Genevieve, asked, a lot of times these discussions are often considered top-heavy conversations. And there's been a considerable good bit amount of work done, on the subject of reparations by a number of different, groups. She asked the question, how, can we make sure that this, issue continues to focus on how Black working class and Black masses of Black people have been affected, so that, their thoughts and concerns and issues continue to function as the face of the issue. So sometimes I guess there's the issue that it can get lost in the shuffle, and that we continue to remain focused on, keeping attention centered on those who've been most affected. That's what she's saying.
Sure. Thank you so much for that question. So I think that there are a couple things sort of that immediately come to mind. One is I've been really encouraged by the ways that individuals, groups, communities have embraced learning about reparations. Like, I feel like even 5 years ago, if I interviewed someone about economic mobility or wealth, it was very unlikely that an individual mentioned reparations as a potential policy solution. Whereas now I feel like it's more sort of just part of our lexicon. It's just sort of in the same way that we talk about like home ownership, we talk about reparations, which I think is really encouraging. And I think that has something to do with like a few things. One is there has been, this huge rise or this increase in the number of formalized reparations task forces and commissions across the country that are focused on documenting what the historical harms have been in particular localities or have been perpetrated by particular municipal governments. And I think that as residents of particular cities are becoming familiar with these task forces and commissions sort of popping up, those task forces are also being called upon to have engagement with community. And it's sort of it is expected, or it is sort of, it is required that municipal governments, that city council members, that reparations task force folks are engaging with and being responsive to the needs of the constituents that they're serving, or that the people who are living in communities that would potentially be beneficiaries of reparations, that their input is actually heard and documented and valued. And I think that that's one part of this. Another part of this that is not lost on me is that, it's one thing for reparations, like researchers or social scientists who are interested in reparations, to sort of step into this space and conduct research on the topic. But I think it's also incredibly important to acknowledge that there are movement leaders and there are advocates and organizers who, for decades, have sort of been on the front lines of the reparations movement and have been calling for reparations, whether it's part of like in Cobra or these other like really, really important organizations. So I think it's important to also give a nod and respect and acknowledgement to those organizations for sort of being trailblazers and pointing us, away from, I guess, the ivory tower and pointing us back to community.
Thank you. Adrian has a question. Adrian, if you can ask your question, and then I know Genevieve has a follow-up question. Adrian?
Yeah, can you guys hear me?
Mhm.
Yeah, so
Yes.
I thank you for your topic that you discussed. And I think in thinking about the wealth accumulation, particularly in like whiteness, they're generally, and I guess my focus a lot of times is how do we connect these conversations to people that are not within academia. So like some of the language we use sometimes, if we're thinking about Black communities that are not necessarily educated in the realms of which we are, how do we get these same conversations to them to help inform what we're doing right now? As you mentioned, like going to activists who may not have the legitimacy of going to school or going to college and having those credentials, but they are actively doing that work. And then how do we, I guess, start decolonizing people's minds, even ourselves in academia, in regards to understanding like white wealth is not something that has ever been accumulated. It has been something that has been inherited based off of the backs and the blood of Black people. And how those lies continually being perpetuated are a lot of what we face when we talk about reparations as a whole, because they kind of go back to those lines of like the bootstrap mentality of just pick yourself up and you would get to where we are as white people or Black people in that sense. How do, I guess, you navigate those different conversations in academia so that they are also addressed by the people that are in those margins?
Thank you for that question, Adrian.
Thank you for that. So I hope that this does not like undermine your question, but I hope it answers it, and I'm happy to follow up, Adrian, if it doesn't. So about a year ago, a colleague of mine and I at Brookings started talking about what could we possibly do with like the research that we're developing, just so that it doesn't sort of like live on a website and it doesn't that it actually has some impact on advancing policy progress or openness or the consideration of reparations as a solution, like all, shortly after one of our briefs were published, an organization called Liberation Ventures, which helps to fund reparations organizations and movement organizations, sort of came to us and asked if we might be interested in starting a reparations research consortium. And the idea of the consortium is to actually take the research out of the control of sort of traditionally trained social scientists. And the consortium model is designed to bring in movement leaders to actually work side by side with social scientists as we're developing research questions, as we're developing research design. So the idea is to be responsive to actually what's happening in communities. So hearing like what's happening on the ground in, like in Detroit or in Evanston or in Asheville or in another place that is mobilizing around reparations, And then how can we design research studies or answer questions that actually help the movement leaders advance progress on their goals? So as opposed to coming up with a set of questions on our own, we're trying to do that more in partnership with organizers, with activists, and with movement leaders. So I think that that's one step that we've been engaged in for the last year, to try to be responsive in that way.
Thank you, Dr. Ford. Genevieve, you can go ahead. You can ask your question, Genevieve. I'm trying to get Genevieve. Genevieve, are you there?
I'll try to get through this just briefly. Can you hear me?
Yes, thank you.
You can hear me? Okay, very good. I don't think that we here in Cleveland are in particularly Black women, are in any better position than the people in Palestine or South Africa under apartheid. We have suffered every egregious wrong you could possibly imagine. And I've written a reparations proposal that I would like for you and Dr. Taylor, Dr. Zachary to have. And the team, I sent it off to Yvanka yesterday. I disagree with the whole notion of incremental kinds of remedies to address the problems that we're talking about, because they are so horrific. The levels of poverty, the treatment of women and children in this country. Homicides, just everything. It's terrible. And so I wholeheartedly disagree with the notion of incremental remedies. I think that it is absolutely imperative that we identify and address these issues and go full on to the United States Capitol to confront the people who are responsible for these conditions historically and currently, and that we make demands, concrete demands, because they are not being addressed in the communities. That these levels of poverty, this harm to children, be addressed immediately. The way they're doing Black men, the incarceration levels, the conditions in these public schools and the charter schools, which are no good and don't address and effectively build up Black people and Black communities. I think this has to be addressed immediately. It is horrific. It's gone on forever. The levels of unemployment, the wage differentials, the poverty is incestuously, parasitically obscene. And so, it's one thing to pontificate about what needs to be done and to go over. And I think the research is important, but in terms of incremental solutions to address these problems, that's absolutely ridiculous at this point. This has been going on. We've had 250 years of chattel slavery. We've been under segregation and Jim Crow. We've gone through civil rights, a failed Reconstruction effort. And so it's absolutely imperative that something be done, and soon.
Thank you so much for sharing that, Genevieve. We appreciate you and the great work that you do in Cleveland and the way in which you shared that. So Dr. Ford, can you speak to that?
Yeah, absolutely. Thank you so much, Genevieve, for sharing. And, I can hear obviously the conviction and the pain and the emotion with which you carry this. And I think it's important for us to acknowledge, not just the sort of intellectual component of this or the data points or the charts and the graphs, but the lived experience and the impact that this has had on generations of Black folks in this country, and that the call for reparations is not, just some sort of trite ask for monetary repayment for something, but I mean, it is a debt that can't, be repaid, but there is some repair that can be made. Yeah, and so I empathize with your pain and share your sentiment about, just what has happened, for centuries in this country. And I agree with in your sense that there is, urgency around policy and other action that could and should be taken now.
Thank you, Dr. Ford, and thank you, Genevieve, for that question and for sharing it with us. I think that is reflective of how many people in our communities feel. And with HR 40 that has been presented to Congress for the last, 40 or some odd years, from the late John Conyers to now the late warrior woman, Congresswoman Sheila Jackson Lee. It still has not, come up for consideration, although there was a significant conversation and debate discussion last year with hearings and the like, but, time is of the essence. So we thank you for that. And also just want to lift up another question before we take a break, and just allow people some time just to, to rest and to recharge. Former Ohio State Senator Nina Turner, now senior fellow at the Institute on Race, Power, and Political Economy at the New School, published a piece, I think yesterday or so in Newsweek, entitled "Madam Vice President, Want Our Votes, Put Reparations on the Agenda." How do we, because we have the local commissions to talk about, how do we give fora, on the local, state, national level for passion, for feelings, for frustrations, for, this is again what Charles Henry called long overdue, to get the attention of folk to move from feeling and frustration to actual policy and law, and getting this done, like, was said the other day, I think in Detroit by the vice presidential and the vice presidential nominee and of course the presidential nominee for the Democratic Party. How do we address that issue? If you could speak to that to some to some help. Yeah.
So, I mean, two things sort of immediately come to mind. I think one is like really, really obvious, which is, so there was legislation introduced both in the House and in the Senate. So there was HR 40, and then I believe it was S40. I believe Cory Booker introduced S40, which is the Senate companion to HR 40. And I think that there's maybe two things that just sort of come to mind. Like one, I think that we need to call on our current representatives and senators to support the introduction or passage of this legislation to help form a commission that could then lead to the study of reparations. And I think it's just maybe just a reminder that I think a lot of attention, and rightfully so, is placed on our presidential candidates, but that we are also, voting for other offices and putting people in place who, have a responsibility to be responsive to our concerns as constituents. And I know that there are other more sort of coordinated efforts that are, moving forward or making progress on demanding the creation of a commission at the federal level. And then there are other folks who want to move in a different direction and don't feel like the federal commission route is the correct way to go. So I think we need to maybe be open to some alternatives.
Thank you, Dr. Ford. I think Adrian has one other question. If you could ask, let's see.
Yeah, I'll make it quick.
Yes.
So it's just more of a statement, I guess, because I know Dr. Ford talked about, I guess, the research in a general sense, looking at the federal ways in which reparations happens. And I think part of that nuance is understanding that a lot of violence that has happened to the Black community. Can you guys hear me? Oh, can you hear me? No? That Genevieve mentioned earlier in regards to like Cleveland is that there's a lot of state violence that continues to happen, and even at the federal level. So if we think of like the Black Fearless Fund that was targeted by a white organization and then targeted by the government in regards to giving Black grants to Black women to help like decrease some of these equities. I guess, what are your suggestions on trying to make initiatives at a national level, but still acknowledging that state violence happens and it is perpetuated through all of these initiatives as well?
Mm-hmm. That's a good question. I'll be really brief. I think I get excited about the potential for local reparations initiatives or conversations about repair at the local level around helping to build a culture of reparations. And I think that it is important to document the historical and present day harms at the local and at the state level. The only thing that concerns me is the extent to which local and state governments actually have the resources to pay reparations to individuals and families that are living in, particular cities or states. And maybe it's just something that I need to learn a bit more about, but it seems to me that the federal government still has the resources or the ability to actually pay the debt that is owed. So I think it's just sort of a thing that I sort of go back and forth on.
Thank you so much, Dr. Ford. We appreciate your presentations. We appreciate everyone who's asked questions and thoughtful questions and interfacing and interactions. Thank you all so much for your passion and your attention to these very vital and crucial issues. And thank you, Dr. Ford, for weathering through and pushing through to offer your thoughts and research. And we certainly want to continue to partner with you and everyone else, the scholars on the panel, and continue to build more, momentum on these issues, so we can actually get more material things done and correct a lot of these generational issues that again been long overdue. So, thank you so very much. We appreciate you. Now I want to give those a break if you need it. Since Dr. McCasey, we want to appreciate and respect your time. Want to introduce you, and if you need to take a break or take a stretch, get some food, recuperate, for recharge, then that's fine. We'll try to take another break maybe after Dr. McKay's presentation, but we want to go ahead and present you because I think it fits well with questions that have been asked by Adrian and Genevieve, thoughtful questions, passionate questions, questions of heart and head and spirit. So let us introduce Dr. McKay. Dr. Sally McKay is an assistant professor of social medicine at the University of North Carolina at Chapel Hill. and core faculty in the UNC Center for Health Equity Research. The title of Dr. McKay's presentation, Mass Incarceration and African American Health, the Case for Reparations. And I would say when I came across Dr. McKay's work and interface with her, I mean, just enthused to present. And I was grateful to be able to find that someone in the hallowed halls of academia was doing research on the link between these subjects. We know about Ava DuVernay's 13th and the work of a lot of activists on the local level, local, state, federal level to get attention to those who've been incarcerated, their families, and how they have been adversely affected. But to link this with reparations, of course, it's happened in a number of places like Chicago and the like, but to talk about it on a more comprehensive scale level, certainly grateful for you, Dr. McKay, and looking forward to hearing your presentation. And without further ado, let me turn it over to you, and then we look forward to the questions and answer and the exchange and dialogue that will come after that. And then we'll take a break after that, your presentation. Thank you so much. Thank you, everyone.
Thank you so much. I'm so grateful to you, Dr. Williams, for inviting me here, and to Dr. Williams and Dr. Hall, and really all of you connected to the Northeast Ohio Black Health Coalition for the powerful, amazing work you're doing, and also to each of you who's present here in this Zoom room. I believe several of you are, like me, beaming in from the path of a hurricane today. I think it does show, as Dr. Williams commented, the deep heart and passion that is beneath this work for so many of us. So I'm just very honored to be part of the conference today, and really and truly humbled to be speaking alongside some absolute powerhouse thinkers and change makers in our shared work here for health justice and reparations. There are still many spaces I'm in where maybe we're beginning to talk about ending mass incarceration, but we're never talking about making right the massive damage that's already being done. Spaces maybe where we're ready to talk about racial justice light, about diversity and inclusion, or about how I own my white privilege, but we're not ready to talk about returning what's been taken. And sometimes we're not even ready to stop taking it. And that's why it is so especially good to be here with you all, to be here together in this moment in history and in this conversation that is so urgently necessary for all of us. You've already heard from the three brilliant speakers who preceded me why reparations deserves a central place on a 21st century public health agenda. I'm going to pick up on some of the threads they have begun, and also on some of the threads that have come up in the Q&A conversation we just had a few moments ago, and use my time with you to drill down into the precise case for reparations for racial harm in one specific area of government wrongdoing that I think really helps put the broader idea of reparations and health justice for Black communities in context, and tells us something we desperately need to know about the scale of ongoing racial harm in the US. Mass incarceration has brutally impacted Black health and well-being in America. And because of an abundance of rigorous public health and social science research on mass incarceration, we can actually quantify many of those impacts in dollar and cent terms. The spoiler alert here is that the magnitude of this number, larger than the GDP of most countries in the world, will be a shock to many people. But it's important to look at these numbers so that we truly understand the scale of harm that our governments have done in Black communities, even in just this one way, even in just this 4-decade or so period, so that we know what reparations can and what it must redress. Before I dive into that, just a quick note about language. I think all of you in this room probably already recognize race is not real, but racism certainly is. I'll be using the term white in my comments today as a shorthand for people like me who've been racialized as white, who've tended to benefit from mass incarceration. And I'll use the term Black to refer to people who have been racialized as Black and who've been disproportionately harmed by mass incarceration. Hopefully, we all recognize that neither of these terms does a great job of representing the people to whom it refers, and beneath them is a huge diversity of lived experience that I don't want to flatten or homogenize. My goal is to be as precise about the roles our current system sets out for us as possible, and as clear as possible about what's been taken from whom, so that it can be made right. Making it right in real and material terms would do us all a world of good. But we have much work to do before all of us will fully comprehend the vastness of racial harm in the US, particularly when it comes to ongoing legally sanctioned harms like mass incarceration. Decades of social scientific research established what many folks in this room already know, that mass incarceration has effectively perpetuated the social, political, and economic exclusion of Black Americans. The harms of racially targeted mass incarceration cluster according to the life cycle of criminal legal system contact, that is, where it meets people along and through the life course, as well as each of the ecological levels at which that contact reverberates. The criminalization of children, the perpetual punishment meted out to convicted adults, the negative effects on the children and families of those adults, the collective damage sustained by hyper-incarcerated communities, and then effects on racial disparities at the national level. These impacts have been very extensively researched by me and many others, and it would be dizzying to try to go over that evidence in its entirety. So I'm going to focus on two examples before I zoom back out to share all my numbers with you. When we talk about mass incarceration and health, I think many of us think first about crowded prisons and their implications for infectious diseases like HIV or COVID-19. And then maybe we think next about the accelerated aging or weathering that happens to people who serve long prison sentences, the high prevalence of chronic diseases, the extraordinarily high mortality that people face after they're finally released from prison. Those impacts are incredibly real and important, but in hopes of conveying just how broad and how deep are the impacts of mass incarceration on Black health and well-being in the US, I'm going to touch briefly on two maybe less expected examples. First, impacts on Black children's health. There are two distinct pathways for these impacts: the mass scale incarceration of Black parents, which has made the experience of incarceration for children in low-income communities almost a matter of course for many Black children, for Black American children alive today. Their chances are about equal of having a father who has spent time in prison and a father who's completed college. This absolute racial injustice also infuses childhood in the mass scale criminalization of Black children themselves. And each of those two pathways, the mass incarceration of Black parents and the mass criminalization of Black children, including through the school to prison pipeline, they each have distinct and devastating impacts that have been quite conclusively established. And here I am talking about very rigorous causal research. We know from causal research that mass incarceration is a major driver of Black-white disparities in infant mortality, in child internalizing and externalizing problems. So these are things like children's depression, anxiety, aggression. We know it's a major driver of Black-white disparities in childhood educational engagement, attainment and achievement, and in childhood homelessness. And then we also know that parental incarceration in particular puts Black children at elevated risk of childhood head injury and child maltreatment. What do these childhood impacts have in common? Each of them, each and every one of them, has its own consequences that reverberate for decades throughout the life course. To take another, maybe somewhat less expected example, let's talk about impacts of mass incarceration on women's health. Now, Black women have absorbed an untold burden from mass incarceration. And I'm not just talking here about Black women who have been criminalized and caught up by the system themselves, but by the many, many more millions of partners and mothers of incarcerated men on whom so many of the burdens of mass-scale jailing, imprisonment, and community reintegration have been displaced by the government. Mass incarceration has, in fact, fundamentally reshaped the nature and the magnitude of what is asked of Black women in uncompensated domestic labor and family caretaking in their own households and communities being targeted for mass incarceration. There's this relatively early study from my mentor, Chris Wildeman, that showed almost a decade ago what the impacts were of rising Black male incarceration rates, which are widely understood as sort of the demographic hallmark of the mass incarceration period. What impact does steeply rising Black male incarceration rates have on the population health here of the entire US population? And what he found surprising, maybe at the time, was that at a population scale, Black men's imprisonment rate had an even more detrimental effect on Black women's well-being than it did on men's. That is, the lost years of life came off of women's lives. So we know that women take on massive direct costs on behalf of their incarcerated children, partners, co-parents, the expensive telephone calling cards and the prison visits, the care packages at expensive rates, putting money on the prison books, the legal fees and the monitoring fees and the fines and the restitution fees and all of that. SC Justice Group has found that a very large proportion of women supporting incarcerated loved ones go into 5- and 6-figure debt because of these direct support expenses. But one of the things that also becomes clear is that women in communities targeted for mass incarceration effectively serve as unpaid counselors and unpaid caseworkers on behalf of their family members and the state. They absorb the physical, psychological, and financial impacts of so much of the system's violence. They compensate with their own unpaid labor for the lack of a functioning public safety net for those who have been caught up in jail and prison and then dumped back out into the community with nothing. And my estimates suggest that the direct economic value of this work is likely greater than $299 billion. This labor and the severe social and economic strains that accompany it in turn place women at higher risk for cardiovascular disease, depression, and all kinds of other stress-related physical and behavioral health conditions. Not all of these costs can be calculated with the information we have, but I estimate that the lost productivity costs and medical expenses associated with women's excess incidence of stroke, heart attack, and major depression directly attributable to incarceration of their partners, co-parents, and other family members totals almost $2 trillion. Of that, roughly $434 billion is associated with the excess burden of racially targeted incarceration in Black communities. Putting a number on it. So this kind of evidence that I'm talking about, for the most part, it's been built by demographers, by public health researchers, by sociologists, criminologists even. It doesn't focus on economic harms. It certainly was not collected with the intention of informing reparations. But what I've done in these last couple of examples is to sort of walk you through the ways that this evidence base can be tapped for questions of reparations. In other words, for the harms I just noted and for the whole gamut of harms of mass incarceration in Black communities across the life course, across levels of the social ecology, we can put those harms in dollars and cents terms with some real rigor. And this in turn makes it possible, I think, to begin to move definitively past one of the most common objections to reparations for chattel slavery. And Dr. Alberti brought this up this morning, this idea that it's long over, it's long past, we weren't responsible for it, and how could we possibly put a number on it anyway? The thing is, when it comes to mass incarceration, it's still going on. It's not in the past at all. It's going on in 2024. We know exactly how it's been done and by whom at all levels of government. And we also know, thanks to the government's extensive record keeping systems, who has been targeted and effectively. So the thing is, when it comes to this, and I think many other areas of racial harm, we can put a number on it. I go into a lot more detail in my book exactly how I went about developing these kinds of estimates. And there's a reason it takes a whole book to detail that. So I won't regale you with the full details during this precious time that we have together. But the short or short-ish version is that to create a scientifically rigorous estimate, I had to focus only on areas where we have three forms of evidence. One, an indication that something was measurably altered by mass incarceration based on studies with a rigorous experimental or quasi-experimental design. Two, evidence for the scope and scale of that alteration. And three, a consensus economic value. But for those harms for which all three forms of evidence are available, I am able to use them together to get an estimate of the harm that's attributable to racially targeted mass incarceration carried out by the US federal government, by our state governments, by our county governments. And because mass incarceration era policies have been in place for more than 4 decades, for most of the harms I investigated, it was necessary to estimate them for each affected year or affected birth cohort. And sometimes that was a matter of simple multiplication. Much more often, the year or the cohort-specific estimate needed to be scaled based on the conditions in place in that particular year or cohort. And then those individual estimates were summed. As a side note, because I think we're all working in this very charged and very complicated political space, I want to be clear that the estimates I'm going to share with you now don't include the everyday, the legally sanctioned harms of our criminal legal system. For example, the suffering that a person convicted of a crime experiences while they're serving out a judge-imposed prison sentence. If there are folks in the room who may believe you do the crime, you do the time, that's a much bigger question, and it's one I'm deliberately not stepping into here. My estimates here focus only on the extra legal harms and burdens that this system creates, above and beyond the legally imposed penalties for conviction. And when we bother to do the math in this sort of slow and painstaking way, the results paint a vastly bigger picture of mass incarceration's impact than I think even if its sharpest critics have previously suggested. So what I've done is to walk out a similar calculation as I did in those examples for each layer of the social ecology that's been affected by mass incarceration. I won't go into equal detail on each of these calculations, but I think the results are just as staggering. The criminalization of Black children and youth and their pipelining out of educational and supportive institutions has cost $4.31 trillion. The perpetual punishment of formerly incarcerated Black adults, especially their ongoing exclusion from the formal economy after incarceration, has cost $1.07 trillion. The burdens and harms shunted onto partners and mothers of incarcerated Black adults, as I already noted, total $4.34 billion. The lifelong repercussions for Black children of the incarcerated, particularly in lost educational opportunity, total $452 billion. And the community and population scale damages, including impacts on Black infant mortality and adult life expectancy, total $890 billion. These estimates are by definition not complete for all the reasons I've already noted in terms of the state of the evidence base as it stands in 2020. And so it's all the more staggering that when you look at the total economic value of just the subset of the harms I can estimate, we find that in less than 50 years, this one system alone of racially targeted mass incarceration has sapped at least $7.16 trillion from Black individuals, families, and communities. Mass incarceration as a system is much, much more expensive than even its sharpest critics have suggested, and an incredible proportion of those crushing costs are borne not by the state, but by Black families and communities. Why reparations? Mass incarceration has caused immense harm, and in confronting it, we must expand our capacity for repair. We must do something different in this time than we have done in other times of reckoning with racial injustice. We have much to learn here from the field of global transitional justice, the study of public policies around the world that actively reckon with mass harm and mass atrocity. The transitional justice record in places like Chile, Argentina, Yugoslavia, South Africa, and Rwanda highlights 3 critical tools for collective recovery from mass racial atrocity. The first, create a shared understanding of the racial harm of mass incarceration. Second, undo and remake the public institutions that have been bent to racial criminalization. And 3, make material reparations on a scale concomitant with the damage. This third piece, the imperative of material reparations, is so widely recognized that, as Dr. Ford noted earlier, it is enshrined in international law and human rights treaties. And why might that be? The United States presents a powerful case example of what it means to not make materially right our past wrongs. I won't repeat the trajectories that Dr. Venkataramani went over this morning of the racial wealth gap since the time of emancipation, but suffice it to say, the more things change, the more in the US they have seemed to stay the same. We are dogmatically invested in this idea of progress, especially where it comes to racial justice. And there is, of course, no disputing the fact that huge gains have been fought for and won by generations of brilliant Black activists and strategists, including some of you here and their comrades and accomplices. But the economic facts remain grim. The relative share of wealth held by Black Americans has changed very little in the last 125 years. I want to repeat this point because it is so important. Across an incredible stretch of US history, from the post-Reconstruction era and the world wars to the civil rights movement and the era of Black Lives Matter, the Black-white wealth gap hasn't changed much. Political reform without material repair, which is the approach we've taken to racial justice throughout most of American history, creates a dual reality. On the surface, rights and opportunities are expanding. And underneath, there is this massively powerful momentum, not just maintaining the status quo, but increasing the value of assets and of debts. And thus, when left to its own devices, actually widening the divide between white and Black Americans. In fact, the relatively flat Black-white wealth gap we've had over the last 125 years represents enormous amounts of work and success on the part of Black communities, Black strategists, and policymakers to close the gap, but it's all the time being silently countered by our economic default setting in the absence of material reparations. So every policy move we make, every policy move we have ever made in the direction of equity and justice has been quietly and steadily countered by that underground momentum. And just as a high level, I'm going to back off of my causal research for a moment just to give sort of a snapshot. What was happening to the relative value of Black and white household wealth during the peak years of the mass incarceration era? U.S. Federal Reserve data show that the wealth of the typical Black household, the effective value of that wealth dropped 75%, while that of the typical white household rose 14% during those years. What does this tell us about what we must do now? I want to be clear, mass incarceration in the US was built through action at all levels of government, and unmaking it will require action at all levels of government. But only the federal government is in a position to accomplish material reparations at the scale these estimates suggest is appropriate for mass incarceration alone. Using data from the US Census and Federal Reserve suggests that the total value of the contemporary wealth difference between Black and white family households, which are the ones most impacted by the kinds of effects I've detailed in my earlier slides. The total value as of 2020 of that wealth difference between Black and white family households was about $8.37 trillion. This tells us that if only the known and estimable damages of just this one form of government wrongdoing in Black communities were redressed, it would close roughly 86% of the wealth gap that still divides Black family households from their white family household counterparts. And I want to return by way of closing to one of the greatest works of American fiction ever that takes place in Ohio to ground us back where you are, and the passion for this work is originating in today's conversation. That's Toni Morrison's Beloved, which takes place in a small town in Ohio before the time of emancipation. How do we grapple with atrocities that have entrenched themselves so deeply in our collective consciousness and the machinery of our government that they are now, as Morrison suggests in that work, as normal and as encompassing as the weather? How do we reclaim a future from the ever-replicating histories of racial harm that define the only country any of us has ever known? History is written by the victors, wrote post-colonial theorist Hazel Carby, but diligent and continual silencing is required to maintain its claims on the present and future. Now, as we have before, the US has an opportunity to acknowledge and recover from the ongoing misuse of our public systems and infrastructures for racially repressive ends. Effecting this transformation will be no trivial undertaking. Neither was the era of mass incarceration that brought us here, nor any of the earlier campaigns of racial atrocity that laid the groundwork for that one. But the evidence suggests that investing in a true reconstruction from these damages and so many others could be more transformative and more fruitful than we have previously recognized. We have the tools, the scientific tools, to understand not just the fact, but the momentum and scale of death and destruction to which life in a racist country has accustomed us. In ledgering the immensity of those losses, I think we can also begin to see more clearly what futures are possible from here and how to move toward them. Thank you so much.
Thank you so much, Dr. McKay. Powerful and profound presentation, especially with the data and statistics and the commentary that you offer. regard to the crucial linkages between mass incarceration and the need to push for restitution reparations and the impact that it has on families. Could you speak more? First question, I'm sure others will have questions or comments. The linkage you said between the incarceration, for instance, of Black males and its health effects on Black women and families. That would include mothers, aunties, and every other relative. And just could you talk more about that and how that also may connect with issues of longevity and
Yes.
and
Yes, that
yeah, if you could just address that. That's good.
Yeah, that question is so over the plate, I think, um, in terms of what being with these numbers and being with some of these public health data actually tell us as people. So I think one of the things that that this reveals is not just the ways that we are so deeply interconnected as human beings, the ways that harm to one of us, the harm to one person in the family hurts the whole family. The harm to one family in the community hurts the whole community. I mean, I think those numbers do tell us something very important about our interdependence. They also tell us something about the ways that Black women's unpaid and I'll say even coerced or forced labor has been extracted by the system we have. The work that Black women have been forced to do as partners, as mothers, is just unconscionable in a system of mass incarceration. And I think that even among folks who are sharply critical of anti-Black mass incarceration as a system, folks who are willing to talk about the impacts of forced labor within the prison system, the mass exploitation of prison labor. What we're seeing when we look at actual formal prison labor is the tip of a massive iceberg of labor that's not even paid at the, $2.12 an hour that our prisons are unconscionably paying people. Labor that is wholly unpaid and extracted primarily from women, essentially on a ransom threat. We have your child. If you ever want to speak to him again, you will. And then there's a whole list of enormous demands on time and money. Or we're holding the father of your child. If you want your child to have a father, here are the things you will do. That's what our system is effectively doing to tens of millions of women in this country. But that picture isn't all grim. I mean, I think I want to be very blunt about the ways that I see the state extracting that labor unethically, exploitatively. It is unpaid. It deserves to be compensated and redressed. But I also think the numbers tell us something a little bit quieter too about what it means to have these two different forms of momentum or impact countering each other all the time. It tells us that if the proportion of the Black-white wealth gap that could be directly attributed to mass incarceration in Black communities is as high as it is, that tells us that were it not for mass incarceration, Black communities might have almost closed this wealth gap. And when you think about that, in lieu of the data we saw first thing this morning on the momentum of post-Reconstruction racial wealth disparities. I think it just tells us that something incredible has already happened, and that the work of the civil rights movement, the Black Lives Matter movement, and all the movements before it have actually been so much more impactful and so much more successful than we can see if we're just looking at that, sort of flat line of the wealth disparity. And I think it tells us something similar with regard to health too, because that care work that is happening, the extra emotional labor, logistical labor, the extra care that children require when they're missing their dad for 6 years straight, the extra care that a partner requires when they're seeing daylight for 1 hour out of 24 hours in the day, when they're physically confined by that. So much care has been offered up that is silently already ameliorating and remediating what would have been the impacts of mass incarceration and other systems on Black health, were it not for the profound acts of care work that are going on within Black families and communities all the time. So I think there are these two very potent stories running alongside each other under those data.
Thank you, Dr. McKay. I'd like to follow up. Oftentimes, researchers, even lawmakers get into this, nether space between, comparing and privileging, quantitative over qualitative research. I like how you're showing the significance, the value of the qualitative value of quantitative research, real people. What Genevieve talked about is she was also making a comment that we can be far-reaching and transformative. But in terms of, people even talking about the economics of stuff and how kitchen table issues, how that matters, with regard to the issue of prison abolition, what Dr. Angela Davis and others have called for in terms of the abolition of prisons, and those calls from activists and others who for generations have been working to bring attention to what you're talking about. In prefacing that, I want to highlight the issue as it relates to Brown versus Board of Education and some of the backstory to that and the notion of separate but equal. And I'm, from your presentation, believing that prisons have been a gross system of apartheid and separation of our communities and families in the ways that you're talking about and others have talked about for quite some time. Separate can never be equal, but that was ensconced into law. So, how can we look at the fact that those who were charged or told to find a way to equalize all those institutions, Black institutions, on par with white institutions, they saw that would cost far too much to do so. So instead of doing that on the front end, there was this openness to desegregate it, but then that was followed up with this resistance in this effort to push against that and to privatize stuff. So learning from that lesson, they basically saw it was fiscally unfeasible to make everything separate but equal. So with regard to prisons, if you don't want to pay, and you said that one slice, mass incarceration, not even talking about the privatization of it. If you don't want to do that, then the other alternative is prison abolition. So, which is it? Either, equalize everything and pay restitution and what to do, or abolish it completely. So I don't know, just in the fact that you put numbers behind, and there, I think a scholar at University of Connecticut has talked about, and Dr. Professor Darity as well, putting numbers to it, in terms of what it would cost. Some say the entire reparations restitution would be 14 trillion. We spend almost that much when we, pay for, bombers and fighter planes that sit in wastelands and are no longer used, or some of those weapons that are of war that are now found on streets, in inner cities that cause a lot of it, along with the pain and the other issues, cause a lot of the further stress and trauma to be accelerated, exacerbated. So if you could just touch on that, and then we'll take a quick break. And again, thank you so much for your research and your work. It's so very important, so vital and necessary. Thank you.
Oh, thank you so much for that really insightful comment. Yeah, I think we are at a crossroads, and I do hope not only as you noted that this figure of $7.16 trillion attributable only to about 4 decades of only one system helps to make that overall figure of 14 plus trillion dollars that would be needed to fully close the Black-white individual wealth gap look just so incredibly reasonable. So incredibly reasonable. And at the same time, yes, to your point, I think it's very important that we also think about these numbers as helping to show us some of the actual operating costs of the carceral system we have. You know, we've got state governments all over the country who have been complaining and wringing their hands for years about how expensive this system of mass incarceration is. Come to find out, they're only paying, you know, some small part of that actual price tag. And it's low income Black communities who are paying the huge price tag. And so, yes, I absolutely agree that I also hope that this figure puts into context conversations about the criminal legal system and about, you know, some of the reforms that are on the table. Is this a system that we can actually afford to retain and reform? Or is some more profound remaking necessary? Because certainly I don't think we can afford to cut corners on making the system any less humane than it already is. And then the last thing I would just say is, I think what unifies this is that for me, questions of what we do about violence in our communities, about you know, our criminal legal system, and what we do about reparations and racial wealth inequality are really inextricable. We could abolish the prison system today, and its harms would persist and replicate themselves well into the future without reparations. And if we did abolish the prison system today and we left these gross wealth inequalities in place, we would also continue to have so many of the stark problems of violence in our communities that at their root are problems of racialized poverty. That, you know, abolition without reparations would never have a fair shot. So I think it's important that we're talking about them together.
Thank you. Thank you, Doctor. Question asks relates to the war on poverty, failed war on drugs, and so-called war on crime. Can you speak to the manner in which the exploitation ensures in Black communities where drugs saturate these communities, extracting money, labor, separating families, enabling dual benefit to those who stand to benefit, particularly as relates to prisons, connections, privatization, to the New York Stock Exchange, which provides dividend checks for white investment portfolios based upon the presence of poor Black, brown, and white bodies in those cells, not even talk about the correlation between butts and bodies in seats in schools and those in prisons or juvenile detention centers.
Yes. I mean, my first answer to that question is yes. Sandy Darity and I actually just finished a study on this topic, the paper. Maybe I'll see if Dr. Williams, if you do circulate some other papers and materials after the conference, I might send you that one to share. It's called Who Benefits from Mass Incarceration? And essentially we studied systematically what white profit from Black mass incarceration has looked like over the last 50 years. And I think a really important takeaway from that work, and you know, as I said, the shortest response to the question is just a resounding yes. The big takeaway from that work is that we haven't even fully had our eye on the ball in terms of the way that mass incarceration has generated revenue for white individuals, white held, publicly traded corporations, for as long as white Americans continue as they do today to, overwhelmingly be the holders of stock in publicly traded corporations, overwhelmingly be the owners of American private businesses. When we have systems like mass incarceration that produce corporate profit, they produce primarily white economic benefit. And so I hope that, as your question suggests, that we can begin really broadening the conversation, maybe outward from just thinking about like the profits that are made off of prison labor. Not that that's not important, but as you suggested, like it's just it's so tiny compared to the massive edifice of resource shifting that this system is effecting. And I think one of the quietest forms of that I'll just lift up here, because I don't see it talked about enough yet, has to do with the suppression of wages for low wage workers through coerced work from Americans who are on some form of so-called community supervision by the criminal legal system. So these are folks who, as a condition of probation or parole, are legally required to be applying for and securing and maintaining overwhelmingly low wage, low security jobs on threat of literal incarceration. And we don't yet know the effect that that has on low wage labor in the US, but we know that in a time of mass incarceration, and especially, Michelle Phelps talks about a time of mass probation and parole, the effects that that's having economically, and the kind of profit generating effects, I think are not widely acknowledged yet.
Thank you. We have a question. Adrian has a question, and our executive director of alcohol has a question following Adrian. Adrian?
Yeah, I think you actually answered part of the question with the last statement you just made. And I guess, wanted to bring it back to like state violence and understanding and knowing that when we talk about crime and when we talk about capitalism, that those things are intrinsically connected to anti-Black racism. And even when we think about the capital that you kind of discussed in regards to what prisons are able to make, when we also think about how this intersects to our federal government, and we have such things like ALEC that has generally been within our politics that have kind of helped create policies that perpetuates this cycle of profit in that sense of privatization. If we think about like telephone calls, for instance, a lot of Black families are the ones that are taking the brunt of that, but the money is going to these private organizations. So when we think about like accountability and reparations, and we don't necessarily name these things or name these companies and expose the fact that they have made ample amount of profit off of these things for millions of years, what does it look like for them to be accountable to putting those profits to the Black community in which they perpetuated these violences on?
Thank you for that question, Adrian.
Yes, I think the word you've used there, accountability, is so important, because I agree with Dr. Ford and you follow Dr. Darity in this, that when we talk about the actual scale of the harms of mass incarceration or any of the other harms that we have inventoried today, it is the federal government is certainly the only entity who is able to move resources at the necessary and appropriate scale. And I never want questions of Black reparations to be trivialized based on smaller entities' limited ability to pay. And yet, I think that globally, transitional justice around the world tells us that that piece of accountability that you're naming is so important. And even if those companies can't themselves mobilize the kinds of resources at scale that would be necessary to fully redress the harms they've participated in. I so strongly agree with your point that accountability is a critical part of the process of acknowledging harm. And I think, there as a practical consideration, yes, it's only the federal government can move $7 trillion or $14 trillion. But from a moral perspective, what do we do when we know we are in possession of stolen goods? I mean, I think all of us raised in this country have been taught the same moral answer to that question. And so from that perspective, from the perspective of accountability, I agree with you absolutely that it is critical that corporations who have directly profited from this kind of mass violence and mass exploitation do play a role in making it right.
Thank you. Thank you, Dr. McGinn. Thank you, Adrian. I'd like to turn over to our Executive Director, Ivanka Hall.
Well, hopefully, I hope that you can hear me without all the noise in the background, but I'm in Cincinnati at a conference on air quality. And so I want to thank you, Dr. McKay, for talking about this Black wealth and this prison industrial complex. It's important for us to all understand the ramifications of the prison industrial complex, particularly when you talked about Black women. I also want to talk about like the loss of their retirement incomes, the loss of their homes,
Yes.
the impact on Black families. Like I remember when I first started looking at the decay of the community. So now you have moms who are hoping that their sons will one day be employed and have an opportunity for them to regain some of their financial status, and then coming home and being punished again, not being able to gain employment. The health impact that it played not only on the mom, but on the young people who lost their lives. We have a generation of African American men who will never retire from anything, who are at retirement, almost at retirement age, but they have never paid into any retirements because they have literally been locked up their entire working lives and locked up and locked out of economic opportunity. So I want to thank you for bringing to light that piece around the prison industrial complex and the continual impact on the African American community.
Yeah, and your point there is so well taken. I mean, I think when I think about the way that I went about developing my estimates, sort of thinking about the impacts radiating outward from the individual into the family, into the next generation, into the community, out to the nation, and then over the life course. I think that piece that you are bringing out about the way that mass incarceration has destroyed Black elderhood is so potent. And we don't yet have, in the space that I work in, I think adequate research focusing on that to be able to, make those kinds of precise estimates. But yes, I mean, it is so potent, I think, when we think about not just the destruction of Black childhood, but the destruction of Black elderhood that you're talking about, and the ways that those two are really inextricable from one another in terms of intergenerational harm. And also, yeah, I think too that I guess I just want to say again what these data also tell us that's a little more hopeful and just as jaw-dropping about what Black communities and Black families and Black women in particular have managed to survive and to stabilize and to make possible is also nothing short of incredible. And I think that that's the other thing that these numbers tell us that's a little bit quieter and equally important. And I would love to see in our lifetimes reparations made at a scale that secures an actual retirement from working life for all Black elders.
Thank you, Dr. McKay. Genevieve? Genevieve had a question. Why is the issue of Black restorative justice so difficult to grasp in light of the fact that of the other precedents, Japanese Americans, Holocaust survivors, World War II survivors, American Indians, and we should also put, along with that, the case for, Palestinian women and children and others around the world who have, either been affected by or received some form of restitution or egregious wrongs done to them?
Boy, that's a potent question. I mean, I think the why in part is that when we look at the extent to which white economic power in this country has been built on systems of exploitation, specifically of Black Americans, when we look at the size of the resources that are being shifted from place to place by the systems we have, I think we're just dealing with such a huge glacier. And I think we all maybe sense that, those of us who support reparations passionately and those who oppose it passionately, I think we all sense the hugeness of it because of what our country was built on. And I think that that is somewhat different, at least in the case, for example, of internment, where you're talking about giving $20,000 per family to a tiny number of elder survivors for something that happened, this discrete state action over this discrete number of years. And this is so much bigger. Yeah.
Well, Dr. McKay, just want to thank you for an incredible presentation in your work. So glad you're able to present with us and look forward to working with you, moving forward and collaborating along with every other speaker who's presented. I want to thank all those who, thoughtfully and prayerfully and passionately offered questions, thoughts, presence, and attendance. Thank you so much. Certainly appreciate your being with us today and your work, and wish you well. And look forward to continuing to work and struggle and fight with you on these issues.
Thank you so much. Right back at you, Dr. Williams, and to each of you. It's such an honor to be here and be in this really urgent conversation with you all. Thank you.
We can take a 10-minute break as we, transition to get our next speaker in place to be able to present, give you some time to take a breath and to reflect and to think. And we will continue, and a few more presentations left. Thank you for your attendance, for your patience, for your thoughtful, questions and comments and just presence today. I do want to make an announcement on behalf of those who are coming to get CLE credit. Some of the questions have been placed in the chat, but we're asking for the CMBA and CLE registrants to email Jaleese Thomas before 11 a.m. with their poll answers to ensure that that you're able to get your credit. And the questions Most recent question is, what is defined as mass incarceration, rising Black male in prison rates? Let me find the other part of it. Question, I think, and how it relates to the health effects upon Black women. Those questions are in the chat. There's a question about the what is the racial wealth gap between Black versus white individuals, and their 3 different responses, answers given. And you just please give attention to that. That would be greatly appreciated.
Okay, I'll be back in 10 minutes.
All right. Thank you so much. We'll reconvene in about 10 minutes, and then we'll continue with the rest of our conference. Thank you all.
Thank you. Dr. Williams, take a break for a second. It's our next speaker here.
I've communicated. I think Dr. Plow said he will be in. We've been corresponding via email message. You'll see us soon. I provided my phone number, so I'm looking in the chat to see if I can see. So hoping they able to get here soon. So
Okay, so go take your own break for a second, and then we'll see you in a couple more minutes. Just don't log off.
Oh no, I won't.
We'll see you in a couple more minutes.
All right.
The same with the rest of my team.
Thank you, team. Appreciate it. And I also want to make mention. I want to recognize Jacqueline too. I mention her help and support. So I'll make sure to do
when
that
you come
as
back.
we get back together.
Okay.
Hello?
Yeah, that'll be fine. That'll be fine, Dr. Williams.
All right.
Dr. Williams, you ready to start?
This is not tap water. This is coming out of that machine. Thank you. Thank you. Oh, it's nice and cold too. Thank you so much. This is all I need. I had a meltdown. I couldn't deal with it.
All right, everyone, we're going to get started again. As you're rejoining, we certainly welcome you to continue to offer your questions in the Q&A section and to raise your hand following presenters' presentation. We look forward to the conversation, through the presentation, to the conversation, and our dialogue and exchange following it. Now I want to introduce to you Dr. Alonzo Plow, who joined the Robert Wood Johnson Foundation as Chief Science Officer and Vice President, Research, Evaluation, Learning in January 2014. He's responsible for aligning all the foundation's work with the best evidence from research and practice on improving health equity and incorporating program evaluations into organizational learning. He also oversees the 2 grant-making portfolios focused on innovation and emerging issues, Pioneer and Global Ideas for U.S. Solutions. Dr. Plow has been a national leader in public health practice for over 25 years. And today, Dr. Plow's presentation will focus on the work of Robert Wood Johnson Foundation and the concept, the topic of reparations as prescription for health disparities in America. And Dr. Plow, we want to thank you for agreeing to present with us and the work that you've been doing, and look forward to hearing your presentation and talking with you about your work and about the topic of this conference. Thank you so much. The floor is yours.
Thank you, Dr. Williams. Can you hear me and see me?
Yes, we can.
Okay, great. Thank you. You never know in Zoom world. Happy to be with you. Good afternoon, or whatever time zone anybody's in. Again, thanks for the invitation to present at this really important conference on reparations. I'm going to really frame my remarks around, just as you said, sort of the public health case for understanding reparations, but I'll talk about it in 3 different parts, kind of the reckoning with the historical and real-time implications of structural racism, how reparation fits into that, and how reparation, particularly when we look at the health implications of structural racism, together become part of the repair process.
Dr. I was waiting for Dr. Plow to come back. We know that there may be some weather-related issues in different parts of the country, so we'll wait and look forward to Dr. Plow rejoining us. In the meantime, if you have, again, questions, be sure to put those in the Q&A chat, and also we recognize you at the end of the presentation. So we'll just kind of wait for a minute or two and wait for Dr. Plow to rejoin us, and then we'll continue. I want to thank, while we're waiting for Dr. Plow to rejoin us, may have been some weather-related issues, as it were, with some of our speakers, but we look forward to them rejoining us again soon. I'll take this opportunity again, thank our Executive Director, Ivanka Hall, for helping us put this conference together, giving us the space and resources and the encouragement support, the vision to put this together. Assistant Director Dr. Lachelle Pugh, Samario Ford, and Michelle Hall work with community relations, and all of you who have been great partners and been attentive and asked great questions and given us a lot of energy and a lot of support as we seek to present these issues and to grapple together, connecting scholars and activists, thought leaders from different sectors and walks of life to try to bring to bear on these vitally important and necessary issues in our time. So we do have a video, just a short 3 minute or so video of a Sudanese performer who our executive director met at a conference, who has a song that is related to the issue of reparations, and it's calls for reparations, entitled "The Time for Reparations," and wasn't able to be with us. Ahmad Sinkane wanted to be with us. I was on tour. Native, actually lives in, I think, Columbus, but also is Sudanese, and has been gracious in talking with us about the importance of musicians and their role in helping to bring attention to this vital issue of reparations. So while we're waiting for Dr. Plow to rejoin us, we'll see if we can show some of that, so that you can see some of Sinkane's comments about this issue of reparations from an artistic standpoint. So let me see if I can bring that up for us to see. Share. Yes. Hopefully everyone can see it.
Can't hear it.
Let's see. Step for a second, try it again.
Dr. Williams, can you explain around the CEs, CLEs, and CMEs for the attendees? And then maybe we can get the video to Dr. Pugh and she can show it.
Yeah, we're offering a number of continuing education credits, CLEs, CMEs, and CEs through different organizations. I know Jaleese Thomas has been working with the CEs and CMEs. Well, actually the CLEs and other related credits for law professionals. And we have through Ohio Social Work Association CE credits. We'll provide the number for that you can access. Make sure if you're attending throughout the entire conference, if you can, make sure that we have your information, your email address, so we can, and your affiliation, so that we can put your name on the certificate. I know for the Cs, once the conference has been completed, and I know there's further information that Jaleese and partners with Case Western Reserve, Metro Health can give you as to completing that. Some of that, which includes the survey questions that have been posed and raised in the chat, and that we also kind of highlighted as well. We'll make sure everybody has all that information, and so that you can, for attending the entire conference, you can be able to access and get those credits. So we'll see if we can get this video going, and we'll get Dr. Plow back with us so that we can hear his presentation, our last presentation following Dr. Plow's presentation. No, there's a question raised about nursing, and we'll, I know President Alma Allen with the Louisiana Center for Health Equity will make sure to get information to you about the nursing credits as well. We'll see, how we can make sure that we address that. But that's a great question.
Can't hear you.
There's no sound.
There's some now.
I was playing this music last night, finishing up this flyer for the I need to print it.
Give us a minute. We're trying to make sure we can get the video on for you.
Everyone, we'll just continue to take a 10-minute break as we get Dr. Plow back in. Also, we get things situated with our video. Thank you for your patience and your presence.
Dr. Pugh, can you open up that video?
For whatever reason, I can open it up, but the box you can click to share sound won't allow me to click on that. So I think that's what's, at least on my computer, what's going on.
And Dr.
I
Pugh,
tried yesterday and I was not able to.
Yeah, because I couldn't get it open at all.
Yeah, I was able to open it, but the sound, I don't know what's up with it. I can hear it on my computer, but for whatever reason, it won't allow for the
for everybody else to hear.
It may be also the issue too with this type of setup, because I know we were talking about doing polling, and I know Jaleesa asked some questions about settings and getting polling through our interface, and for whatever reason, Lachelle and I didn't see that on our list of options, so.
You weren't able to do polling?
No, she was able to do it, through the chat. I guess this particular the way this interface board is set up, it doesn't allow for that. I know I've seen other Zoom interfaces that have allowed for that. So it may just be this. She made reference to different types of Zoom room arrangements.
I can look. I didn't know. If I had known, I would have went back there and looked. So yes, just give me a minute and I'll go back there and figure out what I can do.
Yeah, I'm still trying to communicate with Dr. Plow to see what's going on with him. Maybe they have weather-related issues, but I know Dr. Chatterjee comes in too.
Okay, and then that way when we come back, we can you can kind of fill in the gaps around the discussion that we just had, and then allow and then go on to the next speaker.
All right.
But everything else is great. This is really good. It's computers. We can expect. This is Zoom. We can expect craziness. This weather is crazy all over the country. So.
Yeah.
All right. And so look for your other. So Dr. Pugh, let's look for the other speaker too and see. And you need polling. Let me see if I can reach.
Hello, Dr. Plow.
Did I fall off? I didn't really notice.
Yeah. I don't really know if it was weather-related issues or what. So we took a brief break, but whenever you're ready, we can continue.
Where did I stop?
I think really the beginning, you kind of it froze, and so I think you kind of just kind of beginning we lost you. So
Should I start up again? Should I start up again? All right. I was really,
yeah, if you can,
yeah,
let me.
I had my notes on the page and I didn't really see that I was not on. I apologize to everybody.
Oh, no problem. Let me start recording again, and then we can get started.
Okay.
All right. All right, everyone, we have Dr. Plow back with us, and we want to turn the floor over to Dr. Plow to continue its presentation. Thank you, Dr. Plow.
Okay. How much time do I have?
At least maybe 20, 30,
His full
20,
time.
25 minutes. Yeah, whatever
Yeah,
time
his
you
full
need is
time.
fine. Yeah.
Okay, fine,
Good.
fine. Okay, great. All right. I tell you, the Zoom world. There was my lights were flashing here, so that must have been what happened. I got cut off. Okay, so reckoning. Thanks for inviting me. Good afternoon. Let's hope it works this time. I'm gonna frame what I'm talking about in around reckoning. Reparation and repair. And it's we have a long past time to reckon with. It's a long past time to reckon with this part of the nation's history. The white supremacy that endures through structural racism, and that's a major focus of RWJS philanthropic work. That it's central to our approach to improving health equity. And, from my personal lived experience as the son of two HBCU grads, civil rights activists in the 60s, school teachers in our Black community, I was personally steeped in the imperative of achieving health equity and confronting injustice during that time, that still Jim Crow time. But we had to recognize how present day inequities in all their forms, rooted in that deeply flawed past, and build a collective will and community power to do the hard work of advancing racial justice in the face of significant opposition. What I want to draw on today are some things that are in my recent book, Necessary Conversations, which published by Oxford University Press. You can get that for free. It's an e-version from Oxford University Press or from the foundation. In that one, I'm going to share some things from some meaningful and urgent conversations we had about race and structural racism as the steps toward that racism, that reckoning. We had dozens of leading thinkers and doers, activists, policymakers, researchers, but over 50 people on trying to understand racism as a barrier to health and well-being, and how to create a better future. And I'm going to offer some of the insights from that because I think it's very important. The sequence to understanding the imperative of working on reparations is based in understanding and reckoning with the reality and the persistence of structural racism. So there's my favorite definition of structural racism is from Nicole Hannah-Jones, who was one of the contributors to this meeting and book, where she says there's a structure and an architecture that created inequality, and those exist whether individuals operate with racial animus or not. It's that unconscious impact of this of built-in structural racism that makes it more nefarious. And and those of you who've seen her work and read her work and the 1619 Project, she really lifts up a really important historical framework that I think, and in that history opens the door to action, and broadens the sense of rage that we should share collectively in this country, that should drive us to having conversations about race that are not just historically blaming, though we have to understand what the historical conditions, but also are thinking about what the future, how we can create a better future. I think from the work that we're doing and I've done over the years in these areas, you need to share authentic stories about racism. It's really important for people to understand and hear these stories, so that people can understand, particularly white people can understand their own privileges, and for us to feel like we're being heard and respected. One of our colleagues at the Mississippi Urban League has been talking about having these kind of dialogues around structural racism so there can be more shared understanding to set the stage for action on reparation. My colleague Gail Christopher, who does a lot of work on this one, says to move forward, the nation must heal the wounds of our past and learn to work together with civility. And Gail says even with love. But, the harms of structural racism, particularly the health impacts, must remain prominent in the reckoning process. The health harms of racial injustice are reflected in so many things I think most of you already know about. Maternal mortality, differential incarceration, the fact that climate change is an amplifier of health inequity, and so many more things. We point to, and we fund a lot of journalism because things like the New York Times cover story, Why America's Black Mothers and Babies Are a Life or Death Crisis by Linda Villarosa. I mean, the tragedy of Black maternal and infant mortality, Black infant mortality rates 4 times the white rates. This is what makes structural racism become real in the public mind, and understand this interplay between unconscious but pervasive racial bias that gets baked into our medical system, which still contains clinical algorithms and practices that perpetuate health inequity. And we could spend the entire time talking about other structural factors that impact health in the African American community, disproportionate incarceration. Why is it in Mississippi that Blacks are hardest hit? 75% of those serving in prison sentences of 20 or more years are Black men, and they're in the worst penal conditions in the country. Turning to why RWJF, as a public health research funder and programmatic funder, is interested in this. Well, we're the largest funder of public health research outside of government, but the stakes are so high for us in a nation around health equity that our research and our programmatic activities just have to become an instrument of change and service toward equity and support repair and reparations movements. And we've been about this for 52 years, and we are committed to making significant changes in our work so we are effective and good partners in centering our work on dismantling structural racism and the social practices, laws, and policies that really just value more lives than others. And then when we talk about health, it's more than just the absence of disease. We're talking about how we can have communities thriving and not just narrow the gaps in disease prevalence, but particularly broader cross-generational well-being, and reparations are really a key strategy to improve well-being and wealth for our Black community. So reparations, I see as the action component of racial reckoning and understanding structural racism. I want to share a few things from conversations I've had recently with my colleagues. Mary Bassett, MD, Dr. Mary Bassett, former health commissioner of New York State, New York City, Black woman physician focused on health equity for her entire career. And she says to achieve health equity, what really needs fixing is access to resource. And she wrote a very important article in the New England Journal of Medicine talking about that and really trying to bring more clarity to our fields that closing the racial wealth gap, and reparations can help close the gap in racial health outcomes and life expectancy, which from a public health standpoint is the ultimate goal. So we are funding her to work, and others to be working on better understanding of this intersection of race, wealth, and health. It's been well studied, but it really hasn't been implemented as the public health case for making this approach. I think that's newer and needs to be incorporated in our reparations work. It needs to be a bolder part of what we believe we need to do in the healthcare side to save lives. Reparations is not just a political project, but it's something that those of us who are public health leaders need to think about as part of our activities and humanitarian efforts to save lives. Now, reparations, as all of you and who are working on these are so critical to redressing longstanding harms, but we operate in a extremely divided United States at many different levels now. So there's a lot of differences of opinions around what you do, though 77% of folks in our African American community support reparations, but the data show that only 7% of us believe this is possible. So there's sort of a hope gap there. And then only 18 to 20% of white Americans support financial reparations for descendants of Black slaves. And part of this is just rooted in this lack of enough understanding around the historical and current reasons for why reparations are needed. And we think that the health inequities that are a consequence of generations of structural racism are important of that. So closing the resource gap is necessary to closing the health and life expectancy gap. Another researcher that we funded, and I hope you can go on our website and look at some of this work, Dr. William Sandy Darity at Duke, who has done a lot of studies at proposing the elimination of the wealth gap should be the goal of reparations. And he argues it strongly that it should be monetarily and delivered at the household and individual level. Sandy is an economist, and he urges us in philanthropy that we really need to put financial reparations at the center. So we made a major grant to Professor Darity at Duke to support his group. And he believes he has strong positions about financial reparations. He thinks that techniques like canceling student debt or getting rid of environmental hazards in neighborhoods, all that can make a difference, but he doesn't believe those should be a substitute for reparations. And he has tagged in his studies a number that he feels for a national level Black reparations at 14 trillion, and believes because we, as a government, can put out money at that level, like for the COVID relief payments. It's not that that's impossible, but it's going to take a lot of work to get monetary payments, and the understanding that is a need at a governmental level in this, again, very divided political environment. But again, I think the elimination of the wealth gap is very important. And we need to close that resource gap if we're going to close the health and life expectancy gap, which is why health has to become more present in the reparations conversation. Now, wealth is critical to health, and intergenerational wealth in the African American community is not very prominent. I think in my own family, it's taken 5 generations until there is even modest to my children modest transgenerational health that will happen. So what do we do? How do we create a different future? Returning to some of the things that Dr. Bassett Mary has been finding in her research, it's making the case for understanding what would happen if we eliminated the racial wealth gap. And her research estimates this at about $850,000 per household. And she's asking the research question, if we close that gap, how would it improve health? And she's looking at very complex data sets, which I'm not going to go, I'd love to go into with you as an epidemiologist, the panel study on income dynamics and the health and retirement studies. Just look at her articles when they come out, where she can measure the potential impact on wealth intervention on Black life expectancy. And her colleagues have found, and I want you to think about this number, if the mortality rates of Black Americans were equal to white Americans over the course of the 20th century, her work estimates there would be 8.8 million more Black Americans alive today, 8.8 million more people alive today. So what can we do to ensure we're not saying that same thing or worse 50 to 100 years from now? And again, her research, mine, others, I've all shown there's no biological reason why Black Americans should have shorter, sicker lives than white Americans. And culture or individual choices, none of that accounts for this disparity. The reason for these disparities are longstanding structural problems in governmental and other policies, housing to healthcare, employment, criminal justice, which is why it's important to have this broader and deeper root cause focus on wealth inequality. Mary Bassett suggests that we don't dismiss the fact that health and public health care has played a role in perpetuating racism. So we have to clean up our own house, those of us who are in those fields. We all, as health professionals, need to be working and participating in these state, local, and national conversations on reparations. I'll turn to how we're doing that at RWJF in a second. And third, we really need to bring to prominence these health outcomes as a major measure of equity, and that eliminating the racial wealth gap is not it's a goal, but it's really a goal to eliminate these horrendous racial gaps in across our life course in health and longevity. As long as Black Americans live shorter, sicker lives, equity is just an aspiration and not a reality. So let me turn as I kind of conclude on participation in local action on reparations. I'll end with some comments on RWJF's support and active engagement in the New Jersey Reparations Council, where a number of my colleagues, including our CEO Rich Besser, serve as a member of that council, and we strongly, the foundation strongly believes that we want a world where health is no longer a privilege but a right. That involves local action in our home state in New Jersey. So we have made major investments in our participants in that New Jersey Reparations Council. That's part of our over $5 or $8 million investment overall in reparations work on the research, and also $2 million to this Reparations Council. We feel this is an important shift for a health foundation, for us to be focusing and working on this community-led Reparations Council. We think it's a very important step in advancing our work. Our CEO, Rich Besser, says we have just got to close the wealth gap that stems directly from the atrocities of slavery and centuries of racist policies and practices. And this is absolutely essential for a foundation to be working on and supporting, because we're not going to have an equitable future, as Rich says, without deep and comprehensive knowledge to address this history and understand its long-term impact on people's health. And there are other parts of philanthropy that are also doing this. We are not alone, but it's good to see that there is more focus in our sector, in the health sector, on reparations, but there's still a lot of work to do. We've also funded some evaluations of some of the legislation that's actually in place for reparations, such as in Amherst, Massachusetts, and Evanston. And these important but relatively modest scale efforts, they're important lessons in how those particular cities developed their reparations approach. So we support the New Jersey Reparation Council to conduct research on the state's history of racism, and we're supporting the development of a sustainable structure for a state level commission. But again, we don't have time to go into all the intricacies of this, but as you can imagine, the politics around how you develop the state level commission, the need for a private one, how that works together, the convincing of the legislators to do that in a way that has appropriate community voice. All of that is important, it's important that our foundation is not just financially being a supporter of that, but we're at the table. And it's hard often for lawmakers in a Northeast state to realize the role New Jersey played, the big role New Jersey played in slavery. Sometimes it's harder for the Northeast states to figure that out. So again, I guess to kind of conclude, I'm going to conclude with one of my colleagues who is serving on the Reparations Commission, Maisha Simmons, who's our Assistant Vice President of Equity and Culture. I think she states our position pretty clearly. Maisha says it's a moral and practical imperative to confront the atrocities of slavery, colonization, and decades of structural racism in the United States. The pathway to that is through reparative policies and practices. So just in summary, and I guess it's because I'm an epidemiologist, we need data and experienced, informed knowledge, of shared knowledge on the history and current impact of structural racism on Black health to really drive the reparations argument for reparation. That involves clarifying the relationship between inequitable health impacts on the Black community over time and the role of wealth, not just income, in health and well-being, and then supporting movement building at the local, state, and national level on a variety of approaches. We still don't know which ones are best, income-based, others, but that I think right now a variety of approaches are needed around reparations. And just maybe finally, I think all of us know this, reparations are a stepping stone along the way. What we really want is a true, just, and sustainable multi-racial democracy where we're all committed to building a different future. That concludes my my weather-related truncated presentation.
Well, thank you, Dr. Plow. Certainly appreciate you being with us and offering your thoughts and perspectives and sharing work that Robert Wood Johnson Foundation has been doing and is doing now on this crucial subject of reparations, and particularly it pertains to health and health equity. It's good you mentioned about Dr. Bassett's work, and it kind of connects with our next speaker, who we're still hoping will be able to join us, about making a case for medical reparations. How do you see the issue of health equity being a conduit or an avenue, arena with which to pursue, particularly maybe at the local level or state level or even federal level, restitution, and as you say, as a prescription? If you could speak a little bit more about that, that would be helpful. And how can foundations and philanthropic agencies and groups do more to assist communities in this critical work?
Yeah, it's very important. I mean, I think that providing, as I was saying in the first part of this presentation, sort of showing there's not enough shared understanding of the health and well-being impacts of structural racism over the decades and centuries. And I think that showing that reparation is a corrective and reparative thinking is a corrective to ongoing issues. It's that, that may have started from 1619 forward, but still are manifested today. On the health side, we can provide data, information. The foundation provides, we do a lot of things that show small area maps in cities that show life expectancy can vary by 50, 20% or 30% differences between Black and white neighborhoods and small geographies. So there's lots of things that we can fund and support with the information and data to show the need for corrections to policies and practices that have perpetuated those harms. I think we can also, as we're doing at the foundation, support local and state commissions on reparations and be parts of those. And I think a number of foundations are doing that. So I think it's really putting the structural racism and reparations together with the large amount of information we have on understanding health inequality and the pathways to more inequality through addressing things like housing, safer neighborhoods, climate change and health. Those are ways that the health side of the equation, the public health prescription, can help to advance possibilities for a better understanding and action on reparations.
Great. Dr. Plow, my Executive Director of Alcohol has a question she'd like to raise to you.
Hi, Dr. Plow. I am sorry that I am not on the screen. I am actually in Cincinnati doing some work around getting some purple air sensors in Cleveland, particularly in Cuyahoga County. Right now, we are probably one of the lowest number of purple air sensors in our communities at, I think, 8. But I have some questions about this whole thing, looking at structural racism's role in Black wealth, but then also looking at the role that foundations can play around helping to push policy and helping to make sure that CBOs, such as the Northeast Ohio Black Health Coalition and other organizations that are doing the work that we do, are funded. Because when you look at cumulative impact, when you look at the things that are going on with the air, land, and water, we know that foundations can't do that work, that heavy lift by themselves, that they need the CBOs in order to do the work. And I think that we have so often within the foundation world looked at the treetop and not so much at the grassroots organizations. So the EPA has now changed their funding formula, and they have gotten it right. They have changed their funding formula to make sure that they can push dollars out to CBOs in order for them to get the greatest benefit to the community. So how do you think that foundations can do the same thing in order for us to push for things through a reparations lens? Because starting at the grass tops, are a way for us to make a new way of thinking and a new way of pushing policy change in our communities. So that's my thought.
Yeah, that's very important, and because of time, and I didn't expand on the line I said of that doing this work has required us to make major changes in the way that we do our work, and I'd love to follow up with you because we do a lot of work on environmental justice and climate justice, and I'm interested in what challenges you're facing in Ohio on that one. And yeah, the Justice 40 money, and we're working with a lot of folks around some of the federal funding that's now direct to community, and Bob Bullard's doing in the South. We're doing a lot of work in that area. The better way to shorten a whole other talk I give on how we're trying to walk the talk on trust-based philanthropy would be that we are moving, and if you look at our website, this is work done. This is community generated work. This is a part of our community power bridging and building work. This is not work that's thought up in Princeton in conventional programmatic prescriptive work. This is work that it has to be funded through general operating support in many cases to CBOs who are doing that work. With us as good partners, but with us as collaborators, but not necessarily the lead in those things, which I think is what you're saying. So we are trying to move away from a kind of traditional philanthropy that was so top down, and I think in the work, certainly in the work that we're doing around, since we've been focused particularly on structural racism over the last 4 or 5 years, from our more general focus on health equity for the last 10 or 15 years, these strong community power, community partnerships, a large shift to Dr. Bullard is my long-standing colleague. He is we've been working together for a long time. I'm responding to the chat. I'll finish with you, Ms. Hall first, but yeah, we have been learning from and working with community partners, and have shifted over time, the 10.5 years I've been here, to grassroots funding. Called it trust-based philanthropy, call it whatever phraseology of the moment. That's an important approach, and becoming a much more prevalent approach in what we're doing. I think it's a threshold. When major grants that are coming through for my review have just got to show the community leadership and community co-creation of the work that we're funding. Is that a down payment on an answer?
Thank you for answering that. Yeah, I thank you for answering that because, and I just want you to know, to be transparent, I am a Robert Wood Johnson Fellow. And so I have been a fellow for some 20 years, probably more than that now, with our work. But I'm also part of, so Dr. Bullard is part of the WEJAC, and I'm part of the NEJAC. So I'm part of the National Environmental Justice Advisory Council. So we get a chance, the Northeast Ohio Black Health Coalition has been doing some transformative work all the way around, looking at education, employment, housing, and health, and looking at that cumulative impact, what goes on in our air, land, and water, and how it impacts the things that we see here on the ground. And so those things are important in order for us to actually make any type of inroads in improving people's health status.
Yeah, why don't you follow up with me, aplow@rwjf.org. I'd like to connect you to, we just got through the board this year a couple of large authorizations to do community-driven climate justice work, and we're one of Dr. Bullard's funders at Texas Southern and Beverly Wright Center at the Deep South Center. So I'd like to make sure that we're connected with you and your network as we are connected with them.
We appreciate that because I'm also a Texas Southern alum.
Yeah, and to Dr. Williams, yeah. As I tell Dr. Bullard, I knew him before he got super famous.
Well, as it relates to reparations, one of my mentors, Dr. Tangalizi Sanyika, I worked with him on the issue of reparations for quite a while. He and Dr. Bullard are close colleagues, so it's good to see the connections and the synergy. So appreciate you being with us today.
Yes.
Are there other questions or comments we have? I think we have a few other questions. Let's see. Genevieve still with us? I think Genevieve asked, let's see, as it relates to, issue of land, definitely I think there's a recent work that was written on the subject of called Uprooted about land, reparatory efforts, economic compensatory restitution. I think she asked just the question of, again, how we can make this, happen and make it possible. And she speaks to, the need to and the importance of this vital subject. So thank you for that comment, Genevieve. I don't know if there are other questions, but if you have other questions or comments for Dr. Plow, please contact Dr. Plow. And we certainly appreciate your presence and your participation, your expertise, Dr. Plow, and look forward to working with you.
Thank you. And you contact me at aplough, P-L-O-U-G-H at rwgf.org, our website, rwgf.org. And again, I'm happy to be with you all today.
Thank you so much. And now.
Zachary, I think you're muted.
Dr. Vic, thanks. Dr. Vic Chatterjee, who, MD, MPH, a primary care and addiction medicine physician in Boston Healthcare for the Homeless Program in Boston Medical Center, and assistant professor at Boston University School of Medicine and instructor at Harvard Medical School. Takes care of adult and pediatric patients in shelter-based clinics across Boston. His research interests include innovative treatment models for opioid use disorder among people experiencing homelessness and how racism has shaped addiction treatment. And Dr. Chatterjee's presentation title today will be the case for medical reparations. And Dr. Chatterjee is one of the first, people that I contact interface with regarding this conference, and was gracious to agree to present, and certainly grateful to you for starting us off, and for today helping to end our very exciting and interesting and engaging conversation on the issue of the state of reparation in the African communities relates to health equity and health reparation. So without further ado, Dr. Chatterjee, I want to turn over to you. And again, thank you for participating and for your work and research and for presenting. The floor is yours.
Thank you. And thank you so much for the invitation. Let me share my slides here. Okay, excellent. Let me know if there's any trouble hearing me or seeing the slides. But I'm going to be talking about the case for health reparations. Yes, and I'm going to tell you a little bit about myself. So I grew up in Raleigh, North Carolina. Well, I should take another step back from that. Well, I grew up in Raleigh, North Carolina. My parents are immigrants, and in fact, my dad is a refugee from the Civil War in Bangladesh. And I think coming to this country for them was a huge opportunity. And what they, the great things they've experienced in this country in terms of their lives, the lives they built for us and their careers, for them, at least, when they were first coming here and as we were growing up, sort of were crystallized in the mantra, if you work hard in this country, good things will come. And I went to public school in Raleigh, North Carolina. I was really lucky to go to really high quality public schools. And I, to the point of my parents, got into a good college. I got into Harvard and went up there. And it was so interesting for me because coming from a public school, coming from this immigrant background, it was so interesting to see that what the currency of power was at Harvard wasn't hard work and education. It was really money. And I would see my classmates who'd grown up in, on Fifth Avenue, New York, and had gone to these fancy private schools. And that really was generating the networks of power and, allowing people to be successful. At the same time, I volunteered in the public schools in Boston, which were such a far cry from what I experienced in Raleigh, and a far cry from what my classmates were experiencing at Exeter, had experienced at Exeter and Andover and all those, sort of fancier prep schools. And it sort of shook, right, for me that mindset that I had growing up, that in this country, everything, all opportunities are sort of equal. And as long as you work hard, you'll get what you deserve. And I think that moment of crystallization, being in the public schools there in Boston, I was actually a high school teacher for a few years after college, and then ended up going to medical school. But that realization of the injustices baked into the system of opportunities started this journey for me as far as looking at health equity. When I finished my medical training, I actually did a research fellowship, and we were allowed to do a little bit of time at Healthcare for the Homeless in Boston for clinical work, and I fell in love with it. So I actually moved away from the research realm to do clinical work full-time at Healthcare for the Homeless. And the issue of inequities baked into the system, something we see every single day there, and has sort of informed this talk and the work that I do in terms of researching inequities in medical care in general, but specifically in the addiction world. But I'm going to talk a little bit about this argument that a group of us have made in the form of a paper, and talk about this idea of health-specific reparations. So we're going to describe how physicians and scientists have historically promoted biological conceptions of race, and thus promoted the associated ideas of racial hierarchy and systemic racism. We're going to be able to delineate and justify the ethical arguments supporting healthcare-specific reparations. And then we're going to generate ideas in which healthcare reparations might manifest, or a process by which affected communities could shape how healthcare reparations would look. So what has been the role of doctors and scientists in systemic racism? So these first two slides are challenging because they're so deeply offensive, but also I think important to look at because they do implicate medicine and science in propping up slavery, Jim Crow, and then the health inequities we see today. So these pictures come from Doctors Josiah Nott and Louis Agassiz, who were at Harvard, and so very esteemed physicians and scientists, but they developed this idea based on all of this sort of now pseudoscience, but at the time, right, very, very supported idea that because physiologically in appearance, different racial groups appeared so different, that they must be actually different species, and that humanity must have developed, unlike what Darwin and others were arguing, which is that basically there's a single origin for human, and we were all the same species. That there's this polygenism idea that they promoted, that these people were so different, we were so different from each other, that we must have come from different, basically, gene pools and groups, and not, come from the same genetic path. And that was important because it was an idea that was used by people in political power, including people like Thomas Jefferson, to say that these racial groups are so separate that we need to have separate laws and understanding of things like when slavery is acceptable and not. And in some cases, some groups might be more amenable to slavery because they're genetically so different. And again, these ideas are being propped up by Harvard scientists and physicians. Some of you may have already talked about this. I did miss the earlier presentations, but some physicians went even further in the South and defined whole sets of illnesses that were specific to, in this case in particular, enslaved people, Black people, again, in this order to medicalize and justify slavery. So drapetomania is this term that many of you may have learned about, but a doctor, Dr. Samuel Cartwright, very well respected. He was someone who was in conversation with Thomas Jefferson, right, around some of his ideas as well. The idea that wanting to be free was a psychiatric illness, and that he gave it a name, drapetomania. But if you look here in this paragraph from this paper, the idea of dysesthesia aethiopica, which is saying that, basically there's a medical reason biologically that, this racial group is different. And all these are generated again by physicians. I would argue that, in a way that justified, right, discrimination, obviously slavery, but later discrimination in things like employment and housing, in a way that's completely independent and belongs to health and healthcare. And so when we talk about reparative policies, and I'll talk more about this later in the talk, we can talk about the ways in which, there's reparative policies in housing or other areas, but healthcare starts to, and physicians and scientists start to have to take on some responsibility for some of these ideas as well. Obviously, now we know that race is not biology. There are tons of papers, but clearly, as we started looking at DNA, there was much more overlap among all human groups, and there was differences between groups, and between group variance is minimal compared to within group difference. So we know race is not biology. Another hint we have that race is not biology, even in the US, is this chart is really, really fascinating. I think says a lot to me because it's the ways in which the census has counted race. So nowadays it's changing. It's changed even in the past couple of years, but there's this sort of, and I've even gotten reviewer comments from this on papers, but you have to present race a certain way. Race has to be black, white, and these different categories. And if you don't do that, I had a paper where we had allowed people to define their own race, which we thought was interesting in this case because it was a study about Latina attitudes towards addiction treatment. But we let folks identify their own race because in our experience, folks have a very hard time when you basically have them choose whether they're black or white in the Latina community in particular. And we got feedback back saying that, no, you have to use census classifications. But what's interesting for me, as far as feedback like that I get from other scientists, right, is that the census has been completely changeable about what it considers a race and how it classifies race. So the idea that these things in any given time are like scientifically true, these are the races, is completely arbitrary, right? Even independent of the genetic data that we have. I would also argue that doctors continue basically to do harm by equating race and biology, that these things, just because Dr. Cartwright is dead, Drs. Agassiz and Knott are dead, doesn't mean their ideas and the impact they've had on the system are dead. So we'll talk a little bit about race and kidney function equations and race and pulmonary function testing, and then race and medical education. So I'm not going to belabor this. Many of you have heard or read about this, but basically, for a long, long time, there has been a race correction in kidney function testing. And this is something we just sort of absorbed in medical school. And, I think 99.99% of doctors didn't think much about it. But interestingly enough, there's a group of medical students who wanted to get at where did this come from? How can it be so numerical, right? That there's like a 1.32347 correction factor for calculating kidney function based on blood levels of creatinine. How is it so specific? Where did it come from? And it turns out that it comes from extremely shoddy and minimal science. So basically, nephrologists back decades ago, when these kidney function equations were being developed, hypothesized based on their ideas of racial difference that Black people had more muscle mass. And they cited literally two studies. One was several dozen, like a few dozen Black children in Louisiana. Another was maybe a slightly bigger study in another part of the country, but two small studies citing those studies saying that, those groups had more muscle mass or had a lot of muscle mass. Therefore, for every Black person in America for forever now, we're going to calculate creatinine based on that. It turns out, if you look at it, that was completely inaccurate and has affected so many people. But this is a picture of sort of from an article that talks about the relevance of this. Basically, they went through and did their math in their study group, and I'm pointing to this 6% block here, but basically 6% if they readjusted their model without the race correction. 6% of Black patients were reclassified to a higher risk category. What that means and what that's meant in terms of the way these equations have affected patients is that there's a substantial number of Black people who were calculated as having better kidney function than they actually did. Meaning that if they had been white, they would have been offered dialysis, they would have been put on a kidney transplant list, they would have been moved up the kidney transplant list, but the correction factor moves them into a safer category, assuming because they have higher muscle mass. Again, completely true and completely independent from the individual, right, that's being measured. So there have been modeling studies about how many people, like this one, right? This is a modeling study saying how many people have been harmed. The definitive study isn't done, but we know that many Black people, right, because of this mathematical equation that's baked in, that has this race correction, has classified many Black patients at lower risk of kidney disease than they actually are, and potentially prevented them from getting dialysis or a transplant because of it. Okay, the second example that we have is, again, old ideas that become baked in that cause ongoing harm in healthcare. Is, again, Samuel Cartwright coming up again. But he developed this spirometer to measure lung function. And basically he said that in the setting of slavery, so malnutrition, terrible living conditions, he was seeing lower lung function in the enslaved individuals he was testing. And he hypothesized that this was a genetic and biologic difference, right? That African Americans had lower lung function, not because they were malnourished, not because they were made to live in worse conditions, not because they were enslaved and having to do physical labor in a way that he and his family were not, but that because of genes, these people, the Black enslaved people he was testing had lower lung function. He communicated that to people like Thomas Jefferson, for example. And what I think is important that's really great in this article by Lundy Braun is that not everyone at the time was on board with this. And this article points out that while Cartwright's work was foundational to the history of pulmonology, that is, those corrections that he put into the lung function test are still there, both conceptually and empirically. It was contested by James McCune Smith, the first African-American physician and an abolitionist who in the mid-19th century used narratives to refute the notion that differences in lungs were innate. He said the difference was due to other factors, for example, climate, and that given everything else were to be equal, right, working conditions, climate, all this stuff, that the African-American race was actually equal in physical symmetry and development. I think that's hugely important because we'll talk a little bit about this later, but there's opposition, right, to efforts around reparative policy. And there's a little bit of a sense of deference, like, oh, they did this because at the time they didn't know better and we can't really like get upset about what they did. But the fact that there were contemporary voices, right, saying, you're not right, you're doing this study wrong, you're doing the science wrong, and it's not true that the differences are innate, so much so that they'll be baked into equations into 2024, right? That was wrong and people were being told at the time. So I think we have to take with a grain of salt this idea that, well, we just defer to the fact that at the time things were different. In fact, at the time, people were arguing against Samuel Cartwright, but that didn't stop his ideas from moving forward. Okay. So this talks about this group. Basically, they went back and looked and said, well, what if we didn't have the race correction? And they said, after interpreting 14,080 pulmonary function tests, both with and without race correction, they found that removal of the race correction led to results indicating the presence of more serious pulmonary disease. The removal of race correction led to an increase in the percentage of patients with any pulmonary defect from 59.5% to 81.7%. This means that we may be missing a larger number of patients who may be undertreated or not treated at all. So this is right. It's exactly in line with the kidney equation changes, right? That it's not that these problems and the inappropriate racialization of these calculations is benign or sometimes is helpful, sometimes isn't. In both cases, it's harmful. Because if you say that Black people are biologically have lower lung function, when in reality that's not the case, you're going to take a bunch of results and say, those are normal, they're low, but they're normal because this person is Black and that's just innate. But that's not the case. What you're actually doing is not diagnosing actual disease in a group of Black patients who have low function because of disease. And you're saying they don't need our help. They don't need, let's say, for example, treatment for COPD or treatment for treatment with a lung transplant or whatever it might be. So these are clinically meaningful differences, and they've been going on for decades using very imperfect science that even at the time was argued to be incorrect. Okay, sadly, these ideas persist, and I think this is one of the most shocking studies for me. I don't have the year, that sadly, but it's like within the past 5 years, based on the fact that we know, and I should have put this slide up too, but even though every single medical organization has a consensus statement that says that race is not biology, it is a social classification, to the point of the census images that I showed you, that throughout the medical literature and also in medical education, there's a sense that, okay, race is a stand-in for genetic difference. Race is reported in many, many, many scientific studies, and it's not reported, it's often used as a stand-in, right, for genes. Okay, these are genetically different groups, and that's why we're looking at the difference. I'll talk more about that later too. The sad thing is that this is percolating into medical education. So I think what you're looking at here is the survey results from a study in Virginia, Virginia medical students. But what is happening is that there are medical students in the US South in particular, who believe that there are these physical and genetic differences between Black and white people. And in the second part of the study, they not only asked these true-false questions about whether there were these differences or not, they also asked, would that affect your decision to prescribe pain medication to this patient because you're saying that they have less sensitive nerve endings and so forth. But the ideas that inform these very incorrect notions date back to the time of Josiah Nott, Louis Agassiz, and Samuel Cartwright, but they persist till today. There's another form of this, which I myself and many of you may have seen as well, for those of you who have ever written a paper and tried to get published on the topic of racism. There's extreme reluctance from journals and editors to talk about racism. Whenever I write racism or talk about racism, depending on the editor in the journal, there almost always will be some form of pushback. At least that's what I've experienced historically. And it turns out that wasn't a one-off. So Nancy Krieger, Rhea Boyd, and others in 2021 wrote what I think is this really groundbreaking and seminal work. They looked at the online PDFs of all the articles published by these major journals over the past 20 years, and basically showed that, especially in the biggest journals, I'd argue, so like JAMA, any New England Journal of Medicine, and the Lancet, racism was mentioned vanishingly rarely. In the case of New England Journal and JAMA, 0.3% of articles included the term racism. And if you look, there are even some years when the New England Journal of Medicine didn't mention racism at all, period. And the idea that the biggest journal in the country could go a full year and not mention racism at all, in light of all the disparities and inequities we see in the world, is breathtaking. And they found that, so of those 0.3%, 90% were commentaries and perspectives. That is, the vast majority of times when racism was even mentioned was someone giving an opinion, but that opinion would never make it into their scientific articles, right? Even though a lot of these articles would mention race, to my point, like in a table of, okay, Black patients had these numbers, white patients had these numbers. But the idea that racism could be an explanation for those differences was basically literally never mentioned in these journals. And I think the blame is shared by authors and editors. But I think what is interesting in this graph is that other journals were doing it differently. Like you could talk about racism in the American Journal of Public Health, but you couldn't in JAMA or New England Journal, which I think gets at the fact that there are these gatekeepers at these big journals. The other thing they showed in this article, which I think is really interesting, is that after the racial reckoning, after the murder of George Floyd, there was all of a sudden you were allowed to talk about racism now. And it goes to, I feel like it goes to the critique of the journals, right? Like, why can we all of a sudden talk about it now, but we couldn't 5 years ago, right? But I think this enforced ignorance, which is what they call it, it's not Samuel Cartwright coining the idea of drapetomania, right? Like it's mental illness to want to be free. But it is another way in which scientists and doctors make it so that we can't address racism and racial inequities. If you can't talk about it, if you can't name it in a journal for a full year or two, then it's actually a purposeful and intentional way of removing our ability to talk about and address racism. Okay, so the bottom line is that race is not biology, but physicians and scientists have uniquely contributed to propping up biological difference as a reason for policy in the form of slavery and Jim Crow. Physicians and scientists continue to misuse race as a stand-in for biology and enforce ignorance around racism. And this results in historical, but also ongoing harm to Black and other minoritized groups. Okay, so how do we achieve justice in light of these historical harms? I'm going to look at the chat quickly just to make sure I'm not going to go over time. Okay, all right. All right, I think I should be done before 3, so there should be time, hopefully, for some questions, or if people want to stay after that. So justice is the equitable distribution of benefits and burdens to individuals and social institutions and how the rights of various individuals are realized. Some people, and this is from this website, have argued that there are 3 approaches. The retributive justice is sort of what we're used to in America, basically blame and consequences. You do something wrong, you are punished. You use this drug, you get 10 years in jail. You do this crime, you get this punishment. But there are other approaches to justice. And some of you may have a lot of experience around these things, these issues. So I don't want to pretend I'm an expert in a way that many of you probably are, but restorative justice, the idea that it's not about punishing someone for something they did wrong, but our task is to identify the harms that were done by the action and work to repair those harms, both for the person who was harmed and also to do work to prevent that activity, that harmful action from happening again. And then transformative justice, which is transforming systems to repair harm and make sure the same thing doesn't happen again, more at a systemic level. And I'll talk about that and how that relates to what we're doing or what we're talking about. But we propose basically a combination of reparative justice and transformative justice approach to the issue of historical and ongoing unique harms that we name health reparations, basically. So what I want to just distinguish is that there are very, very thoughtful people, including, I think, the speaker before me, who talk about the health impact of reparations. So the health impact of financial reparations. So basically, in this article, which is a great article, Doctors Bassett and Galea, basically arguing that if you give money to people who are have been historically deprived of wealth, because of housing discrimination, the discrimination in the financial system that's made it impossible for folks to build the intergenerational wealth that is the bedrock of wealth in white families, in particular in the U.S. There are health benefits to that. There's you decrease the resource gap for people to be able to access good education, good healthcare, hospitals, health insurance. You reduce stress in a way that reduces health harm, and then you have this intergenerational impact to boost families. So there are health impacts of giving people cash based on historical enslavement, historical discrimination in housing. But that's not what we're talking about. We're saying that, okay, all those things happen and we should do those things. And also, medicine played a very specific harmful role in propping up all of the discriminatory and oppressive systems, and we need to make good on that. So the restorative approach, you want to repair harm more at the individual level. So basically, this is who has been hurt, what are their needs, who is obligated to address those needs, and who has a stake in this situation? What is the process that involve them in making things right and prevent future occurrences? So an example outside of medicine of what I would argue is like a restorative approach is, I'm sure you've talked about this, so I won't like belabor it, but the Evanston housing reparations program, which I think is so politically astute, again, which we'll talk about later, in that it is very specific. It's saying we can identify the individuals and families that were harmed in our city's housing discrimination policies. We're going to contact those families and descendants and provide them benefit in reparation, right, to restore the harm that we did back, 100 years ago. I think you all probably have had these very nuanced conversations around this. So I don't want to go into that, but I mentioned it as an example of like a restorative approach. And an example in healthcare might be, let's say a hospital goes back and identifies a list of Black patients who would have been placed on or moved up on a kidney transplant list if the race correction had been removed from the kidney function equations at that hospital. The hospital contacts those individuals and or their families, delineates the harm, says, look, because we did this, this is what happened, and we apologize. We own that we did that harm. And then you build the relationship in a way that you can have this conversation around how you address that harm. We argue in our paper, and I would argue that because people are like, well, what exactly will it look like? How many dollars is a kidney transplant worth, and all these different things. I don't think we want to pre-specify from our role as academicians, like this is the exact amount of money or this is the exact program that you should do to repair that harm. The point of restorative justice, and again, I'm not a practitioner or expert, let's say, but is to develop that answer in conversation with the harmed, the communities and individuals that were harmed. But the idea being, you name harm, you make good on that harm through a conversation, whether that means $1 payout or a community like free clinic that is built, that is developed, that serves the populations that have been harmed, or whatever it might be. That's future conversation, but that's an example of restorative justice. But there are challenges, right? So who is a responsible party? Obviously, you don't want every hospital going out of business because they have to do this. So is it the state? Is it the federal government? Is it the professional organizations that allowed for these very non-scientific things to continue to be a part of our policies? And then how do we break out of a retributive or legalistic mindset, right? So now, like, let's say the hospital steps up and does apologize for harm they've done, but then do they open themselves up for lawsuits and all the unpleasantries we have in sort of society today? Finally, there actually is a group at the Brigham and Women's Hospital which discovered that they were, in a racialized way, Black and Latinx patients with heart failure were being discriminated against in admission to their specialty cardiology service. They were less likely to be admitted to specialist cardiologists when they were sick with heart failure. And so the Brigham basically named a policy saying, now we're going to proactively identify folks as race in order to try to make sure that we're equitable when we're giving people beds on the cardiology service. And there was a literal neo-Nazi protest at Brigham and Women's Hospital in Boston, saying that this new policy that was addressing this harm, this historical harm of discriminatory admissions, was being called anti-white and being protested. And in fact, the physicians who led that effort were given death threats and all these different things. Okay, so then there's the transformative approach, which is more, I think about it at systems. So what are the social circumstances that promoted the harmful behavior, and I would say policies as well? And then what structural similarities exist between the incident and others like it? So like the lung function, the kidney function, all these different examples, what are the structural similarities, and what measures could prevent future occurrences? So, for example, after breathtaking stories about ethical violations during research on Black people, for example, Tuskegee prisoners, homeless individuals, children, and other minority rights groups came to light, the U.S. decided to implement national ethical oversight to eliminate the possibility of future ethical violations occurring. And that was the birth of institutional review boards, or IRBs, which many of you probably heard of or worked with. Basically, every single scientific study in the U.S. has to be reviewed by a board to make sure you're not violating certain ethical principles, informed consent, all these different things. And so we are arguing in the transformative justice lens, with that lens, that do we need a reparative review board that is either expanding the scope of what an IRB does, or building in a new component, a review that says, okay, if your study is going to result in, right? Well, look, taking a step back, we know that in the past, medicine has participated in really horrible things specifically to Black patients and other minority patients in different ways. But does that mean that each IRB now should have a reparative review board that that specifically looks at harms by race and ways in which this science, this medication, this procedure could harm or worsen disparities? And so we call for this reparative review board to prevent that ongoing harm. Okay. The bottom line is that medicine and science have caused substantial and unique harm to Black people, even independent of housing, financial, and other forms of discrimination. So thus, independent of reparations based on those systems, or reparations based on housing or financial discrimination, we're saying that medicine and science should specifically consider reparative policies to repair harm done and to prevent future harm. That might look like, how that will look is a work in progress, but it will require community conversation. And sadly, we do have to expect pushback and be prepared for that. But that is our argument. I wanted to thank my co-authors on the paper, Derek Soled, Edwin Lindo, and Danielle Olbetsky. Otherwise, I'm happy to take any questions now.
All right. Thank you so much, Dr. Chatterjee. First question I have, and then I know Adrian has a question. And then if there are others who have questions, please put those in the Q&A section or raise your hand and we will address them. What do you see as the viability of health and medical reparations as a focus of local reparations commissions?
Yeah, that's a great idea. I know that there is a lot on the plate of local commissions, but I would argue that it should be part of the scope. And if it's not already something under consideration, to consider inviting, because every state, every community is going to have, physicians who are interested in this work, to try to think that through for folks.
Thanks. Let's see. And let's see, Adrian. Well, Ivanka, if you could ask your question, then I'll get Adrian in.
Great.
Thank you for a wonderful presentation. Very thought-provoking. I am Ivanka Hall, Executive Director of the Northeast Ohio Black Health Coalition. So like I've been telling everybody today, I'm in Cincinnati. So if the sound sounds crazy, it's because I'm not there. This whole thing around this hospital racism, we worked on a project, this anti-racism in hospital settings. We actually asked the hospitals to kind of adopt strategy to address the racial practices in the hospitals, and not only just with the physicians or with diagnosis, but also in the cafeterias, in the bookstores, like all the things that are happening to people before they even get into the doctor's office. And we did a project, and only one hospital in the whole state of Ohio said that they would sign on to that. They claimed that they already had provisions in place to address it. But we know, because of the things that we've seen in the community, that those provisions do not exist. And so when they say we already have this, we already know, no, you don't. So that's one. The other thing is around this whole opiate settlement. I think that was one of the first things that you started talking about is, and so we now have these opiate settlement dollars that's going into all of these states. But when you look at how the money is going to be dispersed, it's going to be dispersed by the same people who have done nothing with money in the past. And so not having, like, you may have an African-American ahead, whatever is going on, but when you talk about who's actually wielding the power to decide who gets the dollars, very few African-Americans are making in that decision-making process. And when they do they actually understand the gravity of what has happened to the community? Like, what has been the long term impact of what has happened with the community around the drug crisis. The other thing is around this marijuana. You know, now marijuana is medicine. And so in our community, it has been called marijuana as incarceration. And so we have people who have been incarcerated because of small amounts of marijuana. But now we have this whole thing where we're opening up these marijuana shops and saying, oh, you're to ignore the fact that you still have members of your community that are incarcerated for marijuana crimes or cannot get jobs for marijuana crimes. And now you have people who are actually opening up dispensaries in your neighborhood. COVID. So that would be another thing that we have to make sure that we're talking about the level of that about 21% of people who, and I'm sure it was a lot deeper than of African Americans who were diagnosed with COVID, but only about 1% actually are in COVID long clinics, long COVID clinics. And so that whole thing around access and addressing implicit bias in long COVID referrals is something that's going to be very important when we're talking about reparations. The other thing with COVID was where the money went. So you talked a little bit about you know, having these different dollars for things. So we know in COVID, a lot of money flowed, but it didn't flow to communities that were disproportionately impacted. And so we had an opportunity to right the ship in COVID. COVID was our opportunity to right the ship, and we still chose to continue to do the practices that we've always done. And that is because racism is built on every single level of every single place a facet of American life. And so unless you're willing to like tear some things down and rebuild some things, it's going to be hard to get rid of some of the nuances that have existed for centuries. The IRB boards are still majority white. And so when we look at the people who serve on these IRB boards, you know, we have to understand that we can't expect people who don't look like communities that are disproportionately impacted to understand the gravity of being disproportionately impacted. And then the last part, I think, is this whole issue around lead poisoning in our children. We have lead poisoning rates in urban areas across the country that are astronomical. We know that lead poisoning leads to crime. And so we look at this lead and crime hypothesis that is not something that is imaginary. It is something that is very real. And we don't want to do anything about it. And so for us, you know, it has to be looking at reparations through all of these lenses that we looked at today. And I appreciate you providing your lens because we have so many people that don't understand the true issues that are disproportionately impacting African Americans. And we still have a lot of people walking around with this pull yourself up from your bootstrap theory that they thought up in their head. I mean, so we have to let them know it's more than pulling yourself up from your fictional bootstraps. It is actually really addressing the issues at the core and then tackling them. And then for organizations like the Northeast Ohio Black Health Coalition that has chosen to tackle those issues at the core and have taken some heat from it of not being funded, of totally being dismissed because we're willing to pull together conversations that are difficult conversations. This is a difficult conversation. It's difficult to talk about something that people don't want to talk about politically. Politically, this is like not politically correct. And so I appreciate you and I thank you so much for your time today. Thank you, Dr. Williams.
Okay, so thank you so much for your thoughtful questions and comments. I'll try to address them. As far as hospitals not wanting to work with you, in a lot of ways, you know, this makes me think of hospital desegregation back in the 60s. And basically, the federal government had to step in and say, you are not getting another penny from us via Medicare unless you desegregate. And that catalyzed desegregation. And so you're right, you know, you can give hospitals the individual choice, but at some point you have to get the right people into office that can be like, actually, you know, you're dependent on us for these dollars, whether it's state Medicaid dollars or federal Medicaid or Medicare dollars, and we need to do this thing. And so unfortunately, sometimes that's the path you have to take. As far as the opioid piece, I agree with you. And I I don't know what to say. It's so breathtaking to see like police departments, no offense if they're police folks here, but get money for enforcement when the literal point of all of the work that folks have done to bring the opioid abatement funds to communities is so that we can focus on things like keeping people alive, so harm reduction, treatment, rather than arresting folks. So that is another ongoing struggle. Actually, you should keep your eyes out for a paper that I'm really hopeful will come out soon. Again, to the point, we've been having a lot of struggles getting it out there, but we did a study looking at historical redlining and overdose rates, and we found that historically redlined neighborhoods had higher overdose rates. And this is important because of the new disparities, the black-white disparities in overdose deaths. And we're basically arguing that just like in every other way, in so many other parts, sort of health states, opioid deaths are racialized too. All the disinvestment that's resulted from historical redlining has resulted in disinvestment in addiction treatment that's resulting in higher overdose death rates in redline neighborhoods. And so anyway, that I hope becomes an argument for why the abatement funds should be used differently and not be subject to the same systems. As far as cannabis, I sometimes put this example up. I mean, as far as the real world, I'm not sure how it's working, but there are states that have put policies forward where the cannabis licenses for stores are reserved for people who were incarcerated or their families. Now, I just read an article in New York that it's not working very well, but maybe it's working better in other places. I think Minnesota tried to do something like that as well. I haven't read as much about it, but the idea is there. And if you can figure out implementation in a good way, that's the idea, right? That is a reparative policy to say, we know there's a lot of money in cannabis. Can we give the marijuana store licenses to folks who were arrested for doing what you're now saying is a legal money-making thing, instead of locking them up? So absolutely. Oh, actually, going back to the issue of hospitals saying no, I'm a big fan of structural change, like you're talking about, that the systems that exist now are just not gonna, unless you really, really, change things. So I'm a big believer in like a single payer system, because I think for-profit medicine is never going to want to do the things that we're talking about. So I do think, because one example I have, I don't know how many of you all go to work at or go to community health centers or fairly qualified health centers, but there's so many things that FQHCs do that are so good. For example, you have to have a community advisory board. You have to have board members that are people who use the health services there. You have to see everyone regardless of ability to pay. But these are federal requirements based out of this FQHC model. And those are the systems that need to be in place everywhere. It shouldn't just be a small number of health centers that have those rules. Every single health center, right, should have a board. Every single hospital should have a board that's directed not by, wealthy donors, but by people who use the services. And that would, I think, be transformative. So anyway, that's a whole nother conversation. And as far as the lead piece, I agree. I mean, it's all such a big conversation, but that's also to the point of why I think local reparations councils taking this on is important, because every community is going to have issues that they're going to be able to advocate based on that affect them. So that's key. I feel like, COVID was the other point that you brought up. Yeah, COVID was so frustrating in that way, the way that. But as someone who teaches, so I teach at Harvard Medical School and at BU School of Medicine, but it was such a crystallizing way to teach my students, because if they never believed in racism before, they could just look at the differential death rates. You could just point that to them and say, look, like, this isn't history. This isn't, this is real and ongoing and happening now. So I hope I answered some of your questions. But thank you for those points, and thank you for the opportunity to speak here. Dr. Williams, anyone else, any other questions?
Yes, Adrian has a question. Adrian?
Yes, thank you. Thank you for your topic that you discussed today too. So I work in a very large federal hospital in Ohio, and interestingly enough, I also work in research within this hospital. And knowing that we have an IRB that also, as Mrs. Hall pointed out, is not representative of the community that we actually serve here. So majority of our patients, 60% of our patients are Black and brown people. And not one of our research studies actually recruits anybody that speaks Spanish, for instance. And that's something I've only been at this institution for 2 years now. And it's something that I have brought up in regards to like the Belmont report, in regards to like the large systematic illegalities, to the fact that we are, as a system, perpetuating these inequalities because we're not seeking these people out just based on language. That it falls into a whole nother issue that this hospital also has existed in this community for 185 years. And if we just set that on the table and think about how much perpetuation of disparities in health that this one county funded hospital continues to perpetuate, even with the guise of like, we're here for minorities, we're here for the health equities, that at its intrinsic, when we're thinking about transformative justice, that part of that transformative justice is abolishment. You have existed for 185 years and you haven't actually done the work. What does that look like in the future to continue trying to change things up in the system that continues to show us that they are not actually effectively working for us? And that takes me into the next part of like the fact that IRBs exist for very nuanced reasons, but even amongst that, biases still happen amongst that, even in this institution that I work in. Because they're not looking at those disparities, they're not looking at those things. And particularly when we think about like questioning racism and questioning particularly anti-Black racism and whiteness, when providers and doctors are not doing that outside of the institutions that they work in, we cannot expect them to do that in the institution that they work in. Like if you're not at home questioning your whiteness, you're not at home in your family setting questioning those things, you're not truly going to do that effectively at the work environments that you're in. And then we get to the whole performative piece of say like survival, white saviorism in that sense, that coexists with companies and hospital settings that are trying to actively do this work. And it makes it look, I guess it makes it redundant that we do, and we get almost up the hill and then we go right back down the hill. It's like a turning point.
Thank you,
Yeah.
Adrian.
No, I totally agree. And one thing I've talked about is that interestingly, the NIH, which is going to be the single biggest funder of research for a lot of hospitals, including your own likely, they need to stop funding studies that don't enroll Spanish-speaking patients, don't enroll, patients from minoritized groups. That's what's breathtaking to me. I sat in on a call a few years ago now about this study about emergency department based addiction treatment, basically an injectable form of Suboxone that you would give people. It was to prevent overdose and start people on treatment in the emergency department, and it was going to be at like 30 hospitals all across the country from California to Massachusetts. And there was several hundred people on this call, and people were so excited, and they're going through the protocol and they're like blah blah blah, and they have to speak English and blah blah blah, this whole thing. And I was like, I'm sorry, did you just say that you're at 30 sites across the country, overdose deaths among Latine patients are among the highest in the country, and you're not enrolling Spanish speaking patients? And they're like, yeah, it's just too much work and money to do that. And I was like, well, that's fine from your perspective, but why is the NIH paying for a study like that? And so my argument has been that, also to Ms. Hall's point, that these hospitals, these are not going to do the right thing. So sometimes it has to be that someone steps in and says, we're just not going to pay for this. This is not an acceptable study design. And whether it's the NIH saying we're not going to fund this study because it's so big and it doesn't, enroll Spanish-speaking patients, or if it's a federal body saying, okay, the IRBs now have to take equity issues into concern. They have to have members who are from the community, and they have to deal with issues like enrollment of non-English speaking patients and so forth. So I don't know what the answer is, but I agree with you that we're going to need some big changes and leadership who's not afraid to call for big changes.
Thank you, Dr. Chad. Genevieve has a question. Can you comment on the fact that in Cleveland, had it not been for Black mutual aid efforts, aid efforts during COVID-19, such as
People such as Ivanka Hall, Black churches, Black organizations, Black nonprofits, that thousands more in the Black community would have died. She says these neighborhood institutions were our Red Cross, United Way, on the front line, health, restitution, feeding Black families, doing senior well checks and getting supplies to us that enable us to survive. They were not getting the money, but they, in fact, were doing the work. I think you spoke to some of that, but do you have another point to add?
Yeah, I'm not as familiar with the Cleveland context in specific, but I know that this has been the case all over the country. We're having a similar situation now where the number of homeless families in Massachusetts has increased substantially, and the state has basically said, we don't have any more money. We're not going to fund any more family shelters. So we have kids sleeping on the street, and I work at Healthcare for the Homeless, so we're actually seeing these children as young as 1 year of age sleeping on the street because the state has actually closed some of the shelters that they had built. And so churches are taking over the work, community organizations are taking over the work. Now there's a lot of tension because the state is trying to say, well, you're a community organization, you're not allowed to have a tent on your lawn and you're not allowed to do this. But when they're the ones keeping people alive and safe and out of the elements, including children, and it's just like a frustrating lack of leadership or vision. It's very sad. And I don't know how we do it better without, to everyone's point, like transformative change in the way that we run things.
All right. Thank you so much, Dr. Shaji. I believe those are the questions and comments. So I want to thank you so much for your work, your presentation, for your collaboration.
Thank you.
It's been, been great to work with you and look forward to working with you, moving forward. So I want to thank everyone and your questions and comments. And now we just want to begin to conclude and give you a sort of summation of some of what we've heard today. And if there are any final thoughts or announcements, and we'd like to offer opportunity for you to share those, and then I'll turn it over to our Executive Director for her comments, and then we'll conclude. I just want to kind of recap. First, we heard from Dr. Philip Alberti, Senior Director of Health Equity Research and Policy, Founding Director of the Association of American Medical Colleges Center for Health Justice, who presented on the topic of racial justice and health equity, public perspectives on reparations in America, defined and drew connections between health equity, health justice, trustworthiness, community engagement, and reparations. Explored the research brief that they published in April of 2024, published by the Center for Health Justice. The justice would focus on U.S. adults' endorsement of select policies that would have a racial and reparative justice impact, and how framing of such policies, as well as local and state contexts, may improve public support. Again, I want to thank Dr. Alberti. And then next we had Dr. Athindar Venkantaramani, Director of the Opportunity for Health Lab, Associate Professor, Department of Medical Ethics and Health Policy, University of Pennsylvania, and also the Senior Fellow for the Leonard Davis Institute of Health Economics at UPenn. Presented on the title of Wealth, Public Policy, and Racial Disparities in Longevity. Dr. Venkantaramani shared with us the sources of the racial wealth gap in the United States, empirical evidence on the extent to which those gaps may explain racial disparities in longevity, and potential impacts of a variety of policy options, including reparations, which also intersects with the issue of baby bonds, minimum inheritance, and the impact of those on those gaps. Thank Dr. Venkantaramani on presenting, Venkantaramani presenting, and for being with us today. Next, we have Dr. Leslie Ford, Associate Director, Office of Race and Equity Research at Urban Institute, whose topic was how reparations can support Black health and well-being, who shared with us how across several key outcomes, including health, wealth, education, and life expectancy, what appear to be ostensibly race-neutral social policies, they have failed, in her estimation, to close persistent racial gaps for Black Americans. And the goal of her presentation to provide an overview of the policy history, including this research agenda, reparations research agenda, and talked about reparations policy history and present-day application of reparations for Black Americans in the United States. Our presentation examined the historical harms that Black Americans experience and the structural factors that contribute to harm today. And she described how those harms contribute to health inequities in the U.S. and the potential for reparations to help improve health outcomes and well-being for Black Americans. And we thank Dr. Ford and hope that she gets well. Thank her for innovative research and the work that she's doing at Urban Institute. Next, we had Dr. Taseli McKay, Assistant Professor of Social Medicine, University of North Carolina, UNC Chapel Hill, and core faculty in the UNC Center for Health Equity Research, whose topic was based on her book, Mass Incarceration and African American Health, The Case for Reparations. And she talked about the steep public expenses of mass incarceration, over $7 trillion, are far overshadowed by its hidden costs. She shared with us almost 50 years of racially targeted policing and punishment have taken an immense toll on the health and well-being of Black children, adults, families, and communities. And she offered an inventory of the most rigorous available research on the impact of mass incarceration on Black health and well-being, considering its unexpected and devastating impacts on Black women in particular, even those who are at home, and those would include mothers, aunts, other mothers, and cousins and other sisters and other relatives, daughters as well. And she used available health and social science research evidence to precisely quantify the total value of the damage to Black communities and make the case for reparations. Next, we had Dr. Alonzo Plow, Chief Science Officer and Vice President, Robert Wood Johnson Foundation, who talked about reparations as a prescription for health disparities in America, and talked about the multiple impacts of structural racism on Black health and well-being that are well documented, along with the work, the philanthropic work of the Robert Wood Johnson Foundation. Talked about the need to advance broader recognition of the historical decisions and current policies that perpetuate structural racism and continue to influence inequitable health outcomes. Talked about the work of the Robert Wood Johnson Foundation that has supported research and evaluation into one of the mechanisms to build awareness and some correction for past injustices known as reparations. Review key approaches and partnerships around reparations in the broader context of confronting the impact of continuing structural issues on health inequity. Next, and finally, we had Dr. Avik Chatterjee of Boston University and also Harvard Medical School, who talked about the case for medical reparations, which we just heard, the long history, including racial taxonomy and even notions of racial scientific racism that are grounded in current medical practices that reparations restitution can help undo and can help address. We thank all of our presenters and all of you for attending. We cannot do none of any of this without you. And again, I want to also highlight those who are applying for CEs, CMEs, or other continuing education credits to make sure that we correspond, that you have the information that you need. I know Jaleesa put into the chat, for those interested in CMEs, you can either self-register via the site activity code 99, well, it's star 99, or actually it's pound 99, HTTPS Metro Health, colon / Metro Health .cloud -cme.com / or email Jacqueline Delata. And thank you again, Jacqueline, for your help and assistance today. jdelata@metrohealth.org. Put your first, last name, email, and institutional affiliation, and they can file for credits on their behalf. You can file for credits on your behalf through Metro Health. And also, I want to thank our incredible and great Assistant Executive Director and Director of Research and Evaluation, Dr. Michelle Pugh, who's been incredible in helping to put this together. I know, Dr. Pugh, you wanted to offer some comments. The floor is yours.
Good afternoon. Again, thank you all for attending, but we do have some housekeeping to do. So when I look at the list, someone is logged in 3 times. Chris Miller. Are other people logged in as you? Or are you just on 3? Are you the person that told me you were on 3 devices and couldn't turn them off? Let's see. No. Okay. So yes, you're the person that was on 3 devices. Okay. Let's see who else. Marie Curry. So you're on 2 devices. And okay, I'm in here on 2 devices myself, so I get it. Okay, then I guess I've got everybody's name. Lo, is he still here? No. Okay. Okay, then that's it for me. I'm done.
Thank you, Dr. Bell. I think I have the colleague of Attorney Curry's, and I'll pass the information on to you. I think she forwarded that information the other day. So thank you so much for your help.
Thank you.
Now thank you. Turn it over to Ivanka.
Thank you. I want to thank everyone for, I hope that you all had a very informative day. I know I did. It was long, but it was worth it. You know, we very seldom get an opportunity to talk about the things that disproportionately impact our communities. And for Dr. Williams to put together such a prestigious group of professionals who came in to talk with us and outline some of the things around reparations for our community is so important. We have been talking about this, I know Dr. Williams, for some time. And so we have finally seen it come to fruition. Next year, we want to focus a little bit on environmental justice. I think that it's time for us to talk about the environmental impact on our communities, what is happening in our air, our land, and our water, and how it is impacting our communities. Again, I want to thank Dr. Lachelle Pugh, who is our Assistant Executive Director and our Research and Evaluation Director. And we have a long day. So we have an asthma program that comes up at 6 o'clock this evening. And then we have it again 3 other times tomorrow. So we've been doing a lot of work. Michelle Hall, who is our Community Engagement Coordinator. Thank you, Michelle, for attending. And for being part of the Northeast Ohio Black Health Coalition. Samario Ford, who is our Environmental Justice and Activities Coordinator. We want to thank him for his time today. We brought in all our staff. So in case you didn't know, there are 5 staff members for the Northeast Ohio Black Health Coalition. Kayla Boston, who is our Administrative Coordinator. And we also have an intern. I don't know if he's still here, but Dr. Jeremiah Simpson is our intern who started a few weeks ago, and he kind of like jumped, in small nonprofits, you jump people right into the fire. It's like teaching people how to swim the old way, like throwing them right into the water. We threw Jeremiah right into the water, and he seemed to swim really well. And so we want to thank him for his efforts. But I want to thank my friend and colleague, Dr. Zachary Williams, who is our Health Equity Director. He has done a marvelous job of making sure that we had a great conversation and dialogue today. And I hope that for those of you who are not part of the Northeast Ohio Black Health Coalition, that you'll look at it and say, I want to be part of that. If you're not a donor, that you'll look at it and say, you know what, I want to donate to an organization that we know is giving back. But for our other partners, Metro Health, Case Western Reserve University, Cleveland State University, the National Association of Social Workers, the Ohio chapter, we definitely want to thank you so much for being with us here today. And I'm going to turn it back over to Dr. Williams so we can tell everybody bye.
Thank you. And I just want to thank so much our visionary executive director of alcohol, who's an extraordinary leader and has given us space to be able to bring together thought leaders, academics, scholars, and everyday people, community advocates, families, to be able to talk about these very significant, vital issues. So what oftentimes can't be done in institutional academic spaces, we're able to do on this platform. So that's why we're asking and encouraging you to tell your colleagues, friends to become a part of our organization, also to donate to the Northeast Ohio Black Health Coalition, because you see that we do good work. And so I want to thank my colleagues, Dr. Pugh and Samario, Dr. Hall, and Dr. Simpson, and every one of you, because again, we couldn't do this without you. And so you've helped to make this a great time. And we want to thank Jaleese Thomas and Jacqueline Delata and others who've also partnered with us. And we look forward to partnering with you all in the future as well. And please stay abreast of our continuing events. We encourage you to continue to work with us. And Dr. Pugh?
Yes. Jaleese Thomas has put a survey in the chat. And so if you'd like to complete that survey, it would be appreciated.
Thank you so much.
Everybody
Thank you all
see the
so
link
much.
for that. Can the participants see the link to the survey?
Yes.
Okay.
It's on there for everyone.
All right. Thank
And
you.
I'll put it on there again. So make sure that you fill it out. That survey will actually help us to figure out if you enjoyed the speakers. What did you like today? What did you want to change? Technology, we can't change that. And so, we can't help that, we had some glitches in Zoom. I mean, we are in a virtual space, and we have a lot of kind of weather events that are going on across the country. And so, so hopefully you won't ding us on that, but hopefully you will measure this by the content of the presenters. And I think that we have a marvelous group of presenters that were here. Also, Lonnie Sloan is here today with us, and he is our certified public accountant for the Northeast Ohio Black Health Coalition. So he can let you know that we are a good judicial agent of our dollars. And so thank you, Mr. Sloan, for being here with us today. Thank you all so much, and everyone have a great evening.
I got a note from Dr. McKay, and she was just thanking everyone, so that she enjoyed presenting and being a part of the conference. So
Oh, that's great. Okay. I'm looking for the off button for honor. Now, I saw the poll on here. Oh. Make sure everybody is off. I hope that everyone has filled out the evaluation.
Yeah, Michelle, I just filled it out.
Okay.
I did mine too.
Okay. We still have some other attendees that are on here. We're not being recorded anymore, but everybody else I think is off. Nope, we still have about 12 attendees that are here. Hopefully you all will have an opportunity to fill out the evaluation before you log off. So please make sure that you do that.
See, Chris Miller is logged out once, but he's still in here twice.
Maybe she hasn't gotten to those other devices.
Yeah.
I don't want to remove anybody because then I think it won't allow them to come back into something else.
Right.
All right, so we're gonna just leave out. Dr. Williams, thank you for your time and efforts. It was really, really good.
thank you. Thank you for the opportunity to be able to do this, and for your support and help and putting it together. And Ms. Dr. Pugh and Dr. Simpson, Dr. Hall, Samara, appreciate you all's help with that. And also there was a lady here, I think her name was Dr. Alma Allen. I can't remember her last name, but she's founder and president of the Louisiana Center for Health Equity in Baton Rouge. So I asked her to attend, and so she was able to attend. So I wanted to also try to connect you and trying to see if we can, have some sort of, connection here in Baton Rouge. So.
Okay, what was her name again?
Dr. Well, they were just listed, the Louisiana Center for Health Equity. Her name is
but I saw them on there like 2 or 3 times, but I didn't have a name to put with it.
it may be her and her assistant Kwanzaa, but
Okay.
I think she, let's see, yeah, she contacted them about attending, and I'm glad to see they were able to come today.
Okay. All right. Well, thank you all so much. I will talk to you in a little bit, Dr. Pugh. And then you know how I do the introductions in the evening, so you might have to do it. Did you receive your shirt?
I got my shirt, but it's too small.
Well, it's the size you asked for.
Likewise, mine is too.
I know.
Well, you asked for that, and then yeah.
Yeah.
Well, yeah, and sometimes it just depends on where they're made. And over there, they're smaller, and so it was made smaller. I mean, I can wear it with a black t-shirt or something underneath it, but I
And
can't
that's
wear
yeah,
that just by itself.
yeah, because we don't have anywhere else to go with it. So yeah, it's a female shirt. Um, all right, I will see you at 6.
All right. Take care.
All right. Thank you. Bye-bye.
Thank you.
Mhm.
We still have 15 participants.
Yeah, 14 now. Let's see.
I'm in here too.
They may be filling in the survey.
Oh my gosh.
So you all have something else later, asthma tonight?
Yes. At 6 o'clock. I'm gonna have to get a nap in before I can do that.
I know. Yeah, yeah. This, yeah.
3 of them tomorrow.
3 of them tomorrow, but back to back?
Mm-hmm.
Oh my goodness. In different places. Now you saw it virtual now.
It's all virtual now.
Oh, that's saving grace. That's
And then we
good.
probably got 6 more the next week.
Yeah, well, I hope we can get those partnerships with Robert Wood Johnson Foundation and other people so we can, get some other, help. Actually, I was going to
Yeah,
say too,
because the grants that we
yeah,
have had with them
yeah,
were through another organization.
yeah. Well,
So-
hopefully that's going to happen. I was also looking at the Margaret Casey Foundation. They do some innovative work. They have an innovative executive, their president, Carmen Rojas. I've seen some of their panels. I was trying to see if there's a way that we can, connect with them because I think, they may be, open to, the kind of work that we do.
Well,
So
we do have these 2 coming up. So we'll talk about that because those will be helpful. Put it that way.
yes. Well, I hope and pray we're able to get those and more.
Yes.
Yeah.
One is starting now.
Yeah. I hear it in your voice. Yeah.
Yeah.
Yeah. Well, try to enjoy your weekend, and get some rest and have some fun as much as you can.
Fun? I'm too tired for fun at this point.
Yeah. Yeah. Hey, how's it going? How's school?
It didn't start yet.
Oh, okay. That's good.
I don't want to.
Football.
He said he doesn't want it to.
Oh, football's starting up sooner, isn't it?
Oh, football practice. Football. They've already started practice, and they've had 2 scrimmages.
Yeah.
I missed the scrimmage yesterday.
Yeah.
You won. They won the scrimmage yesterday. That was
good. Good. Well, have a good season then.
Thank you.
Yeah.
So, is everyone still on? I mean, there are 12 people.
There's still 12 people who are still on. I'm guessing they are finishing surveys. Thank you all for participating. I'll write a note.
So we're done.
All right.
I would really like to go to the next thing. Are you guys still on here?
I just sent a note to everyone.
Okay.
So hopefully 7 now. 10, well, that's still including us, it's 7. Well, some of those people like Chris is on twice. Chris Miller, Marcella Cox, Regina Taylor,
Yeah, but
Sarah.
Chris was on here 3 times and he left one time.
Mm-hmm. Tom, Zena, Lowe. I think they're probably finishing surveys. That's probably what's
Oh,
going on.
someone sent a message. Was that you? Must be the message you sent.
Yeah, just in case if people are just waiting around.
It's in the Q&A. Let me see. Oh, someone said they're finishing the survey. Okay, that's cool. Thank you, Lo.
Yeah.
And then, I'll just type it in there. How about that? Thank you.
Yep.
And there's one in the chat. Let's see what this is.
Are you smacking my face?
Chat.
No.
That's the message from you. Okay.
Hey, why are you licking my sock? Really had to lick my sock, man.
Your sock wet now? Cool.
Don't rub up all on me. Here, look at what you have done.
Well, if you end it, everybody, I mean, it'll just end.
Yeah, that's what I'll do. I'll just complete the survey now and like to hear all the speakers again.
The shirts are really nice, but
yeah.
where they came from, they were made smaller. No, I think it's empty, isn't it? Yeah, the cookies that I had, I ate.
Wait, I want to see if Luna can catch.
She can fetch? Catch?
Throw its feet.
Oh, yeah, I don't know.
Luna, I want to see how good it's feeling. No. Sit. Sit. I'm done, right? And you did a whole spin.
That Logan is, what's Logan outside?
No, he's here. He's inside now.
Oh,
Oh, a wasp on the camera.
so what you gonna do?
Oh,
For basketball?
we already did that a few minutes ago. For like 30 minutes straight. Mm.
Oh, you weren't with me. You weren't with me when I saw his mom yesterday.
Yes, I
Were
was.
you? You were?
We went
Look,
to
I
go get
can't
ice
even.
cream.
Yeah. All right, they're still here.
Yeah. What do you think?
I think you just ended.
All right. All right, we'll do that.
Well, I mean, maybe we could ask the question, has everybody completed the survey if you're still in here?
Yeah.
And were you able to access the survey?
Let's see.
Not getting any response. So I don't know. Let me see.
Oh, you asked that question?
I just asked it
All right.
out loud. I mean, and no one has put anything in the Q&A. I'm gonna use my judgment. I mean, when I'm in meetings in Zoom calls, they end them all the time, and I think we've allowed enough time.
Yeah.
Oh, somebody says something. Let's see what they're saying.
Oh, no, that was just me just putting, just what you were saying, just to,
Oh,
if you're still in here, just in case, we'll give you one, last call. So other than that, we'll just end. Yeah, we'll do that. All right. Thanks, Michelle.
okay.
Appreciate you. Have a good weekend.
You too. Bye-bye.
All right. Bye-bye.